check, check. Hello, check. Hey, hello, check one. Hey, hello. Hello, hello, check. Hello, check one. Hey, hey, check one, two. Hello, one test. Hey, one, two, check. Hello, 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 check. ये ऑडियो आ रहा है क्या आपको? आपको आ रहा क्या? हेलो, 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 आपको आ रहा क्या ऑडियो? हेलो, check. Hey, one. हेलो, check, 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 check.
महाकाय महाकाय हरि तो तेरे सहाय अवतारी आम्ही धरतो तुमचे सहाय रे गजवदन
Check, hello, check, check, hello, check, hello, check, check test, hello.
तुम्हा संकट अमुचे विलयाला जाओ कभी तो तुम्हा संकट अमुचे जाओ कभी तो तुम्हा संकट अमुचे विलयाला जाओ जबरदन वक्रतुंड
Check, check, hello, sound check, check test, hello.
गजवदन वक्रतुंड
Hello, hello, check test, hello, hello, check test, hello,
तुंड महाकाय
check test, round two.
हरि तो तुमचेच पाय दशावतारी आम्ही धरितो तुमचेच पाय सुंदर सिंदुराची भिजली माळ मुक्ताची जय देव जय देव जय देव जय देव जय जडिता मुकुट शोभतो बरा सुरती तू बोले चरणी आगल्या देव जय देव जय देव जय देव जय देव जय देव ईश्वर तो तुम्हा संकट आमचे विलयाला जाओ.
तो तुम्हा संकट आमुचे
तो तुम्हा संकट आमचे विलयाला जाओ. गजवदन वक्रतुंड हे गजवदन वक्रतुंड महाकाय हे गजवदन वक्रतुंड महाकाय वक्रतुंड महाकाय लंबोदर पीतांबर
गजवदन हे गजवदन वक्रतुंड महाकाय
वक्रतुंड महाकाय
धरितो तुमचेच पाय दशावतारी आम्ही धरितो तुमचेच पाय
वक्रतुंड महाकाय हे गजवदन वक्रतुंड महाकाय हे गजवदन वक्रतुंड महाकाय वक्रतुंड महाकाय वक्रतुंड महाकाय सुंदर शिवराची भिजली माळ मुक्ताची जय देव जय देव जय देव जय देव. चढीचा मुकुट शोभतो बरा सुरती तू बोले चरणी लागल्या. जय देव जय देव जय देव जय देव जय देव जय देव. तो तुम्हा संकट आमचे विलयाला जाओ.
तो तुम्हा संकट आमुचे
तो तुम्हा संकट आमचे विलयाला जाओ.
गजवदन वक्रतुंड हे गजवदन वक्रतुंड महाकाय हे गजवदन महाकाय वक्रतुंड महाकाय वक्रतुंड महाकाय लंबोदर पीतांबर
गजवदन गजवदन वक्रतुंड महाकाय
वक्रतुंड महाकाय
वक्रतुंड मी धरितो तुमचेच पाय दशावतारी आम्ही धरितो तुमचेच पाय
वक्रतुंड महाकाय गजवदन वक्रतुंड महाकाय गजवदन वक्रतुंड महाकाय वक्रतुंड महाकाय वक्रतुंड महाकाय आणि सुंदर शिंदुराची जय देव जय देव जय देव चढिता मुकुट शोभतो बरा सुरती बोले चरणी आगरे देव जय देव जय देव जय देव जय देव जय देव ईश्वर तो तुम्हा संकट आमुचे विलयाला जाओ
वितो तुम्हा संकट मुझे
तवितो तुम्हा संकट आमुचे विलयाला जाओ
गजवदन वक्रतुंड वक्रतुंड महाकाय वक्रतुंड महाकाय वक्रतुंड महाकाय लंबोदर पीतांबर
Hello, check test. Hello.
गजवदन हे गजवदन वक्रतुण्ड महाकाय
वक्रतुण्ड महाकाय
धरी तो तुमचेच पाय दशावतारी आम्ही धरितो तुमचेच पाय
वक्रतुण्ड महाकाय हे गजवदन वक्रतुण्ड महाकाय हे गजवदन वक्रतुण्ड महाकाय वक्रतुण्ड महाकाय वक्रतुण्ड महाकाय सुंदर पिशुराची चढीचा मुकुट शोभतो बरा सुरती तू बोले चरणी लागले देव जय देव जय देव जय देव जय देव जय देव. ईश्वर तो तुम्हा संकट आमुचे विलयाला जाओ
तो तुम्हा संकट मुझे
तवितो तुम्हा संकट आमुचे विलयाला जाओ
गजवदन वक्रतुण्ड हे गजवदन वक्रतुण्ड महाकाय हे गजवदन वक्रतुण्ड महाकाय वक्रतुण्ड महाकाय लंबोदर पीतांबर
Check. Hello, check test. Hello, check test. Hello, check test. 1 2 mic check. Hello, check. Hello, check. Check test.
धरी तो तुमचे
Hello, check test. Hello, check. Hello, check. Hello, check. Check. Hello. Hello, check. Hello, check. Check test. Hello. Hello, check. Check test. Hello, check. Hello. Check. Hello, check. Hello. Hello, check.
Hello, hello. Good morning, everyone. I, Ekta, your host today, welcome you to the iasgcon, the 34th annual conference of the Indian Association of Surgical Gastroenterologists, hosted by the Department of Gastroenterology, Indira Gandhi Institute of Medical Sciences. This time, the theme of ISGCon, वो लिखा है मैंने पहले बोला है बट वो डिपार्टमेंट लास्ट टाइम हरनिया वाला भी तो किया था मैंने किया था मुझे याद आया वो भी आईएसजी कौन ही था ना Good morning, everyone. I, Ekta, your host today, welcome you all to ISGACon 2024. Good morning, everyone. I, Ekta, your host today, welcome you all today in this IASGCon, the 34th annual conference of the Indian Association of Surgical Gastroenterology, hosted by the Department of Surgical Gastroenterology and Liver Transplant, Indira Gandhi Institute of Medical Sciences, Patna. This time, the theme of ISGCon is controversies and debates in the surgical gastroenterology, with the which is going to be a beacon in the scientific. अच्छा इसमें सेकेंड टाइम भी नहीं नहीं एक्चुअली ये टॉपिक में भी Indian Association.
क्लोज करो। और करो ना, नीचे का कट करो ना, इधर तक लो, इधर तक। और करो। बस उसके हिसाब से आप कम ज्यादा देख लेना। हेलो चेक 1 2 3। हेलो 1 2 3। चेक कर लूँ क्या एक केबल दूसरी? रवि, दूसरा चेक कर रहा हूं मैं। ओके। हाँ। check. Hello.
I request, first of all, a very good morning to one and all present here. I request all the dignitaries and our esteemed guests to kindly take their seats in the auditorium. I request all the guests and dignitaries to kindly take their seats in the auditorium so that we can begin with our program in time. Respected guests and dignitaries, please be seated. I request you all to kindly take your seats. I request everyone to be seated. Good morning, everyone. I, Ekta, your host today, welcome you all to the iasgcon, the 34th annual conference of the Indian Association of Surgical Gastroenterology, hosted by the Department of Surgical Gastroenterology and Liver Transplant, Indira Gandhi Institute of Medical Sciences, Patna. This time, the theme of iasgcon is controversies and debates in the surgical gastroenterology, which is going to be a beacon of scientific excellence in the field of surgical gastroenterology in India. We are delighted to unite national and international faculties at one platform to contribute their knowledge and skills to enrich the field of gastroenterology in India and neighboring countries. The 3-day conference will not only unfold interesting panel discussions, orations, and debates, but will also highlight poster presentations, case based talks, video presentation, and many other exciting events. Now, may I please call upon Dr. Manish Mandal, HOD, Department of Gastroenterology and Liver Transplant, IGIMS, for his welcome speech.
Thank you, Ekta. I, on behalf of organizing committee, iasgcon Patna 2024, welcome all the faculties, delegates, and others who have come to this conference at Patna. As IASG goes, we'll start it by dot time 11. It's already there. The program goes in Hall A and Hall B today. Hall A is this hall. Hall B is just next upstairs. There are two lifts on both the sides. You can use both the lifts. So today the program is in Hall A and B. From tomorrow there will be four halls. Hall A, B, C, D. B and C are upstairs. A and D are on this floor. You have your iCard. You can scan behind and see all the program list and way to how to go and where to go. So this is the key card. It will tell once you scan with this QR code, you'll get all the details, where to go, and all the posters presentation, which will be in the next few days, will be in the ground floor in the exhibition area. Once you cross the exhibition area, there's a ground floor, and in the after crossing the exhibition, there is poster area. Just besides the poster area is our lunch and dinner area, which will be there on all days. It's mandatory to carry your iCard because it will be scanned there for plates. So on behalf of team again, I welcome you all and we'll start our first deliberation today for the day. Thank you for being us.
Thank you, sir. Now, without any further delay, let us begin with our first session. Now, I take the pleasure of inviting our respected moderators and chairpersons for today's first session on borderline resectable pancreatic cancer, definition and current understanding. I may now invite Dr. Rakesh Kumar Singh, IGIMS Patna, to kindly take his seat on the dais. Next, I would like to invite Dr. Vikram Chaudhary from TMH Mumbai to kindly take his seat on the dais. Dr. Vikram Chaudhary, I invite you on the dais. Now I invite Dr. Vikas Gupta from Abu Dhabi to kindly come up on the stage and take his seat. Now I invite Dr. Basant Narayan Singh from AIMS Patna to kindly come up on the stage and chair this session. I invite the panelists to kindly come up on the stage. Dr. Sujoy Paul, AIMS New Delhi, to kindly begin with his discussion on borderline resectable pancreatic cancer, definition and current understanding.
Dr. Sujoy needs no introduction to this audience. He is currently heading the Department of Surgical Gastro at All India Institute, New Delhi. So over to you, Dr. Sujoy.
Thank you, chairpersons, and welcome you all to this edition of iasgcon in Patna. I'm supposed to be the opening bat, but I hope I do justice to this topic. This is I'm supposed to speak about borderline resectable pancreatic cancer, a topic which has been debated for the last 3 decades. Ever since the group from MD Anderson came up with this concept, where there are potential problems during surgery, which actually led to the thinking that maybe in these patients we are not doing enough as far as R0 resection is concerned, and we are probably not giving good surgical results where these might affect the outcomes. So when you look at the background, we all know that pancreatic cancer is one of the most deadly cancers known to humans. But when you see a cohort of patients, of say, for example, 100 patients are being seen, then 15%, approximately 15% will be upfront resectable. 50% will be unfortunately metastatic disease at presentation, and the 35% of patients, which is the gray zone in between, which range between the borderline resectable and the locally advanced unresectable group of diseases, where the disease is still restricted to pancreas and its surrounding structures, but yet we are not able to achieve good results in them. So the whole story is about tackling this 35% of patients and trying to achieve resectability so that we can offer a better survival and outcome to these patients. So when we talk about the surgical resection, again, we know that adjuvant chemoradiotherapy multimodal is actually the standard of care for most patients who undergo resection of the pancreatic tumor. And the factors which influence post-resection survival include the lymph node status, the perineural infiltration, the lymphatovenous spread. Then you have other things like the disease margin status, which is important because surgery can affect that. And we also know now that neoadjuvant chemotherapy and advanced surgical techniques can enable R0 resection in a substantial number of these patients, which enable us to have a better chance than it was possible previously. So just to recapitulate, there are terms, anatomical terms, which are used to designate a particular tumor as borderline resectable, and that depends upon the relationship of the tumor with the vessel. If there is a clear plane of available between the tumor interface and the vessel, which may be the artery or the vein, then it is called normal situation, where it is resectable prima facie straight off. But when you have abutment which is up to 180 degrees of the circumference, it's called, actually the contact is 180 degrees and less than 180 degrees, it's called abutment. When the contact or the tumor is seen to engulf or totally surround the vessel, it's called a fully infiltrated tumor, which is called encasement. So that is the basis between the anatomical description, which I'll come to later. This is another way of looking at it. This is at the length and extent of longitudinal extent of infiltration of the vein. This was actually espoused by the IAP meeting in 2018, and it was in there it was shown that the length or extent of the tumor involvement, if it is restricted to group A, which means not exceeding the upper border of the this is probably the one of the easiest groups of patients where a resection and reconstruction can be done. Then, of course, gradually as you go down group A, B, C, D, with D means when you're beyond the lower margin of the third part of the duodenum and encroaching upon to the first jejunal vein, which indicates the degree of difficulty in excising these tumors. So as you go down, the difficulty keeps increasing. There are a lot of classifications based on the anatomical details, but what is important for you to realize, and what the MD Anderson group in the initial uh, publication also tried to mention, the two things which are important is that you have to not only take the anatomical details which are given to us by a good contrast enhanced dynamic CT scan, which tells us about the vascular relations of the pancreatic tumor. You have to also look at the biological things, which means that you're looking at tumor marker. The commonest tumor marker which is used is CA19-9. So if the CA19-9 levels are more than 500, then it indicates a biologically aggressive tumor. And if after treatment this falls by around 50%, it indicates a better or a likely successful outcome. And then you look at the performance status of the patient, which determines the operability. And in these patients, anything ECOG performance status beyond 3 or equal to 3 is indicative of a poor prognosis. And this is another way of categorizing this, incorporating all the anatomical, biological, and conditional aspects together to define what is a borderline resectable. So here we see that the borderline resectable actually is the shaded zone, which indicates whether the borderline resectability is only because of anatomical reasons, or is it because of biological reasons and a combination of biological and anatomical, or it is conditional, which is a combination of anatomical and conditional, or conditional alone. So all these things have to be taken into consideration to label these patients borderline resectable. So these are a few examples. This shows a patient which is upfront resectable. You can see that the vein and the tumor are quite apart, and there is a clear plane between the two. The SMA is also far away. Here is a situation which is would be classically referred to as a borderline resectable, because you see that's about 180-degree contact with the superior mesenteric vein. The artery is of course away. This is the length of involvement, where this is the first jejunal vein and it is actually stopping short of it. This is a situation which is locally advanced and unresectable. Here you can see even the vein is surrounded all around, and the artery is also engulfed in the process. And you can see a metastatic deposit in the liver, which makes it locally unresectable in this situation. These are other examples which can make a patient who's a locally advanced unresectable pancreatic carcinoma. You can see the length of involvement, separation of all the draining tributaries of the SMV. Here again, the SMV is encroached upon, and the first jejunal vein is infiltrated. This indicates unresectability in the conventional term. So when we look at this, we have to realize that the experience with the use of adjuvant chemotherapy led to the institution of the concept of neoadjuvant chemotherapy in these category of patients, with the aim of achieving a higher R0 resectability rate and improving the survival. And it was the use of this categorization and the use of downstaging using the chemotherapy, multi-drug chemotherapy regimens, which I'll come to later, has shown that it can also impact a proportion of patients with locally advanced unresectable disease which are picked up initially. So it is now known with all the experiences in the literature that about 50% of the patients with purely categorized borderline resectable pancreatic cancer would be able to undergo surgery for a potentially curative resection, whereas the proportion is between around approximately 10% to 15% in those patients who have locally advanced unresectable pancreatic cancer. So we can make an impact in these 50 to 60% of patients belonging to this category of patients where the resection is prima facie in doubt. But what is important is that when you do the neoadjuvant chemotherapy protocols and with or without radiotherapy, you have to look at the responsivity. You have to also look at the reconstructability factor, and you have to also look at the patient's overall status before advocating the surgery, because all three R's will affect the outcome and also your ability to do a curative resection. So when you look at the initial studies, the prospective data from US, which talked about a large cohort of patients who had borderline resectable disease and locally advanced disease, we found that the R0 and the partial rates were between partial regression rates were 82.5% and 6% respectively, and the 3 and 5 year overall survival was between 46 and 30%. So improved biochemical, pathological, and clinical responses were associated with neoadjuvant chemotherapy, which was actually benchmarked by this group. And they, of course, advocated that either of the FOLFIRINOX or the regimen containing gemcitabine and paclitaxel have similar outcomes. This, the Dutch randomized control trial, the PRIOPRANC trial, which was published in 2017, they benchmarked what the actual treatment now that we have used in many of these patients with borderline resectable pancreatic cancer. But they used the gemcitabine combination, and they achieved a significant overall survival benefit and median survival benefit in this category of patients. The R0 rate was higher in this preoperative chemoradiotherapy arm, that is 79% versus 13%. So that is the beginning of one of the positive randomized studies. And then the factors, it was found that the factors which affected the good results was how the ECOG status improved after the treatment, normalizing or falling of the CA19-9 levels more than 50% of baseline. Then they found that the radiological criteria to actually document downstaging are not good enough, and you have to actually use metabolic criteria, clinical criteria, as well as the surrogate markers like CA19-9 to show that there has been response. Only one thing good about radiology is that it can pick up advanced disease or progressive disease, in which case it's actually a documented failure of neoadjuvant chemotherapy. Then, of course, you have the transcriptomic and genomic stratification, which states that the classic variety of adenocarcinoma RNA shows a better pathological response to chemotherapy, and the post-resection histopathology will be used to confirm whether we have achieved R0 resection. So this is the meta-analysis which was published in 2022, which documents that overall survival, the resection rate, R0 resection rate, the N0 resection rate, and the major surgical complications have been benchmarked. All these things have shown a significant improvement if we combine all the randomized trials published to document that NSAT is beneficial in borderline resectable. This is an algorithm which has been, I think, by Mark Besselink and the Dutch group, which has looked at the flow chart of the patients who undergo neoadjuvant chemotherapy because of a borderline or a locally advanced diagnosis, and how they go through the pathway till they end up with a resection, and how chemotherapy even subsequently can help these patients recover and achieve a long-term survival. This slide is just been put to show that post NSAT radiology is not good enough for diagnosing whether the effect of the therapy is successful or not. But one must remember that neoadjuvant chemotherapy is just one part of it. You have to have well-versed technical expertise with managing these tumors in a better fashion, which may include vascular resections, resection of the mesopancreas, arterial resection, divestment, and the concept of the triangle operation, and of course, using artery first approach, which can make many of these subsequent techniques feasible. So these are the various approaches to the artery first. Usually the posterior and the uncinate approach is commonly used. And these are the algorithmic representation of the kind of dissection that you have to undergo when you feel that the arterial margin is threatened. And if complete divestment is possible, you should proceed with that. If it is not, the details of this will be discussed with by Dr. Bhandare, who will be following me. These are the examples of mesopancreas clearance, where this dark area between the SMA, posterior to the SMA, indicates the location of the mesopancreas, and this yellowish colored tissue is the one which is actually the mesopancreas, and clearance of the mesopancreas is essential for achieving R0 resection. So level 3 dissection is the cuff of autonomous nerves along the right and the posterior aspect. There will be the highest level of clearance for the mesopancreas. Examples of the triangle operation, where you can see the SMVs forming the roof, SMA and the celiac axis. But this is only for the head. For the distal pancreas in the body, you have to do the RAMS technique, which also looks at circumferential clearance posteriorly, which may include the adrenals or posterior to the adrenals and the gerotas fascia, and of course the spleen. This is how the artery issue is tackled, which may include Appleby, other things. And I'll just come to the slide, which is important to for all the residents who have gathered here. This is a large consensus program which was conducted by the Italian Surgical Society. All that we talked about may be considered having a high level of evidence, but the questions that these posed, only 3 questions had an answer which was moderate to high level of evidence with a strong recommendation. So patients are fit for surgery, borderline resection, surgical resection improves survival, epidural anesthesia should be used, and embolization of the common hepatic artery, which was advocated by the Japanese for patients in which a potential Appleby procedure may be done, is actually not recommended, and it comes with a high level of evidence. So I'll just come to the take-home slide. Basically, high-quality, multiphasic cross-sectional imaging is essential to identify patients with borderline resectable or locally advanced pancreatic ductal adenocarcinoma, and the decision-making has to be shared and has to be MDT-based in most of these patients because complex things have to be discussed. Both the modified FOLFIRINOX and the GEM-NAP paclitaxel regimens are effective as NSAT with a survival benefit, but we do not know radiotherapy has a concrete role or not, except for the fact that post radiotherapy, there is a decrease in the resectional morbidity in terms of pancreatic fistula rates. The imaging, unfortunately, is not accurate enough for assessing whether the tumor is actually downstage or not. You have to look at conditional as well as biological factors to come to the conclusion before offering the surgery. And advanced pancreatic surgical techniques are often required, maybe to the tune of 1/3 to almost half of these patients who are finally taken up for reconstruction so that we can achieve R0 resection. I thank you for the patient listening. Sorry for overstepping the time. I can't hear.
Thank you, Dr. Sujay, for your excellent talk. Before I open this topic for discussion, what is your take on that radiology?
I'm unable to.
What is your take on this, that radiological involvement is not equal to pathological involvement? And when we talk of venous resection, we see 4 types of venous resection.
You're
And
talking
how
about
they should
before.
should you think that they should be subcategorized? I mean, depending upon the degree of venous involvement, or
Yeah.
just because, yeah.
Absolutely. The degree of venous involvement, as I mentioned in that slide, it's not only the circumferential involvement, it is the length of involvement which is important, because the reconstructability issue will come when the tumor has actually gone on and engulfed the first jejunal vein and actually involved it in such a way that the tributaries are totally separate. So reconstructability and that situation is going to be less. Whereas when you have a segmental involvement of say 1 or 2 centimeters with or without the splenic vein involved, reconstructability is easier, and it is, you can actually do in them a prima facie resection straight off without using NSCT protocols.
There are any questions from the floor? If there are no,
No, this is controversial still. And if you have a resectable pancreatic cancer, there is no clear dictum as of now to go ahead with the NSCT protocol. Although the European groups would have you believe that this is the way to go, but there's no concrete proof that the results and the outcomes are in any way better in the potentially resectable patients. Thank you, sir.
thank you. Thank you,
Thank
Professor
you.
Pal. So I would like to invite Dr. Manish Bhandare, who is my colleague at Tata Memorial. He's a professor of GI and HPB surgical oncology and has a particular interest in vascular resection in pancreatic cancer, and aptly is going to deliver a talk on vascular resections in pancreatic cancer. Manish.
Thank you, chairpersons. Thank you, the organizing committee, for inviting me for this talk. Um, I'm going to talk on vascular resections in pancreatic cancer. Dr. Sujay has very nicely elaborated what is borderline resectable, what is locally advanced, and the role of neoadjuvant therapy in these cases. So whenever we talk about vascular resections, almost always they have to follow the some kind of a neoadjuvant therapy. It can be neoadjuvant chemotherapy. At times, it could be radiation also, which for which the role is still evolving and debatable. Um, I'll try to rush through a little bit. Apologies for that because I have some slides and I was unable to cut down these slides because this topic is little close to me. So I'm trying to include maximum which is possible, but I'll also brush upon each points. So although everywhere we listen that pancreatic cancer is a systemic disease, but still the reality is that surgery remains the mainstay of treatment still for pancreatic cancer. And as surgeons, we have to ensure that we offer an R0 resection in PDACs. And this R0 it could be 1 millimeter, it could be even less than 1 millimeter. And when you see that when there is R0 or R1 indirect or even R1 direct, there is a degree of difference between the outcomes that we achieve. So getting an R0 becomes the most important thing and the most important job as a surgeon that we have to offer. And to offer this kind of a better R0 resection for PDAC, what we already have is the artery first approach, as Dr. Sujay mentioned. The triangle clearance is also evolving now. Vascular resections form the integral part of getting an R0 resection because of the close proximity of these blood vessels to the pancreatic head and body tumors. And the so-called the recent or the new kid on the block is the arterial divestment techniques, which is becoming popular in the past 5 to 6 years for getting this kind of a better R0 resection. Now, this artery first approach, just to touch upon, we know that there are 6 different approaches that are available for artery first technique. This kind of an approach is also possible with minimal invasive approach. We published this last year as a technique. Those who are interested can go through this video, which is full length available online. And the most common approaches that are used is the posterior and the right medial approach, as Dr. Sujay also mentioned in his talk. But depending on the location of the tumor, there can be other artery first approaches which are defined. They can also be used. This is the standard plane that we stay into when we are doing a dissection for pancreatic cancer, that the plexus just outside the plexus of the SMA, along with triangle clearance, which is evolving, but it is not with a very high level of evidence. Now, sometimes we can also use another approach which we recently proposed, which could be proposed as a seventh approach, especially when the tumors are located posteriorly behind the SMA and portal vein, which is in the exact uncinate process, and getting through different kind of proposed artery first approaches becomes difficult to get an R0. So what can be also done is the small bowel can be completely reflected as we do an retroperitoneal lymph node dissection, and then you can get an access from behind the SMA full circumference, and you can get a complete clearance in that region also. Coming to the vascular resection, the spectrum of vascular resection is obviously the vein resection. It can be an artery resection, which is hepatic artery or SMA. There can be situations where we have to offer a combined artery and a vein resection, and the arterial divestment technique is also there. I'll try to brush through a little bit on technique of each of these procedures. So coming to the vein resection, again, I'll not go into the details of this. This has already been discussed. The degree of involvement defines that which type of a portal vein resection will be performed as per the ISGPS, whether it is type 1, 2, 3, or 4. The type 1 is usually a smaller involvement on the lateral wall of the vein, usually at the site of insertion of the draining pancreatic tributaries into the SMV. The tumor tends to creep along those vessels, and there is a focal involvement of the vein wall at that position. And usually, a small wedge of the vein can be excised. It is recommended that the closure is done in a transverse fashion in order to avoid any narrowing, but very small involvements, a vertical closure is also possible. The other common scenario where you can require a type 1 resection is in distal tumors where the splenic vein gets involved close to its insertion into the portal vein. So you may have to apply a side clamp or a clamps above and below and cut the vein flush to the vein insertion and then close that area of opening. The next is a type 2 vein resection when there is a larger degree of vein wall is going to be excised, which is not feasible for a primary closure, or a primary closure would result into a narrowing. This is slightly more complex than even I would say type 3 resection because the clamping time can be higher and you have to use some material to patch this kind of an area. In this particular case, a small peritoneal patch harvested from the parietal wall is used with the glistening side inside. And what one needs to take care that this patch is adequately sized to that defect. Otherwise, you can have ballooning or narrowing of the defect. So that care needs to be taken. And I would say the most important location where this would be used is when it is at the junction of the splenic vein or the confluence of splenic vein, because otherwise you need to sacrifice the splenic vein to do an end-to-end resection in this kind of a scenario. The type 3 resections or the end-to-end resections are by far the most common type of vein resections that are performed. Typically, 2 centimeters or 3 centimeters of vein length loss is ideal for doing an end-to-end reconstruction. When you have a longer length of vein loss, then something like a continuous parachuting technique, which is shown in the video below, I tend to use it so that there is no tension or traction on an individual suture point. And when the entire posterior line is completed, the veins tend to approximate relatively easier, and then an end-to-end reconstruction can be performed. Of course, there are reports which come up that this kind of a technique is also possible with minimal invasive approach or robotic approach or laparoscopic approach. But this, I would say that very few high volume centers would do it. Even we don't do it any often. A couple of cases maybe that are suitable that are done, but vast majority of these are going to be open resections only. Again, type 4 are even rarer because the use of synthetic graft and a longer length of involvement usually precludes any kind of resection as well, especially when we talk in terms of the ideal candidate for a surgery or a suitable candidate for surgery. And usually when we have a longer length of involvement, the surgery is also not biologically or otherwise indicated. But when it is indicated, we can use a prosthetic graft or we can use a left renal vein, which is harvested just next to the resection area, and that can be used as an interposition graft between the two ends. Something uncommon, unusual is also that we do a vein resection, but since the involvement is much lower down into the mesentery, if there are adequate collateral channels which are developed, which have to be studied well in the preoperative CT scan with reconstructed images, then we can do a vein resection without doing any kind of a reconstruction. But we need to be extremely careful to select these cases and preserve the collateral channels while we are doing the resection. Otherwise, there can be a major mishap. So this is also something which can be, which is possible, but very few selected cases. We have published a series of 6 such cases in the past 10 years. Uncommon, unusual kind of involvement can also be anticipated at times. This is a case where a posteriorly located tumor had involved or infiltrated the anterior wall of the inferior vena cava. Usually there is a clear plane with these, but this patient had a wall invasion. And then again, in these cases, to get an R0, you have to do a radical resection, not leave behind any disease. And this is again possible with vascular techniques, reconstruction techniques. Again, I have used a larger peritoneal patch to seal the defect in the anterior wall of the vena cava. And this is also a rare scenario, but I wish to share this as well, that you can expect as a part of vascular resection. Coming to the artery resection, by far the commonest arterial resections that are done for pancreatic cancer is the celiac axis resection, or at times the hepatic artery resections for pancreatic head cancer. The celiac axis, of course, is for the body, tail, or neck tumors, where the celiac axis hepatic artery is resected, and then the gastroduodenal artery is preserved, and the blood flow is reversed from the superior mesenteric artery, which supplies to the liver as well as to the stomach. But depending on the degree of involvement of the hepatic artery and the degree of extent of this tumor into the distal part or hepatic artery proper, you can have you can anticipate what kind of a resection that will be required. You may have to do a reconstruction of that hepatic artery if the gastroduodenal artery is involved, which is done in the second video that you see over there. But when there is gastroduodenal artery which is intact, you can do a clamp test on table. If the hepatic blood supply is good, confirmed on the intraoperative Doppler, then it is safe to ligate the CHA, which is just proximal to the origin of gastroduodenal artery, and then do a celiac axis resection without the need for any reconstruction. The stomach vascularity is very important, and that's why if possible, you should try and preserve the left gastric artery in these cases. But if it is involved, then sometimes a proximal resection is needed. Otherwise, best is to reconstruct the divided vessel with the stump of the celiac artery as well. Knowing this, and because these resections are more and more popular now, the celiac axis resection or involvement is also classified now. This is proposed by the Mayo Clinic in 2020, Mark Truty. Class 1 means the classical tumors only involving celiac axis. Class 2, when the GDA gets involved or the hepatic artery proper is getting involved. And class 3 tumors are those where there is a combined involvement of celiac axis as well as the superior mesenteric artery, and they are a little higher end, or the higher end of the spectrum for resection. Then, as I said, hepatic artery and hepatic artery resection is yes, of course, and SMA resection is even rarer. We also don't do it often. Very few selected cases we use it, and because the data says that there is a higher mortality rate and the benefit is still questionable. The choice of graft, I'll not go into the details again for the want of time. When you have combined resections of artery and vein, again the challenge is even different. You have to time the vascular resection differently. The vein has to be reconstructed first, and then we move to the next part of the resection of the vessel. And these are even more challenging cases to handle in the intraoperative as well as in the postoperative phase. The arterial divestment is what something we should know because the artery resection has a higher morbidity and mortality. If we can achieve an artery divestment and still get an R0 resection, what's important is to take care of the arterial divestment procedures also. This can be either a periarterial divestment or a subadventitial divestment. Usually, the periarterial one is performed, which is keeping the adventitia of the artery intact. But when you have to go subadventitial, that means that this is a subadventitial divestment when the tunica adventitia is involved, but the muscularis is still intact. So in the first case, as you see, that is the periarterial divestment, which is nothing but the LV3 dissection, which is proposed by Inau. But when you have the tunica adventitia which is involved, then you can go deep down into the adventitia and then do the divestment by removing the adventitia and get that R0 clearance. But we know that pancreatic cancer is a heterogeneous disease. We still are not perfect in terms of planning and evaluating these cases. You see that both are almost similar cases at presentation that I show here. But the first case succumbed after a curative resection in 18 months, in 12 months rather, while the second case, who also had a metastatic lymph node in the para-aortic region, is doing well. She did well for 5 years. Only in the last week that she succumbed to the disease. So this is heterogeneous, and that's why it is very important to plan and choose these cases properly. What we have seen in our own data from TMH is that the CA19-9 is very important in these cases. When we choose these cases, each incremental value, whether it is 78, 200, 500, 1000, 2000, makes an impact. And that's why it's important to select these cases. There are a number of other publications that you can see where the role of CA19-9 in deciding the surgeries is there. For the evidence, I would like to you to take a picture or something and read and go through these published literatures which are already available if you want to know the details of vascular resection. Coming to the long-term outcomes, again, I'm brushing through because of the want of time. The long-term outcomes are also encouraging now. You see that reports of 23 months, 36 months of median survival for celiac axis resection and vascular resection are possible when the cases are chosen and selected properly. At Tata Memorial, we are also in the process of publishing our series of vascular resections. This article is in progress. Dr. Vikram and Dr. Aditya had worked on this paper as well. Close to 177 vascular resections. The median survival is not so good that you see over there, which is 17 months. But this is also depending on the case selection, and there are a number of patients who are doing well, more than 28 months, 30 months as well. The other multicentric effort that we have done, Dr. Diksha Kapoor led this study, which is a multicentric Indian study where 11 Indian centers collaborated for portal vein resection data and 389 portal vein resections that we have analyzed. We tried to identify what are the factors. The mortality was 6.4%. What we have tried to see here is what predicts mortality in these kind of radical resections. And what we saw was preoperative radiation therapy, the ASA status, the BMI of the patients. These are some of the factors which can predict perioperative morbidity and mortality. And coming to the long-term survival, what we see here is about 25 months of a median survival, which is very good. And the only factor which was important for getting this survival was if the patient was able to complete the planned multimodality treatment. So if these patients can complete the therapy, so it's important that as surgeons, we do an R0 resection and do a very safe resection so that patients do recover well and go back to their adjuvant chemotherapy in order to enjoy the best possible outcome. Again, this is my favorite slide. You see this borderline resectable metastatic disease. But when you see that group in between, when there is a therapy given neoadjuvant, when the disease is stable, we are able to explore and we are able to resect. You get the survival which is similar to the resectable disease. So we have to obviously choose these cases well, but when there is a good response, we get to have a best possible outcome. I think in the want of time, I'll end here. Thank you so much for your kind attention.
Question from the floor.
if it is there first. For shortage of time, we'll take one question from the floor, otherwise we'll close the session.
I think it's fine to close because we are running late. Sorry.
Before we close, just one comment. I mean, in your arterial resection, you showed reconstruction using a celiac artery stump in Appleby procedure. But I will like to disagree because using that stump will have a risk of having a recurrent disease in the celiac artery because we are excising the celiac artery. So in our practice, what we do, we take a jump from the aorta and then we implant the hepatic artery.
So obviously it depends on an individual case. If there is R0 resection achieved and the stump is free of disease, you can use that area. But when there is any slightest of doubt of involvement, then obviously a jump graft from aorta, I agree with you. But what we have seen is very rarely that the disease is completely infiltrating the actual root. It is most often the bifurcation of hepatic splenic artery and the left gastric artery. But of course, if the disease has gone into the retroperitoneum, yes, of course, we need to not use that area and do a recon at some other place. I agree.
Thank you so much.
The residents here that arterial divestment cannot be taken lightly. In many of the instances, if it is forced on you at the time of surgery, there's little that you can do. You have to just proceed. Otherwise, you have to plan as if you might require a arterial reconstruction proper. Because if you do a subadventitial resection, you can end up with further damage, which can actually force you to do a arterial reconstruction. And second, patients who have had radiotherapy, I've seen some reports in the literature which suggest that they will be problematic in doing a sort of a adventitial clearance in these patients.
Yes, sir. I agree completely. I missed mentioning that point that whenever we are planning an arterial divestment, we have to be prepared for a vascular resection beforehand because intraoperatively you can land up in trouble. So a backup of vascular resection should always be there in mind. Thank you.
Thank you so much.
Thank you so much for such an enriching and enlightening session, sir. Now let us proceed with our next session on the topic locally advanced pancreatic cancer case-based panel discussion, for which I would like to invite our moderator, Dr. Vikram Chaudhary, Professor GI and HPB Surgery, Tata Memorial Hospital, Mumbai. Dr. Vikram Chaudhary, may I request you to kindly come up on the stage? Now I invite panelist of this session, Dr. Jaswant A. from Stanley Medical College, Chennai, Dr. John Manipadam, Lake Shore Hospital, Cochin, Dr. Avinash Upadhyay, Big Apollo Spectra, Patna, Dr. Richa Chauhan, Mahavir Cancer Sansthan, Patna, to kindly come up on the stage and take their respective seats. Thank you.
Thank you very much. Thank you, organizers, for this opportunity. And responsibility given to me is to discuss the multimodality management of locally advanced pancreatic cancer. The fact that we are having a session on LAPC in ISG does tell us that the surgeons now have a renewed interest in this. This would usually be a panel discussion in a MEDONC or a RT conference, but now we are having it at surgeons conference. So this is my panel, Professor Jaswant, Dr. John, Dr. Avinash, and Dr. Richa. Dr. Avinash will cover the MEDONC part, and Dr. Richa will cover the radiation oncology aspect. And Dr. John and Dr. Jaswant, I'm expecting to help me with the radiation surgical discussion. The time for the panel is, I think, 30 minutes. Time has to be reset. So the traditionally LAPC has been considered unresectable. Around 30 to 35% of the pancreatic cancer patients do present with locally advanced pancreatic cancer. The vascular involvement in LAPC is not uniform. Some of these patients have a vein predominant disease. Some of these patients have one or two artery involvement. Some of these patients may have multiple artery or vascular involvement. And and therefore the involvement is not uniform. The survival in this subgroup is only 10 to 15%, and the median survival increases if you offer them surgery or if you can offer them surgery. Uh, the multimodality treatment has evolved in last 2 to 3 decades, and there is slight improvement in 5-year survival of pancreatic cancer with this. And and let's go to the case now. So she is a 54-year-old lady, diabetic, good performance status, has a history of hysterectomy in the past for a benign indication, who presented with abdominal pain, worsening diabetes, loss of weight. Abdominal ultrasound showed a pancreatic mass. A CA19-9 which was performed was 1000, and rest of the investigations were normal. And this was the CT scan which was performed. So any of my surgical colleagues would like to comment on the CT? Give you the images, the CT scan. Dr. John?
Yeah, as the slide shows, there's the involvement of the celiac axis and the splenic artery, and also the portal vein abutment is there.
So the tumor did involve the the celiac artery, but I think the LG had a origin which was very near to the origin of the celiac artery or the celiac artery, and the tumor predominantly involved the hepatic and the splenic artery bifurcation is what is seen, and it also reaches the portosplenic confluence, and you can't see the splenic vein. So by definition, Professor Jaswant, what will be the classification of this tumor? Would you classify this as a locally advanced tumor or a borderline resectable tumor? How do you classify this tumor?
Basically locally advanced pancreatic cancer. So by definition, local advanced pancreatic cancer, it is without any metastasis, the name suggests, but locally unresectable because of extensive vascular involvement. Say, for example, more than 180 degrees of supramesenteric artery, carotid artery, or celiac axis, unreconstructable portovenous axis.
Yes, so this classically is a locally advanced pancreatic cancer. There have been some proposals of including this kind of tumor, which is potentially feasible for Appleby after a neoadjuvant therapy or a systemic therapy, to include these tumors in borderline resectable pancreatic cancer. But as of now, they are still classified as locally advanced pancreatic cancer. So for all practical purposes, a distal pancreatic tumor which involves the celiac axis with or without venous involvement is classified as a locally advanced pancreatic cancer. For a head tumor, the classification differs, and the SMA and the common hepatic artery come into the play. And once these become more than 180-degree involved, or if they are completely involved, it classifies as a locally advanced pancreatic cancer. Most of the times, as far as the venous criteria is concerned, non-reconstructability is the only criteria which is taken as a definition of locally advanced pancreatic cancer. So we have classified this as a locally advanced pancreatic cancers, but what is your intent in this patient, Dr. John?
Since it's locally advanced, we should consider chemotherapy first. And then also we should consider the CA19-9 levels and the performance status of the patient. So that would help us to make a comprehensive decision as to how to proceed. But invariably, a locally advanced pancreatic cancer, we would go for upfront chemotherapy.
Dr. Avinash, would you like to clarify what is your intent? The surgeon has referred this patient to you for chemotherapy, but he says that it is potentially resectable.
So locally advanced pancreatic cancer, classically, we will have a palliative care approach. But in recent the trials which have shown that if you give good chemotherapy, actually earlier trials used only single agent chemotherapy. Now we are using multi-model chemotherapy, like 2 or 3 drugs, along with incorporation of radiotherapy. We might convert some of these tumors. Some of these tumors might get resectable at a later point, but classically the approach will be palliative only.
So the definition of a locally advanced pancreatic cancer is radiological. It doesn't take into account the performance status of the patient and the CA19-9, which you need to when we are planning the therapy. And usually if the CA19-9 is more than 500, if the performance status of the patient is not optimum, these patients may not be candidates for curative intent treatment, and that they may go into systemic angle. And as I said, a definition of LAPC is not uniform as the vascular involvement varies, and the intent whether a surgeon considers them potentially resectable in future or not also changes, and that's why this classification. Would you like to comment about this, Dr. Jaswant, that this newer classification is LAPC, which we discussed?
Because of reconstructability of the vessels, the classifications have been made actually. Another classification, because I also told earlier, biological nature of the tumor as well as the performance status of the thing.
I think to get the more uniformity in the definition of LAPC, what was done was most of the time the celiac artery involvement is considered resectable. When there is a SME involvement, it may or may not be resectable, and when there is multiple artery involvement, it is usually non-resectable. So locally advanced, possibly resectable, may or may not be resectable, and probably not resectable. That's why they subclassified the LAPC into these three groups of 3A, B, C, and that's what is being proposed. But this is not a standard again. So if the patient's performance status is good, if the tumor markers are responding to chemotherapy, we know that there is enough evidence that around 20% of these patients are potential candidates for future surgery. And yeah, this is John Hopkins data where you can see that 55% of their patients are locally advanced. Our data suggests that around 35 to 40% of our patients are locally advanced, and around 20% of these patients undergo surgery after adequate neoadjuvant therapy. At our center, the rate is around 15 to 20%. So very quickly, Dr. Richa, a role of PET scan, staging laparoscopy, and endoscopic ultrasound guided biopsy. So do you do a PET scan regularly at your center for locally advanced pancreatic cancer, and what is your opinion about this? Should it be done?
Yes, at our center, if it is locally advanced and we are planning to give a new adjuvant chemotherapy followed by chemo radiation, we do go for a PET CT to rule out for the micrometastasis. But all trials and have seen diagnostic laparoscopy should be the gold standard, because PET CT, especially with the FDG PET, what we are using, we can miss a lot of maybe peritoneal implants and something like that, or even small tumors with FDG PET. So if diagnostic laparoscopy is available, that should be the initial, staging procedure. And of course, when we are starting with new adjuvant, we need a tissue or a biopsy proof. So if available, endoscopic guided biopsy should be done. If not, then we can go for a
Dr.
percutaneous
John,
biopsy.
is PET scan your routine practice in pancreatic cancer, or are there any specific indications for pancreatic cancer where you would consider a PET scan at a baseline?
Especially if the CT scan is showing some indeterminate histology, there are few nodes which are, around 1 centimeter. So for those cases, we go for PET CT scan. For other cases, we may skip CT
Dr.
scan.
John, in surgeon's practice, do you do PET scan as a routine, or you have specific indication for PET scan in pancreatic cancer?
Yeah, only when it's borderline resectable, locally advanced, or if the CA19 levels are very high. Not in all cases.
Yes, I think we should summarize that the PET scan is not a standard indication for assessment of pancreatic cancer. If most of the patients would have a metastatic disease diagnosed on CT scan, and if tumor is resectable, low tumor marker, still FDG PET doesn't have a good avidity in pancreatic cancer, possibly because of its significant amount of stroma which it carries. But there is something called as a FAPI PET which is coming up, and there are studies which are now showing that FAPI is something which may have a slightly higher sensitivity and even specificity as far as the staging of a locally advanced pancreatic cancer or a recurrent pancreatic cancer is concerned. And this is something even we are trying to look at our center. We are recruiting patients actively for this. And I think the PET has a role in pancreatic cancer only probably in borderline resectable or locally advanced pancreatic cancer for response assessment, and probably in recurrent setting. So that's the use of PET scan in our own practice. We do staging laparoscopy very selectively. As Dr. Richa rightly mentioned, the patients who have exceptionally high CA19-9 and tumor is appearing resectable or border or non-metastatic on scan, and where you definitely want to decide an intent if the patient's PS is borderline, where you don't want to be really very aggressive if the patient is having a metastatic disease. Probably these are selected indications where staging laparoscopy can be considered. But again, again not a routine in even our practice. So FAFI has shown a good sensitivity. You can see that this is a patient who was operated in 2019, came few months back, and there was a stranding near the celiac artery, which was clearly having an uptake. So now, in our case, you saw that the GDA was free, the portal vein was free, though the tumor was reaching the portosplenic confluence, and the celiac artery was involved, and the SMA was completely free. So in this case, Dr. John, what is your intent?
If the SMA is free, there is a short segment portal vein involvement, and the celiac axis seems to be involved. So I would prefer to go with chemotherapy first, and then hopefully, if the disease remains stable or if it downstages, we could counsel the patient and
I
attempt to
think
resection.
everybody agrees that this patient will go for a neoadjuvant therapy, and now probably the debate would be whether you are going to go ahead with what is your regimen of choice, and what is the duration of therapy which you are going to offer. So, would you like to comment? What is Dr. Avinash?
So, if you ask me the best regimen which I would choose for a very fit patient, I would definitely like to go ahead with modified FOLFIRINOX.
So why modified FOLFIRINOX? The SWOG trial apparently showed that the FOLFIRINOX and the Gem-Nab-Pacli are probably equivalent in neoadjuvant settings. So why the medical oncology colleagues are stressing for FOLFIRINOX? Any opinion about that or explanation for surgical colleagues?
So modified FOLFIRINOX not only in this category. If you see adjuvant, if you see metastatic, everywhere in metastatic, in pancreatic cancer, the FOLFIRINOX has shown very good results. Whereas Gem-Nab-Pacli, when it was tried in adjuvant, it didn't show any benefit over Gem. So still, we want to give FOLFIRINOX.
I think apart from the SWOG trial, there are quite a lot of studies which have shown that the FOLFIRINOX probably has better DFS and OS in pancreatic cancer, even in neoadjuvant setting. However, one of my medical oncology colleague nicely explained to me that probably it is better to give a regimen which you can give full strength rather than giving a compromised FOLFIRINOX. So if the patient's performance status is not suitable for FOLFIRINOX, some Gem-Nab-Pacli may be a better option in
So
that
if the
patient
patient
rather
is not fit, definitely modified
Yes.
FOLFIRINOX is a very toxic regimen. So it's difficult to
Ah.
use if the patient is not very fit.
Yes, and
Then
that's
in that time we can use single agent Gem or Gem-Nab-Pacli or Gem-Cap also.
and when do you reassess the patient once you start the neoadjuvant therapy or a systemic therapy in LAPC?
4 cycles of modified FOLFIRINOX I will give, and then after 2 months we will reassess the patient.
And in your own practice, what is the current usage of radiation? When will you think? When will you call the radiation oncologist in your practice?
If the patient has either stable disease or there is a decrease in the tumor tissue when we reassess after 4 cycles, I would like to involve my radiation colleague at that time.
Dr. Jaswant, the patient has received 4 cycles of systemic FOLFIRINOX. Patient has responded well. There is a partial response. The tumor markers have come down. In this patient, would you like to continue chemotherapy or would you like to plan this patient for radiation at this moment and use radiation in this patient?
The patient is responded. I would like to also do diagnostic laparoscopy in this patient.
Okay. Okay.
And plan for surgery.
I take your point. Basically, you want to confirm the intent again that patient has responded. So whether you want to go ahead with surgery later or not. Dr. Richa, would you like to offer radiation or you would like to wait for your colleagues to keep on giving more chemotherapy?
No, after 3 to 4 cycles of chemotherapy, we'd like to go for chemo radiation. But before giving chemo radiation, I'd like to restage the patient because these cancers, they are very prone to, progress and develop metastasis. So after 4 cycles of the chemotherapy, we'd like to restage the patient. And that if the disease is stable or has responded to chemotherapy, I would definitely like to go forward with we use the long course radiation protocol, 45 to 50.4 gray in 25 to 28 fractions, along with concurrent daily capacitor
So
bin.
on the background of alliance results, how do you justify the use of
Okay, yes. So
radiation?
alliance result, it did show that adding chemo radiation was not helpful. But then if you look at there are only 30 patients in the chemo radiation arm, and out of them only 10 patients completed the treatment. And after that, the analysis was done. The SBRT they used and the dose, the planning contour and the plan evaluation, that was not very adequate. So maybe because
I think
it is one of the cause
I
for the
take your
failure.
point that probably that was not a properly conducted trial,
Yeah,
multi-center
exactly.
trial where actually few of the centers were not good at offering SBRT. The doses were suboptimal. And the trial also was not completed. So maybe we should not write off radiation with this trial. But Would you
Yeah, we
argue for a long course radiation or would you argue for a SBRT? What is your choice and what will you prefer in your patients?
see right now we are going with a long course radiation based on the Conco 007 trial, which showed that if you add a long course chemo radiation after induction chemotherapy, the chances of getting a R0 resection increases substantially. And in the subset analysis, if you see patients, these type of patients who are able to undergo R0 resection, they do have a survival benefit. So adding and with SBRT, yes, it's coming up in a big way. There are many ongoing trials. So we, at our center, we have not yet shifted, but most likely SBRT will be in future.
So at our center, our usage of neoadjuvant radiation maybe have reduced a little bit as compared to what it was historically, but I would not say that we don't use it. We use it more often than not, even in borderline resectable, not only in LAPC. And you can see that most of the patients have received neoadjuvant radiation. Our preference is SBRT, and on matching, you can see that the patients who do well uh, are the patients who have only vein involvement if they undergo surgery, if there is an overall radiological response, if there is both serological and radiological response, if there is a CA19-9 response. So if these criteria are fulfilled, the patients who have neoadjuvant therapy should be considered for surgery. And we still use radiation in our patients in LAPC settings. And I think we even in our borderline resectable pancreatic cancer paper, which we published in 2018, we saw that in our patients, the patients who took neoadjuvant radiation at that time, it was more of a long course radiation. And if they undergo successful surgery and if they complete their adjuvant, the survival in that arm was the longest among all the patients. But again, these are super selective patients who completed their adjuvant therapy, so may not be applied to the whole cohort. But that's what we have found, and that's why we have not stopped or reduced our radiation beyond a certain extent. It is still an important part of our neoadjuvant therapy armamentarium. So how do you assess the response after neoadjuvant therapy, Dr. Jaswant, Dr. John? Any of you can take in your practice. You are given them 4 or maybe 8 cycles now, and then how do you assess? And what is your definition of TNT? How many cycles would you define as TNT, Dr. Avinash?
So there are two protocols which we use. We can go for like FOLFIRINOX if we have given 4 cycles of FOLFIRINOX, followed by CTRT, and then we go for surgery, and then adjuvant chemotherapy. So for chemo radio, we combine totally 6 months of therapy we give in neoadjuvant and in adjuvant.
So if you see a response after 4 cycles, would you still consider continuing chemotherapy for a longer period of time, or you want to assess the patient now for surgery?
So surgery, it has been shown in all trials, particularly in unresectable or borderline resectable. If the patient has undergone surgery, then only the long-term outcome has been good. So after 4 cycles, if the patient is doing good, the tumor has regressed or it is stable, then I would like to go for like surgery or
So,
radiation.
Dr. John, what is your protocol? Like the patient has received 4 cycles now, and there is a partial response. Now, what do you do?
Yeah, for borderline resectable, definitely we take up for surgery. But for locally advanced, maybe there is a role for extending further with radiation because the disease is more advanced and the chances of resectability is less.
I think usually minimum of 6 cycles is something is defined as TNT in literature, but preferably 8 cycles is what is the norm is considered as a TNT. To call it a TNT, it has to be at least 8 cycles of FOLFIRINOX and 6 cycles of Gem-Nab-Paclitaxel probably, and with or without radiation. And do you use FAPI or FDG, Dr. Jaswant or Dr. John, in your practice to assess the response after neoadjuvant therapy? And
No, we use only staging laparoscopy, CT scan, and CA19 level. Of course,
so
the
I think the
performance is
disease
there.
stability which you want to document, as long as there is no progression of the disease, as long as there is no new onset lesions, if the patient's performance status is good, and if the tumor marker has come down to an acceptable level, all these patients should be explored for potential surgery, is what the message is. So these are the criteria which patients should fulfill, and then they would be considered. So now this patient after neoadjuvant therapy, her CT scan looked like this. So what is your plan? I think some disease still, I think, looks abutting the adrenal. but the tumor volume definitely seems to have reduced a little bit. I won't say significant, but a little bit. And the CA19-9 has come down. So this is what the tumor is. Would you like to comment about this, Dr. John? What do you want to do now?
Yeah, in CT, if it's not a progressive disease, and if in a locally advanced setting the patient has completed the total neoadjuvant therapy, then there is a role for attempting resection after adequate counseling and preparation.
So yes, so this patient's CA19-9 had come down to 18 from 1000. She had an excellent performance status. Her albumin was more than 4. All other investigations were normal. And we, in her case, actually gave 12 cycles of FOLFIRINOX followed by SBRT. And then finally she was operated. But something about total neoadjuvant therapy is uh, if the patient is responding and if you continue to give more cycles, the minimum chemotherapy or systemic therapy which is offered is 6 months. That's what most of the centers would follow. If it is addition of radiation, sometimes it may vary from 5 to 8 months because the radiation will take maybe around 3 months more. It will add a treatment duration of 6 weeks or SBRT if it is around 1 or 2 weeks. So it is around 6 to 8 weeks of months of neoadjuvant therapy, followed by reassessment for surgery. It has been seen that with the total neoadjuvant therapy, not only it selects the patients better, you have more R0 resection rate and you have more uh, pathological complete response rate if you give more cycles in neoadjuvant therapy. And of course, the likelihood of receiving complete systemic therapy is more if you are giving all the cycles before surgery. There are phase 2 trials which have suggested that uh, total neoadjuvant therapy is something which we'll need to look at even if you have a curative intent in patients, particularly who have LAPC. Now again, you are going to offer a vascular resection, so you have to balance your risk of offering major vascular resection after a lot of chemotherapy. Those cycles also have to be tailored to the patient and the type of surgery which you are going to perform. But 6 to 8 is something which we usually do in such kind of patients. So this is what we perform in these patients. So portal vein resection type 1 celiac axis resection. But in this case, we could preserve the left gastric artery origin and the hepatic artery to the proximal stump anastomosis was feasible. So would you have done the same thing, Dr. Jaswant, or would you have done something else in this patient?
Same thing only.
So would you have tried to preserve the left gastric artery origin, or it wouldn't have bothered, or you would have gone ahead with
I will
resection
always
of that
try to
artery?
preserve the artery. And do divestment, you will always do divestment, preserve the artery.
Dr. John, your
So you have to go
practice,
for
would you recommend a complete radical resection and just take out everything, or you agree with this approach?
I agree with Dr. Jaswant's approach, the left gastric artery, because the gastric supply is important. So since the right gastropolic, all that it's going to be lost in the resection if there's a type 1 portal vein resection. So the blood supply to the stomach is important. So it's important to preserve it if possible.
Dr. Ramesh has a comment to make, so I think we'll take his comment. Because I think the so I think we may who are not responding will need a different approach of maybe change of chemotherapy or maybe addition of radiation that probably we did not touch
4 to
because
6 months of chemotherapy will have more effect. The tumors.
So TNT data, if you see the recent trials, Conco 007 also, the OS and PFS data is not very clear. Like it has not changed if you compare just chemotherapy versus chemo plus chemoradiotherapy. But definitely R0 resections, CRM negative resections, they were pretty high in those arms. So we believe that giving the combination of chemo as well as chemoradiotherapy will improve the things for
so I
pancreatic
think
cancers.
Professor Ramesh, as long as we are discussing LAPC, a 6 month of systemic therapy, which probably would involve anywhere between 6 to 12 cycles of FOLFIRINOX actually, with or without radiation, is probably a standard of care for LAPC.
No. I still want only clarity.
Hmm.
Plus the resectability rate of 73 or 13 and all that. All these figures are depending on the number of resections, which itself is very small. So that significance is dramatic, but it's not really dramatic. I want to just point out to you. So if you have to look at the bigger picture, you have 100 people who get into this train. How many people get home? That's the question. So
Yes.
which way are we going is we don't quite know.
Yes. So I
We have
think
to pull it together.
initially I
True, true. I
mentioned
think
that at our center, the resectability rate or the number of patients who are undergoing surgery for LAPC are around 15%. I
yes,
also
yes,
showed
yes.
the John Hopkins data where they showed that 20% of their LAPCs undergo surgery. So it is likely to vary as per the center, what is the extent to which you want to go to offer resection, and that's what is going to make a difference between the resection rate. But it's anywhere between 15 to 33%. I think the
Exactly.
Heidelberg group had suggested that their resection rate is around 30%. So I think the resection rate in LAPC varies anywhere between 10 to 30%. It usually won't go beyond that because a lot of this cohort would be non-resectable. Some of them will progress, and therefore the resection rate is likely to stay between 10 to 30% depending upon where the center wants to take it further. Manish will comment here.
One quick comment for what Ramesh sir asked about 4 cycles. One is the cancer indication that we give more therapy, but that data is emerging. But the other indication is to complete maximum therapy before surgery because it is likely that patients would take longer time to recover from a major surgery, which is for an LAPC, and will not be fit enough to go back to chemo. So maximum possible therapy needs to be finished before. That is another indication why we would want to do a TN.
Some emerging data from MSKCC that the chemotherapy response also assumes a bell curve. That there is a response and then there is an
Yes.
escape of the tumor
I
from the.
I think it was a very
When you
important
should
point.
hit the tumor hard. I mean, this is a very key
You
area.
cannot eternally give chemotherapy. You have to
Yes.
stop somewhere, and you
Plus,
have to take the window of opportunity to offer
may I
surgery. It's
finish,
a very
please?
good point. I think
May
that
I finish? 10 to
agreed.
15% of LAPCs have normal CA99. And whatever radiology you do, FAPI is also has its limitations. You can't be depend on imaging to decide when you to operate. You have to be a little proactive. And I think the comment made that the general condition of the patient is often the key determinant. And I think somebody should emphasize that.
Agreed. I agree with you, but I think we have a lot of things to cover. So let's go on. Do you use IRE in your practice, Dr. John? And what are your indications to send the patients for IRE? Any center is using IRE would like to convey the usage of IRE in LAPC patients, particularly?
I have no personal experience using IRE.
I think very few centers in India are offering it. We have also started offering it very recently. A very selective subgroup of patients of LAPC or the recurrent patients who do not have metastasis is what we are looking at. Our experience of use of IRE is developing. There is enough data in literature suggesting that if these patients are not being offered surgery, IRE may definitely improve their progression-free survival. There are uh, phase 3 trials also, which are probably coming up. The only problem with the IRE, which I would like to mention, is that uh, the morbidity rate of 3A and beyond complication is significant with IRE. There is almost 20% plus rate in almost every trial. And if you have a morbidity after IRE, the patient loses the chance of further systemic therapy or any other therapy. And that has probably been an important factor which has led NCCN to give a guideline that probably it is still not recommended as a routine practice. So I think Manish has nicely covered most of the aspects of LAPC, but as far as the vascular resections in pancreatic cancer is concerned, Dr. Jaswant, would you like to make any comment? How should you approach these patients, and what should you offer?
This triangle
Finish in
resection,
2
yeah,
minutes.
mainly the celiac axis, supramaxillary portal in the area is clear. Mainly in this case, we do arterial divestment also.
So I think that point was also mentioned well by Dr. Paul that whenever you are preparing for divestment, you should offering a divestment, you should be prepared for a vascular resection.
Section also.
The subadventitial and the periadventitial divestments were very nicely put up by Manish, and I don't think we need to go into details of that. But subadventitial divestment is something which can be very potentially very hazardous, and the bleed and the leak rates with those are very high, and which should be really done at a center of excellence at very few centers. this is now a standard of care that the LV3 dissection should be considered a standard of care for pancreatic cancer. These are some of the examples. As far as the graft is concerned, for a apple by procedure, there are various options. You sometimes you need not reconstruct at all if there is adequate prograde flow via collaterals. PTFE is an option. Autologous GSV is something which we use more commonly now than other grafts. As Manish mentioned, there are few patients where we would also consider autologous splenic artery interposition, but we ensure that in these patients, a long length of splenic artery need to be free of the disease, and a very small disease has to be there before we consider that for the principles of proximal and distal control. Before you resect the artery, the tumor should be completely hanging only on the vein, preferably, and you should be in a position to complete your anastomosis perfectly. As some principles, I think these cases, I think Manish also has shown. This is something which is important in patients who have a long segment venous involvement, where you, in the beginning, just put a long segment PTFE interposition graft, complete your resection, and maybe depending upon the length of the vein available, you can either reduce the length of the PTFE, or you can maybe just keep a length of the PTFE to tailor to the patient's requirement. As long as one major vein drainage is available, you can extend your indications in selected patients where a venous reconstruction may not be involved. The preoperative assessment of these patients is absolutely important. The length of SMA involvement, the narrowing of the SMA, the circumferential SMA involvement are important in deciding about offering either divestment of resection. And I think that I would conclude here. Any final comment from Dr. Jaswant about this?
Almost everything covered, yeah.
Yes, sir.
Yeah, almost everything covered, no? Yeah.
So I think the LAPC is a classic example of a need of cancer management in a multidisciplinary setting, and the results are improving. But as Dr. Ramesh said, we are far from what we desire. The resectability rate are still around 15%, 10 to 15% at our center. Would like to improve it further. It is seen that if you can offer surgery to this patient, their survival increases at least by 6 months, and if not more. And thank you to all my panelists. If there is any question from the floor, we would be happy to take.
So just one comment from my side, that in whole discussion we not discuss. So only 20 to 30% will make the discussion part, and rest 70% might require additional treatment. So at baseline of any locally advanced or metastatic pancreatic cancer, we must do genetic testing, including BRCA as well as NGS to see for any target, so that when a patient progresses on your first line chemotherapy, you might be able to give something to him while progression. Thank you.
So we are discussing LAPC. So probably, as we said, 80 to 90% patients are going to continue with you people. But these 15 to 20% of the patients where we should be exploring them and offering them surgery, because surgery is something which is likely to benefit them if performed in for good selected indications, is what the message would be. Thank you. Thank you, everyone.
Thank you so much, sir. Now, without any delay, we will begin with our next session, which is based on benign pancreatic disease. The topic is necrosectomy for acute necrotizing pancreatitis. Our panelists for the session are Dr. Saurabh Singla, DMC Ludhiana. I request you to kindly come up on the stage, sir. Next, I would like to invite Dr. Shreyash Modak from AIG Hospital, Hyderabad, to kindly take his seat on the stage. Next, I would like to invite Dr. Pankaj Kumar from Big Apollo Spectra Hospital to kindly take his seat on the stage. Dr. Rajiv Priyadarshi, AIMS Patna, I request you, sir, to kindly come and take your seat on the dais. Now let me introduce the moderator of this session, Dr. Rajesh Gupta. Professor and Head, Department of GI Surgery, HPB and Liver Transplantation, PGIMER Chandigarh, to kindly come and begin with his session. I request you, sir, to kindly come up on the stage.
Thank you, organizers, the scientific committee of this IASG for this opportunity. My talk is to moderate this panel about necrosectomy for acute necrotizing pancreatitis. Before we have a right mix of panel here with surgeon, a medical gastroenterologist who is our interventionist, Pankaj, and we have intervention radiologist, Rajiv, and Shreyash and Saurabh are there to help me in decide about the surgical issues in the case scenarios. So we have three cases to discuss, and before that, I'll just lay framework for the cases. Coming to the indications for intervention in necrotic collection or one, infection is obviously the clearest indication. Though diagnosis of infection is sometimes difficult, generally in the second week of the disease, where there can be overlap between the SARS as well as the infective etiology. But if there is a patient who has fever, leukocytosis, rising CRP level, procalcitonin level, and if you can demonstrate gas in the bed of the pancreas, then obviously we are dealing with infected pancreatic necrosis. And on top of it, if we have a new onset organ failure or organ failure which is persistent, or it is deterioration in the organ failure, that also becomes an indication for surgery. If we are dealing with sterile pancreatic necrosis, lack of progression is one sign where we should not delay surgery beyond a point, because we have seen that when we delay surgery, then we push them beyond a point where we cannot retrieve them. And if there are local symptoms like gastric outlet obstruction or biliary obstruction, so these patients would be other candidates for surgery. I must caution the residents here that the antibiotic use in acute pancreatitis is being abused. Antibiotics, it's not that antibiotics cannot obviate surgery, they can. The pointer trial did show that one third of the patients would be managed without any intervention just by antibiotics alone. But please understand that if we treat all pancreatic necrosis with antibiotics, we are going to have high mortality rate. Percutaneous drains are sufficient in themselves in half of these patients, but necrosectomy would be required more often, because if we do not deal with the source, we are not able to reduce the mortality. So this is a classification which has been given by three prominent institutes of US, predominantly from Mayo Clinic, where they have tried to make a uniform nomenclature for expression of this infected pancreatic necrosis, where the four quadrants are used. The vertical line is the midline, and the horizontal line is along the lower pole of the kidney. And then the quadrants 1, 2, 3, 4 are divided, and then depending upon the percentage of necrosis, whether it is 30%, 30 to 60%, or more than 60%, they are graded 1, 2, 3, and then presence or absence of infection. So probably in our institute also we are now instituting this so that we can compare results, because endoscopic necrosectomy is coming in a big way, and also it will help us define the treatment. Timing is important, as we will discuss during our case discussion, but please understand that keep in mind the patient's clinical status as in pancreatic carcinoma also. Delaying definitely has been shown to improve the results, and when we delay surgery beyond 4 weeks, whether we do step up or sometimes even we do upfront surgery after 4 weeks in a preserved patient, the results are no different, and that is important to understand. Which approach we will now see in the next three cases, but obviously it depends upon the local anatomy or the morphology of the disease as well as of the physiology of the patient. So coming to the first case, this is a 50-year male. Saurabh, wherever Sandeep's name is written, I would substitute you because I didn't know Sandeep was not coming, right? I'm sorry, your name may not figure, but obviously I will address to you wherever Sandeep's role is there. So this is a 50-year-old male who had no comorbidity, no history of substance abuse. He developed acute necrotizing pancreatitis, which was moderately severe because there was local complication. And this was 7 months ago. This patient was managed conservatively and discharged in 5 days at a local hospital. And then after that, this patient remains asymptomatic for 3 months. After that, patient develops upper abdominal discomfort and postprandial fullness with occasional non-bilious vomiting. However, there is no fever, chill, or jaundice suggestive of other local implications or presence of infection. So, Rajiv, this is the radiology of this patient. Can you please tell us what are the findings which you would like the residents to know?
Yes. The radiology CT, this is contrast scan CT scan, which is clearly showing a well-defined fluid collection. And this collection is involving pancreas and the peripancreatic area. And if you see the underlying pancreas, most of the pancreas is almost completely necrosed. It is not enhancing with the contrast. Only a small part of the head of the pancreas is visible. So it's more than 70% necrosis of the parenchyma. And it's a well-defined fluid collection. What is two important points that I would like to emphasize from the point of interventional radiologists is that number one, it's a well-localized fluid collection and it's behind the stomach. So it can be easily approached by transgastric approach. And this collections contains more than 50% of the solid component, although CT scan is not the modality to comment on the solid component. But since it is very heterogeneous, and I can guess it's more than 50% necrosis, and this case can easily be approached by transgastric approach. It is not extending down in the paracolic area or the pararenal space or any other part of the body, I mean, mesocolon mesentery. So, but whoever is taking this case, if the endoscopists are taking it, they should be ready to evacuate the solid component by putting the endoscope or whatever, or if the surgeon is
So I will
taking this
discuss
case,
that.
they
But
should be.
as an intervention radiologist, would you like
I would
to
say that
intervene in
yes,
this?
this is 50% solid component, and this requires evacuation of.
I think Rajiv is conveying a very clear message that the percentage of solid necrosum is important to know when we are deciding about any intervention, right? So this patient was then referred to gastroenterology department with features of gastric outlet obstruction. The intervention gastroenterologist did endoscopic ultrasound and they found that the percentage of solid necrosum was 70%. And subsequently, patient didn't turn up because he was doing well, though he was not progressing. We will see the investigations. The ultrasound showed the liquefied content around 20 to 30%. The size has remained the same. When he was admitted, patient was actually well preserved, but on examination, he had fullness in the epigastrium, which was, there was no guarding, no tenderness. And most of the investigations at that time were normal, except albumin, which was low, 3.4. So, Dr. Pankaj, with this scenario, what would be your approach?
Yeah, as the solid component is more than 50%, as the city and the previous EUS shows that the solid component is more than 70, approximately 70%. So I think surgical approach is a better option here. If we do the endoscopic necrosectomy by US guided cystogastrostomy, so that requires more session to remove the necrotic content, and the result of such type of necrotic content is not good.
Pankaj, do you make such statements in medical gastroenterology meetings also?
There are various RCTs which shows that if the necrotic content is more than 50%,
Whatever the level of evidence.
uh, uh,
I don't think, the intervention gastroenterologists do intervene in these patients also. So, I mean, this is just an observation. I'm not particularly pointing to
we
any
can
particular.
do
In general, I'm saying.
we can do, but the session of necrosectomy requires
Yeah,
this
that's
more session is
important.
required.
Right, that's very important. So, Shreyash, what will be your approach in a patient like this?
So it totally depends on the local expertise, as sir has told. If the good intervention endoscopist is available and if they are confident that they can clear that, it is still acceptable. But I would prefer a laparoscopic approach of transgastric drainage. Other point
But
to
why
note,
why would you prefer that if
other
endoscopists can
point
clear it?
other point to note is that patient has a gallstone related pancreatitis and still the gallbladder is not yet removed. So patient needs a laparoscopic cholecystectomy. So in the
Saurabh,
both
do you,
same sitting, we can complete the both procedure, take care of the etiology as well as the.
Saurabh, do you agree? So I think here the message is clear that uh, we probably endoscopy in a very expert, in hands of high expertise, probably should be taken up. Otherwise, with this necrosum amount more than 40%, that is what we have shown in our literature also, in our publication, then the chances of failure are more. And these patients going into repeated sessions mean we are leaving infected necrosis longer, right? Because we are not removing in one go, which we as surgeons do. So if we leave this necrosum, which is infected longer time, we taking 2 weeks to clear this or 3 weeks to clear this, we are prolonging the sepsis in these patients with its consequences. So this patient, that's why I love this trial, which is tension trial. If you go to medical gastroenterology conferences, they glorify this trial, and we surgeons also glorify this trial because it shows that the endoscopic or minimally invasive surgical approaches are showing equal results, and more so in terms of if we look at the new onset organ failure, which is probably the major concern with surgical interventions, is not higher in surgical approach shown in this trial. And the major complications as well as the death also was not different in the two trials. So that was clearly shown. Shreyas has very clearly shown that transgastric necrosectomy is effective one-stage procedure compared to laborious repetitive endoscopic necrosectomy. It ensures also the durable drainage, because if we put in a pigtail catheter, as was being discussed, would lead to external pancreatic fistula with its problems. So this patient actually underwent laparoscopic cystogastrectomy and necrosectomy and cholecystectomy. And I'm not going to show the video because that will take few minutes. But in case the anterior wall is open like this, I'll just run through the steps for the residents. And once we open the anterior wall, then we'll before that, and this is opened at the site of the maximum bulge, and after that the the collection is localized, and once the collection is localized, the opening is made into the posterior wall of the stomach, and that opening is enlarged by use of stapler. And here you can see the opening is at least 55 millimeters, right, compared to whatever the stents which are used by endoscopists. And not only that, you see that through this opening, all the necrosum can be debrided easily in the one go itself. And what we see subsequently is large cavity which is devoid of any necrosum. Of course, you can also see if there is any prominent vessel which can be clipped here, that can be also addressed at this point. So this is the specimen, and this patient was discharged on post-operative day 5. So coming to the second case, this is a 35-year male who was hepatitis B positive with low viral load. He was using alcohol for 10 years now, 60 ml a day. The date of pain onset was 8th of this July 24, with the pain which was severe, radiating to back, and patient also had abdominal distension with recurrent episodes of vomiting, high-grade fever with chills. He was admitted at local hospital in Karnal with severe necrotizing pancreatitis and multi-organ failure. He had both acute lung injury, bilateral pleural effusion, and persistent acute renal injury. This patient was managed at local hospital efficiently with IV fluids, but I mean, he was also given antibiotics. This is a day 3 of the disease when he was given antibiotics, which were continued for next 2 weeks. The AKI and ALI improved. What happens is the antibiotics get credit here. However, subsequently he started developing persistent spikes of fever. And then again, he was referred to higher center with oral antibiotics after 4 weeks. So, I will like to take Pankaj here for a brief content. This use of antibiotics on the second day, third day, fourth day, when we know clearly that this is not infection. What is your, reaction to this and your comments on this for this audience?
As per the studies shows, there is no benefit of use of the antibiotic at the initial part of the management of acute pancreatitis. So the main management is IV fluid, rehydrate the patient. Antibiotic is not used in initial part.
Right. So there is no role of antibiotics, especially in the first week. But as long as we have ruled out extra pancreatic sources of infection. So if there are no extra pancreatic sources of infection, which we have ruled out, and it is in the first week, probably we should not be using antibiotics. In the second week to third week, obviously, if there are other features, then you cannot distinguish SARS between the sepsis, and then probably the role will come. So in the fifth week of illness, this patient was referred to higher center and he came to us. At that time, in the fifth week of illness, he had pallor, there was pedal edema, he had tachycardia, and he was febrile. So if we look at components of SARS, we already have tachycardia, we also have temperature which is more than 100.8, which is 38 degrees. The chest showed bilateral decreased basal entry. Abdomen was distended. There was ill-defined lump in the left lumbar region, which was extended till the umbilicus, which was mildly tender, but there was no guarding. And investigations done at that time showed that he was anemic, leukocytosis was present, albumin level was 2.08. Both ProCal and CRP were raised. Dr. Rajiv, I would like to help us with the findings in this CT scan.
Again, this is another contrast CT, which is showing much more extensive fluid collections than the previous case. And underlying pancreas is again showing more than 70% necrosis. And here the collection is more or less well defined and has developed capsule. So it's a walled off pancreatic necrosis. And if you see the heterogeneity and there is some fatty component, which is clearly indicating a good amount of the solid component. So maybe in tune of 50% of the collections or the 40% will have at least solid components, which is extending down to the pararenal space. And maybe further it's going down to the left paracolic space and the left iliac fossa. So it's much more extensive collections, which is going down to involve the left iliac fossa and the paracolic space.
Thank you. So we now have a collection, which is actually one, and this is extending from pancreatic to pararenal to iliac fossa. So this patient was planned for surgery, of course. He was transfused blood. His nutrition was optimized in the short period of time, whatever was possible. We sent his blood culture and urine culture. They were sterile, but we didn't get any, since we did not get, so he was empirically started on piperacillin tazobactam. And these are preoperative investigations just before the day of surgery. There is some reduction in leukocytosis and improvement in albumin. So in a scenario like this, Would you like to wait further, Saurabh, or would you like to go in now?
No, sir, since the patient has a good albumin, TLC has come down, so some like catabolic phase is more or less decreased. So we'll plan way for surgery, this patient. I'd like to go for a surgery in this case.
Krish?
Yeah, he has passed the required time duration from the onset. He is now almost 6 weeks. Perioperative care has been set in. The enteral nutrition is being given in the form of supervised enteral feed, and general condition is improved. So unless until you remove the source, he will not improve further much. I would like to offer surgery.
So surgeons are very clear. What about Pankaj and
Yeah.
Rajiv?
I can prefer the step-up approach by placing the PCD followed by doing the US guided cystogastrostomy.
US guided cystogastrostomy.
Cystogastrostomy. And another approach is also there. By placing the PCD, we can increase the size of the catheter of the PCD, and through that catheter, we can do the sinus tract endoscopy.
Right. Rajiv.
If I were the radiologist, I would have taken this case for the percutaneous drainage. I will put a small size catheter first, 2 or 3 catheters, and maybe further I will keep upgrading it up to 28, 32, and I will try to do the suctions and the evacuation and removal of
Rajiv, what
most
about
of.
the solid component here?
Yeah, there is a lot of solid component, but if I feel that if I put two large bore catheter and I irrigate it, gradually it will liquefy and this patient might not need the surgery. This is possible, but it all depends on how much care I can give to this patient. If I am giving every alternate day irrigation, suction, evacuations, very vigorous, putting multiple catheter, I am ready to take up every alternate the patients, upsizing, adding more and more catheters. I can save this patient from the surgery, and maybe it can obviate the need of the surgery. This is my feeling, sir.
So I think, when we are managing these patients, the message should be that we are not trying to save the surgery from these patients. The important is to save the patient, right? That should be our center. We are trying to save the patient. In a patient who is in the 6th week of illness, whose albumin has gone down, who's nutritionally and immunologically challenged, who has lot of solid necrosum, and we know that if we start doing percutaneous drainage and treatment through percutaneous and endoscopic step up, it is going to take further 4 to 6 weeks. It will not be earlier than that, because if you look at the extension, it is going right down, and we may not be successful. And when we have pushed this patient beyond a point, and we refer the patient to surgeon, then the outcome is already written before the patient is surgeon. So I would agree. We in our center actually take up these patients early, at a time when there is a window period, because that is a time when we get the best results. This patient was taken up for video assisted retroperitoneal drainage. I'm not going to show this video now. And this patient responded. He came, this is the CT scan which was done 2 weeks later. Rajiv, you can have a look at it, and then we can move to the last case quickly.
Yeah, CT is clearly showing almost a resolution of almost all the fluid collection. What we can see is that still there is mark of the catheter which was put from the retro peritoneal approach just anterior to the kidney, and I think that catheter might have been used for the guidance of the
Right.
video assisted laparoscopic
So we quickly come to the third case. I think we just have 2 minutes. This is a 32-year male who's a non-alcoholic, had DJ stenting for renal stone disease, presented with pain in the epigastrium radiating to back, associated with multiple episodes of vomiting, shortness of breath, and high-grade fever. He was diagnosed with severe necrotizing pancreatitis with single organ failure. He was initially managed conservatively with IV fluids and also IV antibiotics. There was no resolution and was referred to the gastroenterology department of PGI. In the 3rd week of illness, he was having pallor. There was pedal edema already which had set in, tachycardic. He was maintaining blood pressure. He was a tachypneic. Oxygen saturation was low and he was febrile. Again, the bilateral chest air entry was low at the basis, more on the left side, more decrease on the left side. And there was a large ill-defined lump in the epigastric region, which was having diffuse tenderness. And this is a workup which shows leukocytosis, albumin which is low, AST is high, procal is high, and CRP is high. Patient was started on piperacillin tazobactam and teicoplanin empirically by our medical colleagues. And then in the 4th week of illness, this patient undergoes percutaneous catheter drainage, which was upsized around 8 days later, and we can discuss that. And antibiotics were upgraded. There was initial partial resolution. Percutaneous catheter drain showed pseudomonas. So, Rajiv, maybe Pankaj can take it. What is the significance of this culture which has grown positive maybe on the 10th day of the percutaneous catheter insertion?
Maybe due to the sepsis, the patient develop infection.
Might be related to the percutaneous catheter which was put for.
So that can itself introduce infection. Shreyash or Saurabh, you have anything to say here?
Antibiotic, like ill use of an antibiotic.
Oh, anyways, I mean, we should understand that if we are not growing organism at the first insertion of pigtail, we should not give importance to subsequent cultures which are positive because they are more often colonization. But it has to be seen in the context of the patient. If patient is having features of sepsis and you grow this organism, then you have to take this into consideration. So this patient was put on irrigation, and this is the radiology of this patient. Rajiv, quickly, please.
So it's a very extensive collections. Again, underlying pancreas is necrosed. Most important finding what I see is the lot of hyperdense material, which is indicating blood clot. And because of the blood clots, I think there is also PCD catheter from the retroperitoneal approach, which is not effectively draining the fluid collection. And there is still a lot of solid component and blood clots in the collection.
Yeah, so in the 5th week, there was hemorrhagic output, and then CT angiography was done. Rajiv.
Which is showing aneurysm, which is being marked by this arrow, blue arrow, which is pointing
So
out.
would you, I know you will otherwise embolize, but in presence of such huge necrotic material lying in the vicinity of this aneurysm, which is now bleeding, would your approach change? Would you send it to surgeon, or would you still go ahead and do embolization?
First, I would definitely like to do embolization because there is a lot of necrotic material, and underneath that there is aneurysm. So it might be very difficult. Maybe the surgeon will land up in torrential bleeding while doing the surgery. It might not be visible to
What
them.
are the surgeon's options? Go ahead with embolization.
So I agree with that. Pre-op embolization, if it is detected on a preoperative CT.
Right. So this patient was undertaken for DS and glue embolization, and then he was undertaken for open necrosectomy, which showed lot amount of, almost when we measured there were clots around 500 grams, and then necrosum was almost same size. And post-operatively, this patient had bilious drainage from the drains, which was actually delineated subsequently to be leak from the proximal jejunum. This patient is still recovering in the ward. And this is a post-operative scan of this patient. This patient is in the 4th week. Rajiv, quickly, please.
So it's again very good response, and there is almost a resolution of more than 80% of the collections.
So, we probably do not give importance to open necrosectomy today because the emphasis is on minimal invasive, but we should know that open necrosectomy in a patient who is well preserved, where there is extensive necrosis, still probably offers the best one-time approach for cure in these patients. And then briefly, minimal invasive necrosectomy also has a role where you can give small incisions over the pigtail catheter and achieve necrosectomy as we can do with large incisions, which we were giving earlier. But now, and these are giving better results. Our paper has also shown that. So I will conclude here by telling that we have different approaches available to us, which will depend upon the condition, expertise, the condition of the patient, the expertise, as well as about the morphology of the disease. Any questions from the audience?
A small comment on last case. As there is a pseudoaneurysm, so depending on the expertise or center at which the case is, we can do the US guided coil embolization of the superior mesenteric artery followed by the sinus tract endoscopy and necrosurgery through the same catheter.
This is not. This is a branch from the SMA, not the superior mesenteric artery itself. The branch. This is a 5 millimeter, right? Any questions from the house to the panel? Sir, that is just one.
Sir, may you please switch on your mic?
Since first case, gallstone-induced pancreatitis with necrosis. Even if there is less necrosis, straight away go for laparoscopic cystogastrostomy, some then cholecystectomy, as Shreyas said. Yeah, the single stage procedure.
Rajiv. Oh, Pankaj. Sorry,
Yeah,
Pankaj.
that's
You are a
mentioned,
comment.
yeah.
That was what was done in the first case.
Yeah.
Straightforward. There was
Straightforward,
no any straightforward that patient was taken for the
because
surgery.
single stage procedures better always. No discussion about endoscopy, cystogastrostomy, necrosectomy and all. Because single stage you can do the laparoscopic cholecystectomy as well as laparoscopic necrosectomy also. Simple for the patient.
So I
Otherwise-
think Dr. Jaswant is trying to say that when the etiology is gallstones, we know that.
That will be the added advantage. That's why cholecystectomy and necrosectomy that can be done in the same setting.
Do you agree that in all patients with localized retrogastric necrosum, we should go ahead and do surgical intervention?
No, not in all cases.
No,
Depending
that's what is the, because there is a gallstones which also need to be tackled.
In this particular case, what was done was the best approach from my point of view, because there was a lot of solid component. There was very high chance of the failure of endoscopic approach or even percutaneous transgastric, because it's not all liquefied.
The question is different. The question is necrosum is said 20 to 30%. Would you address? But Dr. Jaswant, you know, I mean, if it is symptomatic, then only we should
that's
address. Otherwise, we can leave that.
That's
I mean, sterile one does not need any treatment.
Yeah, that's true.
That also should be clear. Any other question?
Thank you, sir.
Sir.
Can I ask your comments about the Q&I approach to pancreatic necrosis? Can we categorize our patients because we don't know what language we are speaking? You know, you showed us several morphologies. If you have the quadrant, if you have the amount of necrosis, and if you have the presence or absence of infection, presumed or real, then we have a kind of template where we can plan treatment. Your comments.
Yes, sir. I mean, this, I was first introduced to Q&I by Dr. Ramesh itself. And that is the slide which I had put up. I mean, it's not showing there. So Q&I, I have already elaborated on this in the initial part. Q&I means quadrant, which are 4 quadrants. The abdomen is divided. Necrosis, as I said, less than 30, 30 to 60, more than 60, and presence or infection of necrosis. This will help us determine which strategy to adopt, whether endoscopic or surgical, number one. We can also upfront know what are we expecting out of these patients. Either a single procedure or repetitive procedures would be required. So we should start using this. In our center, we have started now. And I expect other centers also to start utilizing it. With this, I would like to thank my panelists, and they were very clear in their thought, and also the audience for their participation. Thank you so much.
Thank you so much, sir. Now it's time for our next panel discussion, which is based on complicated chronic pancreatitis. And our panelists for the discussion are Dr. Dipankar Roy, Kolkata Medical College, Dr. Mohan N. from Meenakshi Mission Hospital, Madurai, Dr. Sanjoy Mandal, Kolkata, Manipal Hospital, Kolkata, Dr. Sanjeev K. Jha, IGIMS, Patna. I request you all to kindly take your seats on the dais. Now I invite Dr. H. Ramesh, the moderator of the discussion. He is the Director of Surgical Gastroenterology, Lakeshore Hospital, Cochin. I request you, sir, to kindly.
Could I have my... Could we have a presentation up, please? Somebody? The old presentation is still
patient of suspected EHPVO, we would like to do the prothrombotic profile to do the whether the some prothrombotic condition is there or not, and in patient chronic pancreatitis related the portal hypertension, we would like to see whether which vein is involved, the splenic vein, portal vein. So, in all these cases, there is a clinical point of view, we would like to do the endoscopy to see whether the varices is there or not. In presence of varices, the further course of treatment depend upon the bleeder status of the patient. If the patient is bleeder, then the endoscopy is needed to for the varicose eradication in the presence of esophageal varices is there, or the blue injection in presence of gastric varices. If the patient is non-bleeder, then the further course of action depends upon whether the any symptoms, the pancreatitis like symptoms is there or not, or the pancreatitis like mass is there, whether the surgery is indicated or not indicated.
So let me ask you, you said prothrombotic conditions. What tests do you do to assess for prothrombotic conditions? You mentioned something about prothrombotic conditions. I mean, especially in patients with extrahepatic portal venous obstruction, in a patient with cirrhosis, in a patient with chronic pancreatitis, do we specifically look for factor V Leiden mutation or protein C, protein S deficiencies?
So in typical case of chronic pancreatitis, with involvement of isolated splenic vein, whether the cause and effect, the pancreatitis is very well known to cause the splenic vein thrombosis. So in such cases, usually the prothrombotic evaluation is not needed in my view, but if there is a involvement of extensive venous involvement is there, including the portal vein involvement and the cavernoma formation, in those group of patients, I would like to do the prothrombotic evaluation.
Yeah, maybe there's no umbilical sepsis, no childhood umbilical sepsis, no such history, early age chronic, portal hypertension, and then chronic pancreatitis also. Maybe it's worthwhile. Dr. Mandal, would you like to tell me how do I differentiate the portal hypertension component from the chronic pancreatitis component? Do I see it separately or do I see it together? Some tips?
I think for the management wise, I think we need to see both things. If the patient, I would look at it this way: if the patient has an underlying problem with regards to the chronic pancreatitis, then these patients would require surgery. And if these patients have a symptomatic varices or symptomatic portal hypertension, they should be tackled together. If the patient,
how do you do the tackling together bit?
Do either a head coring drainage procedure with a splenectomy.
And the devascularization, you mean?
A splenectomy would be an ideal to treat these, but if you are not able to do it, then a devasculation.
If the thrombosis is extending onto the splenic vein and portal vein,
I was talking about the left-sided portal.
Yeah, if it's left, it's fine. But if it's extending beyond, which is a more usual case.
If it's involving all these, then probably there's, splenectomy is not going to work. There's no shuntable vein. A devas is the only thing that can be done in these patients, if surgery is at all required.
Just a quick question, maybe Deepankar can comment. Chronic portal hypertension means disaster. Let's say we are not talking about cirrhosis, we are talking about extrahepatic portal vein obstruction and chronic pancreatitis. Surgery is not very easy to do.
No.
So is it better to do always endotherapy? Or is it better to find a good time and do the surgery carefully? Can you suggest something? Or everybody can respond to this?
Focus should be surgery for the chronic pancreatitis itself. Focus whether the patient was indicated for in the surgery is indicated for chronic pancreatitis. Most of these patients, even they have varices, usually they don't bleed much. Esophageal varices should be banded, that is definitely there. But these patients already, the patient we are talking about already developed collaterals. So I don't think the surgery should be focused on chronic pancreatitis, is phrase, Rivagers, the focus should be chronic pancreatitis surgery, not isolated any surgery for the portal hypertension.
Dr. Mandal, do you think it's easy to do these scoring in chronic pancreatitis?
Definitely not. Definitely not. I think the surgery, I mean, if the patient is not symptomatic for the chronic pancreatitis and only having a bleed per se, they should be managed with endoscopy. But if it fails, then probably surgery has to be, and it has to be done carefully. I mean, you have to keep these patients tend to bleed a lot. And if there are a huge number of collaterals probably covering, then I think we need to have a second thought also.
Except for the small group which you mentioned of the left-sided portal hypertension where it's therapeutic. I think pretty much I'd like to see both these entities separately and treat them both. But if you're going to operate a patient, certainly variceal obliteration is a good idea because you don't want the patient to bleed post-operatively. So even if they have not bled, I would like to suggest to Sanjay Jha that we should do a endoscopic therapy of whatever type. It's just a suggestion and I don't know if you agree with that.
Or yes, grade 2-3 esophageal varices should be banded.
No, he said if it's not bled, you shouldn't touch it. That's what he said. That's why I wanted to clarify.
No. If the varices is of high risk, then and some sort of pancreatic surgery is indicated in near future, then the varices should be banded before surgery.
Dr. Mandal, is there a role for a shunt in a patient with EHPVO and chronic pancreatitis?
If it's an EHPVO, yes, you can do a shunt. I mean, but for a left-sided portal hypertension where I don't think splenectomy would be, I mean, the treatment of choice. In patients where there is, I mean, most of the time you cannot find a vein to shunt.
Yes.
If you have it,
exactly.
I mean, rarely you can get a mesocaval. You can do a mesocaval shunt in some rare patients, but most of the time you cannot, unless it is a exclusively isolated EHPVO limited to the portal vein.
Dr. Mohan, just a question. If you have a patient with very large collaterals, one of the things that we found is that if you interrupt the collaterals, you increase the portal hypertension. So often it meant that we have to drain the body and drain the head separately and leave these big collaterals intact. Your comments on such an approach?
Yeah, we tried to preserve the collaterals as much as possible, but invariably there are very thin-walled collaterals, and inadvertently by surgeon or assistant it gets ruptured, and we have to end up in ligating it.
I just want to update you because this is a publication from this country, from Sudeep's unit, where you must look for a possible entity where there is a possible narrowing or the obstruction to the portal vein where you can do an interventional radiology and transform the situation completely. And I think if you look for them, you will find more and more cases. After this publication, we found two patients which qualified for this treatment, and I'm glad to say neither of them have undergone surgery. Neither of them have undergone any therapy for portal hypertension either. So it's really, I'm thankful to Sudeep for bringing up this paper. So, any questions about portal hypertension quickly? Yes, Puneet. Mike quickly to them, please.
None of us are fond of, but this is one situation. If you enter inside, you can do a shot. It doesn't reduce the pressure that much, but it might save the day. So, one point. Second is.
Acute inflammation is lethal. Don't touch the patient. Absolutely acceptable. Second is that a makeshift shunt may work because it have temporary lifespan. During that time, you must do surgery on the pancreas as well. Same sitting, and it has to be geographically little away because if you have a pancreatic leak or something, then you have an unholy mess on your hands. Thank you, Puneet. So, biliary obstruction with or without head mass. And again, we have the story of a young man in the late 30s, abdominal pain, jaundice of 5 milligrams, tantalizingly, one episode of cholangitis, and a 9-kilo weight loss of out of 62 kilos in 3 months. So, it's significant. The CT scan showed, and this is a reconstruction showing that there is obstruction to the biliary system, calculi. This would seem like a pseudocyst with calculi in the wall, but it's actually calculi in the duct. There were calculi in the body and tail ducts as well. So how do we go about it really? What do we do next? Do we do US for these patients? Do you do ERCP? Do you do surgery? The patient has pain. The patient has a 5 milligram jaundice, biliary obstruction, but no mass on the CT scan. Dr. Jha.
So I would like to do US followed by ERCP.
No, why EUS? What is that you're specifically looking at?
So there is a mass.
There is no mass. You can see that there is no mass. There is no mass. There is a cystic lesion in the head, which could be either a blown up duct or a cyst. No definite mass on CT scan.
So cystic lesion is seen, but there is evidence of the peripheral calcification is also there. Calcification is seen on the wall of the cyst. So to characterize the lesion, I think US is required.
Okay.
And if suspect and there is also a dilated pancreatic duct as well as the biliary duct. So there is evidence of compression is there. So, and if the FNA is required, if we suspect some mass is there, then the FNA will be done in the same setting. And as the patient has evidence of cholangitis is there, then the biliary decompression should be done in the same setting to decompress.
Dr. Deepankar, would you agree with that plan, or would you have a different suggestion?
If there is no mass and there are stones in the bile duct and also in the pancreatic duct with upstream ductal dilatation, this is the picture. If the patient doesn't have cholangitis, then probably US. But if that cholangitis, then in any case ERCP and drainage will be required.
So does the other panelists agree that US, FNA, and probably a biliary stent is appropriate?
Actually, if patient is not in cholangitis right now, you don't need to do ERCP. US is also with no presence, no mass. US you can't find anything. It's stone will cast.
US may find a mass where the CT did not find it. That's the question I'm asking you.
Stones with lot of artifacts. US may not actually even in a big mass. US is unable to cannot find any. Biopsy.
That's the other view, which is very valid. So, what would you do? Patient has pain. Patient has significant pain, which is interfering with the lifestyle.
Surgery.
You would do surgery straight up, Sanjay.
I would get a US, but then offer the patient a surgery, depending upon the US finding.
Yeah, US FNA or just a US?
US with FNA, if they find a mass in the US.
So US FNA, if you find a mass, then if it's negative or positive, appropriate surgery. Yeah. Probably Mohan may go along with that, because as long as you said surgery. So I just wanted to mention here that this is something that I'm obsessed about, that if any stents have to be placed, please do the cross-sectional imaging before the stents. Stones themselves are bad enough, the stents are terrible. And even if you put a stent, even the US doctor is unable to see the change in the diameter or the caliber of the duct where he or she can concentrate their attention. So if at all a stent, then you do it after the imaging is over, cross-sectional imaging. There are many ways of trying to say whether this is cancer or not cancer. Dr. Jaswant is here and he published this data, and we have our own criteria. But whatever we may say, I just asked our panelists, put all the questions from clinical to radiologic to EUS and FNA, bilirubin levels. I talked about double duct obstruction, and you may notice here that FNA was given a thumbs up by everybody. Duct penetration was blocked, was given a good certificate. Clinical, that is type B pain, weight loss, worsening of diabetes, as well as double duct sign. And now the question is, EUS without FNA was also given importance, although I contest that, but I bow down to the panelists' opinion. And the rest of it, they said, is by and large rubbish. Do you agree? Except in a very difficult situation where those contribute a little bit. Do you want to, stick your neck out and change your stand or something, or you are happy with that?
No, I'm happy with this. Only thing is that I think single criteria doesn't hold. You have to look at in a whole picture.
The single criteria is asked why because you have a clinical suspicion of cancer. You do an FNA. FNA is negative, but there is double duct obstruction. Which are you going to give weightage? If you're going to give double duct obstruction weightage, then you give double duct obstruction 1 and then FNA 2. So that's what I just trying to push you guys into committing yourselves because we need some commitment from the experts. That's all.
Everything is okay, but probably there should be some weightage with bilirubin level also.
Yes, I agree. Bilirubin more than 5 milligrams. Dr. Jaswant will also subscribe to that. Our own data also subscribes to that. So I agree that bilirubin is also an important factor. I'm not going to. I'm going to delay. Just forget about it. I'm going to ask, Dr. Mohan to summarize. We have many categories. We have mass with biliary obstruction. We have inflammatory mass, no biliary obstruction. We have no mass, but extensive pain and some biliary obstruction. And you have no pain at all, only biliary obstruction. Four scenarios, your recommendations quickly.
Yeah, it all depends on how much of the stricture size is the very short segment thing or a mass having a long segment biliary obstruction. And if it is a very short segment biliary obstruction, definitely pancreatic surgery like a Frey we can get away with it. And if it is a long segment, we have to combine Freys with a hepatocytosis.
Only biliary obstruction, Dr. Mohan. The patient has got extensive calculi in the pancreas. There is no hypercalcemia. There is no mass in the head of the pancreas. But there is definite biliary obstruction. The bilirubin is 3 milligrams %. AUS has been done. There is no obvious tumor. Now, you follow up the patient. Do you do an endoscopic stent? Do you do a biliary drainage procedure?
No, actually on table we do a head coring and...
so you would add a pancreatic procedure in most instances. Yeah. Even in the absence of pain is what Dr. Puneet...
absence of pain you don't...
No. We are talking about a patient who has no pain, who has biliary obstruction with a bilirubin tantalizingly of 3 milligrams. This is a real situation. And no mass on ultrasound, no mass on CT scan, no mass on EUS either. Now, what do you do with this patient?
I think you have to combine a definitive head coring.
So there are those who would say that just observe the patient or just do an endoscopic stenting and observe and then re-image and see what happens. There are those who, such as yourself, who would say that they would probably, the presence of a complication is an indication for intervention. I think we have to leave it to the clinicians to do their bidding because we don't quite know what the... so, one final question. How many of these conditions would you tackle laparoscopically? And I'm not going to ask Sanjay Jha this question. I'm going to ask the 3 surgeons from my left to right. Sanjay Mandal.
I'll start with the lower one first. I mean, biliary obstruction, head mass. I think as surgeons, the head coring requires the guidance of the hand of the surgeon. I'm not sure we're able to do a good head coring on laparoscopy. There are some studies who have done phrase laparoscopically, but I don't think it's a classical phrase. But rather,
you have to be quick in your comments because we are running out of time.
Portal hypertension, not. Acute on chronic pancreatitis depends whether we are doing a drainage procedure or something or drainage, then probably yes, laparoscopically can be done.
The acute on chronic pancreatitis, lavage laparoscopically, and the rest all is as a policy open.
Deepankar?
Same, except there are few situations in chronic pancreatitis. If you decide to do pancreatic duodenectomy,
yes,
then
you could then do it laparoscopically or robotically. I agree completely. So I think the robot also has made our ease of dissection so great. I think is Kalai here? Dr. Kalayarasan has shown me very eminently that you can do a bigger procedure very well with the robot, and I thank him for his contribution. Chronic pancreatitis, more than any other condition, is characterized by the lack of teamwork often, and so I can't emphasize this enough. And I would like to coin this term of specialist machismo. We've had all types of machismo. This is specialist machismo. And I believe that every specialist feels that they have to treat the patient themselves. I hope we all do not fall victims to this approach. Would you like to add any comments, panel? And are there any questions? And we can stop.
No. I think chronic pancreatitis. So it is already very much proved that in Indian subcontinent we have a different kind of spectrum of disease than Western population. So the treatment schedule is or the protocol or management a little bit different than standard Western textbooks. I think we have a different kind of patients in chronic pancreatitis.
Yeah, what you mean is that we cannot extrapolate Western data directly to our country. And
yes,
I have our own
endoscopic interventions, a lot of endoscopic interventions. Those are probably not very suitable for.
My limit is 22 stents. So far, the maximum number of stents that have been placed in a patient has been 22. I'm hoping to see larger numbers. Dr. Jha.
Sir, I think I have just recently a consensus assessment has published in I think in 2023 or 24. In that consensus statement, the term the acute on chronic pancreatitis was recommended. And that is defined as the acute exacerbation, acute inflammatory exacerbation in patient with chronic pancreatitis resulting in acute deterioration of patient's condition resulting in exacerbation of pain. I think we have seen many cases of the patient with chronic pancreatitis presented as acute episode, but the such term is not defined. So we should think and should work on this condition.
Could you tell us the criteria for that definition? The criteria on which you say this is not just a severe type B pain or a severe exacerbation of just pain, but what criteria would you say this is acute exacerbation? What is the definition of that?
Sir, here the pain is because of acute inflammatory exacerbation.
As evidenced by?
Yeah, pain in absence of acute inflammation cannot could not come under this definition.
Thank you. Are there any questions from the audience? Yes, Dr. Pradeep. Can somebody get a mic across to Dr. Pradeep quickly so that we can hear? It's easier to mic to come to you than for you to come to the mic.
I think all of us don't operate when there is an acute exacerbation of chronic pancreatitis, but there can be situations where we have to operate, particularly when the patient is having recurrent attacks and there is no window of opportunity. So we did operate in such situations because so we cannot say that it is not an absolute contraindication, but in some cases where the patient does not, the acute inflammation doesn't subside, we did operate with acceptable morbidity in these patients.
So this is what it shows, that there will be more morbidity. You have to accept that you have to do morbidity. Maybe when the second time it happens, you operate the patient in the same sitting. Don't discharge them. Would you agree with that?
So one question here. So there was a patient, 19-year male, underwent repeated endoscopic procedure for chronic pancreatitis. Now his pain has been taken care of, and he has been referred for surgical consultation for portal biliopathy. Current LSM is 27, child age cirrhosis. So what can be done for this patient?
Sanjay? Mandal?
I didn't get. Could you repeat it once more?
Sir, young male, 19-20-year-old male. He had chronic pancreatitis since past 4 years. He underwent repeated endoscopic stenting, pancreatic stenting. At present, there is no pain, but has been referred for portal biliopathy with the LSM of 27, current child A cirrhosis. So, what can we offer him?
I think we need to work up the patient to see the extent of the thrombosis, and depends if it is
Same say, chronic liver disease with portal hypertension. Just something like that.
4 years back, his liver was normal, portal vein was normal, and now the portal vein is replaced by multiple collaterals.
And there are evidence of chronic liver disease also.
Yes.
Completely
Can I sort of short circuit this because time is running out and there's no pain. So the patient requires complete evaluation of his liver function, including a liver biopsy. See if the liver deterioration is a consequence of what is it a consequence of? Is it because of continuing alcoholism or what it is? And manage each on its own merit. Chronic pancreatitis on its merit, portal hypertension on its own merit. Portal biliopathy is not such a common thing in cirrhotic livers. So I wonder whether there is a extrahepatic component as well. Because extrahepatic components, they obstruction, they last longer, they obstruct the conventional channels, and then ectopic channels multiply. That's the concept, at least as far as I know. Therefore, I feel this patient merits more evaluation and not so quick intervention. I wonder if the panelists agree. Thank you very much for your attention.
Thank you.
Thank you so much, sir. Now it's time for a lunch break, and we'll resume sharp at 2:30 p.m. for our next session. So I request you to kindly proceed for the lunch, and I request you to be on time when we are back for our next session. Thank you so much.
Follow check.
Hello, sir. Can you hear me? Yeah. No, we just wanted to test the audio. We just wanted to test the audio. Audio. It's okay, sir. It's fine. Yeah. Sir, the video is also visible and it's clear. Yeah, it is good. Yeah, good, sir. Voice is clear. Yes. Yeah, just let me check, sir. Okay, sir. Hello, sir. Yeah. सुनो सर का ना इनॉग्रल के दौरान
इनॉग्रल
speech
फंक्शन
है।
है, एक बार चेक कर लूं मैं अभी। Adjust.
आ रही है वीडियो में आवाज? नहीं आ रही है ना? Still, we are not able to hear the voice from the video. No, no, no. Okay. During the presentation? Okay, sir. Okay, we'll just check. Yeah, I'll just check and confirm it to you, sir. Okay, sir? Yeah. Okay. Okay, sir. Okay. Sure, sir. Sure, we'll do that. We'll do that, sir. Okay. 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 Thank you, sir. Thank you.
Welcome back, all of you. Now it's time for our next session, which is based on abdominal wall reconstruction. And the first topic is abdominal wall anatomy. The GI surgeon should know. Our speakers are G. Parthasarthi, KIMS Hyderabad. I invite him on the dais. Sir, kindly take your seat on the dais. Next, I would like to invite Dr. Abhimanyu Kapoor. Dr. Abhimanyu Kapoor from Regency Hospital, Kanpur. And our chairpersons, sorry, sir, I think I have misspelled the names. It's just Dr. G. Parthasarthi, KIMS Hyderabad. He is the speaker for the session, and the chairperson for the session are with Dr. Vijay Mittal, Big Apollo Patna, Dr. Manoj Kumar, AIMS Patna, Dr. P.K. Jha, IGIMS, and Dr. Senthil G. Kindly take your seat on the stage. I request all of you to kindly come up on the stage. Sir, please.
Can we start the session? So, Dr. G. Parthasarthi, please start.
Yeah. Good afternoon, everybody. I thank the organizers for giving me this opportunity to present on this topic here. And I also thank the organizers for bringing forward the importance of AWR as a part of core GI surgery. Like we know, abdominal reconstruction is no longer just hernia repair. There is a lot of evolution which has happened in the last decade or so. Very rapid evolution in terms of understanding the anatomy of the abdominal wall, development of newer techniques, and management of more and more complex ventral hernias effectively. So as a GI surgeon, it is imperative that we need to catch up with these procedures because most of these hernias we know are incisional. These are created by us, so we better know how to handle them. And just like any new surgical procedure, the learning of the procedure starts with learning of the relevant anatomy. So we can do the presentation in the following topics like the layers of the abdominal wall, muscles of the anterabdominal wall, fascia of the abdominal wall, the origin, the insertion, the direction of fibers, the nerve supply, and the action. Or we can take a more practical approach to this topic because this is a forum of learned GI surgeons. They need no teaching about the basic anatomy of the abdominal wall. What we need to say is there are a lot of new concepts in AWR and a lot of new structures and a lot of new anatomical points have come to the forefront because of the new techniques which have evolved. So we would focus our topic on these newer areas which, if you recollect as an anatomy student or even as a surgical trainee, you wouldn't have even realized that these structures or areas or spaces existed. But these have come to the forefront and they are very pivotal in performing a lot of AWR procedures, like the retrorectus plane, the transversalis fascia. I am sure as a resident, nobody can write more than 5 lines about this structure. Nerves in the pelvis and the so-called TAR plane. But for the sake of completion, I'll quickly go through the muscles of the abdominal wall. The external oblique, which is the outermost flat muscle, it originates from the 5th to 12th rib and then it inserts into the linea alba and also into the inguinal ligament, and it causes rotation and lateral flexion of the trunk. The internal oblique is the muscle next to it. The fibers are oriented perpendicular to the external oblique and it also causes rotation and lateral flexion of the trunk. These are the two flat muscles. The third muscle, which is the most important muscle, is the transverse abdominis muscle. This is a transversely oriented muscle, and in contrast to the first two muscles, the transverse abdominis is very important because it's called the corset of the abdomen. The other muscles cause flexion and rotation of the abdomen. This causes contraction of the abdomen. So you can increase your abdominal force by contraction of the transverse abdominis muscle. And this is how you increase the pressure for coughing, for defecation and straining. The rectus abdominis, this is the muscle. Only one point, it originates from the pubis and goes to the rib. And it has got this tendinous intersections. So coming to the applied anatomy of these flat muscles in AWR, one has to understand that these muscles, when they arise laterally, they are muscular, and as they move medially, they start getting aponeurotic. So why is this point important? Between the anterior axillary line and the mid-clavicle line is a good spot where you are sure to encounter all the three muscles in their muscular part. As you move more medially, they turn aponeurotic. As you go more posteriorly, you may not find all the three muscles. This is important because in AWR, there is a concept of injection of Botox, which is used to paralyze these muscles to increase the pliability of these muscles and to regain domain. And that is the line between which you will inject your Botox injection. So this is applied anatomy of knowing where these muscles are muscular and where they're aponeurotic. So the line has, the Botox injection has to be between the mid-clavicular and the anterior axillary line. The second point is flat muscles are very retractile. Like as the hernia size increases, these muscles can undergo retraction and contraction. So if you see the image on the right to the same patient, you can see how retracted the flat muscles are and how big the hernial defect is. The same patient underwent Botox and pneumoperitoneum. You can see the mark of the pneumoperitoneum catheter inside, and you see how much stretch on these external oblique on the oblique muscles you are able to achieve by pneumoperitoneum. So that itself can give a lot of regain of domain. So these muscles are very stretchable, and you should exploit this while doing complex hernias. The next important point is the plane of the neurovascular bundle. We all know it before. I want to reiterate it now. The nerve bundles in the abdominal wall run between the second and the third muscle, between the internal oblique and transverse abdominis. So that is an important plane. Why it is important? Because these nerves run into the rectus, posterior rectus space, and they take an upward turn and enter the rectus muscles. So they sort of form a barrier for you to laterally extend your incision. So nowadays, the most preferred plane to place a mesh is the sublare or retrorectal plane, where you go posterior to the rectus abdominis and then you place a mesh there. So when you try to do that, you will only get so much space between these green arrows to place your mesh. So if you have a wide rectus muscle, you can expect a wider space. If you have a narrow rectus muscle, you will only get a narrow space. What will restrict your movement laterally is the turning up of these nerves from the posterior sheath into the rectus muscle. So they act like a compound wall which will prevent you from moving laterally. If you by mistake continue laterally, injure these nerves, what you will create is an iatrogenic abdominal wall paralysis, whereby you give rise to more hernias. So it's important to preserve these nerve bundles. Like if you can imagine the linea as the road here and the posterior rectus sheath as the pavement on both sides, these nerves ascend up from the posterior rectus sheath like a row of lamp posts. So if you want to move laterally from the road into the pavement and across, you cannot use this path because you will have to crash through the lamp post. And that is where the concept of TAR comes, where you need to undermine below the posterior rectus sheath, find a plane there, and then proceed laterally if you want to get a wider coverage or if you want to do a component release. The transalis fascia is a structure which has got a lot of confusion and controversy about its nature. It is basically, the consensus it's a condensation of the endoabdominal fascia. It is a very thin, imperceptible fascia in many places, but in regions of natural defects like the inguinal region, like the posterior lumbar region where the lumbar triangles are, or near the diaphragmatic hiatus, the transalis fascia actually becomes thicker and gives support. And this is a thin fascia in the upper part of the abdomen, and as you go down towards the pelvis, the fascia becomes thicker because there is an impending defect coming in the deep inguinal ring. So the fascia becomes thicker and it is bilaminar. Even though there was a controversy about the number of layers of transalis fascia, it is definitely bilaminar, at least in the lower part. And this we can very clearly appreciate in this surgery, where you can see the left hand pulling on the peritoneum doing a tap repair, and you can see the thin peritoneum on the left hand. Anteriorly, you see a layer which is covering an epigastric muscle. Ideally, you should be seeing the epigastric muscles epigastric vessels naked when you pull the peritoneum down, but because there is a good transverse fascia, you can see transverse fascia and the epigastric vessels through that. You can also appreciate that there is a slip of the fascia which descends down onto your flap. So you can have one layer on top and one layer coming medially towards your flap, and that is the bilaminar layer. This one part of the transverse fascia covers the epigastric vessels and the nerves. The second part medially is there because it covers the bladder. So it sort of gives you a natural protection against from the mesh from eroding the bladder and the nerves. So you must exploit this knowledge of the anatomy when you do this surgery. It is not a very constant feature, but you will get to see them if you know that this exists in many patients. So you can see the laterally you can see the transparent peritoneum, medially you can see the transverse fascia, anteriorly again the other layer of transverse fascia, and there you enter the space of Bogros. The second thing which we need to understand is understanding the TAR plane. Like I told you, you cannot extend your retrorectal dissection medially because the neurovascular bundles act as a lamppost. So before venturing into any of these component separation procedures, one has to understand the TAR plane well. This is a large hernia you must have seen. This is a 15 by 12 centimeter defect. The TAR plane is entered by incising the posterior rectus sheath and then going posterior to it, where you have the transverse fascia and the peritoneum below you, and the entire flat muscles of the abdomen are superior to you. So that is the incision which is made there. In the upper part of the abdomen, you will find the posterior rectus sheath is formed by the muscular fibers of the transverse muscle. And as you come down, the transverse abdominis becomes only aponeurotic. So there you can see the muscle layer being cut. In the next image, you will see a white glistening layer which will appear after you cut this muscle, and that is the transverse fascia. And that is the plane you need to get into if you want to proceed further laterally. And this is the incision which is completely made where the posterior rectus sheath medially is cut, all the flat muscles are laterally, and you are going to now undermine under the pavement, and that is the dissection which is started under the pavement, where you are staying on top of the transverse fascia and you are going to do a posterior component separation. Understanding this anatomy is important because this space, I would say, was rather invented only a decade ago. We didn't know that this existed. And you can see that there is hardly any fascia on the cephalic part of the body where you can see bare muscle, but the same fascia will get thicker as you go towards the caudal end, towards the pelvis, like I showed you in the previous video. And this is a completed TAR on one side, where what you are seeing on my hand is the transverse fascia and the peritoneum. You can see the transverse fibers of the transverse abdominis muscle anteriorly, and that is the plane you have created, which will go all the way bloodlessly till the psoas muscle. And this will give you an extra 15 to 20 centimeters of length on the posterior abdominal wall, and that big hernia could be closed without tension like this because you did the posterior component separation. And this is the image where you can see the posterior teeth cut on both sides and the TAR plane is created. So understanding this plane is very important to do a safe TAR, because if you lose the TAR plane and you enter into the dangerous neurovascular bundle or create injuries, you will create more problems than you venture to solve. And the important thing is, these problems are very difficult to handle when you have a mishap with an advanced abdominal wall reconstruction procedure. One important point which people have to understand is, while doing a TAR, there is a small point which you need to be careful on the superior part of it, where the transverse abdominis muscle and the diaphragm, they are in the same plane. So as you keep ascending up, you need to understand that your transverse muscle will very quickly transit into the diaphragmatic fibers. So if you don't realize that and keep cutting that, you will create an iatrogenic diaphragmatic hernia. So how do you know that? You know that by the transverse abdominal muscle has got a lateral, the left to right orientation of the fibers. But as you see here, under the costal margin, you can see the fibers going front to back, from the anterior to posterior. And there is also a small line of fat. That fat is very important. It's a sentinel fat. Normally, you don't see any fat in your TAR plane. If you find that fat, you have to pause and think, because above that comes the diaphragm. So when you see that fat, you slow down, and the diaphragmatic fibers can be very thin. And if you injure the diaphragm, you create a diaphragmatic hernia when you try to treat an abdominal hernia. So those are the diaphragmatic fibers which are getting pushed away, and then you stop your dissection there. What is below that is your TAR plane. What is above is the end of your dissection. The next area which is many times ignored is the nerves of the groin. We all have know these nerves in the inguinal hernia repair from the anterior side. But once we start doing a lot of laparoscopic repairs, we encounter these nerves from a different perspective in the pelvis. Three nerves which are important is the femoral branch of the genitofemoral nerve. One important point one has to remember is we all know about the quadrilateral of pain. What we need to know is all these nerves exit below the iliopubic tract. So what is the white line where the scissor is pointing is the iliopubic tract, and you can see the nerve exiting. What is the meaning of exiting? These nerves are pelvic inside, and then they pierce the muscle and they start going into the parietal wall. So when you're doing a laparoscopic repair, they are at high risk of injury when you catch them in the pelvis. You need to fix tackers when the muscles have already left the pelvis and they've gone into the parietal structure. So the Lakshman Rekha of this is the iliopubic tract. So make sure that there is no tacker or fixation placed below the iliopubic tract. And this is one look at the femoral nerve. This is just to show that these nerves exist. We do not try to see these nerves, but this one way where once you know that these nerves are their location, you are also careful that you don't injure them. Again, having said that, these nerves can be very variable in their number and location and where they cross. A safe point is, even though it is said that they all cross below the iliopubic tract, it is said that study by Reinhold has proven that they can have up to 2 centimeters above the iliopubic tract, the exit can happen. So a safe point of fixing should be much above the iliopubic tract. So this is a nerve which is lateral quadrant nerve of thigh, and that is the iliopubic tract. You can see it below this, and this is where you should be fixing it. The point, the star denotes the iliopubic tract, and you can see a suture which is much above that, and that's a safe point. Another nerve which unlikely to be injured is the obturator nerve, but it's good to know where it comes in your way while doing a tap procedure. So these are various places where you can injure these nerves. In conclusion, newer techniques of AWR is fast evolving. There is a need to relearn the anatomy and focus on erstwhile non-existent planes and structures. And mishaps with newer techniques are very expensive and they're very difficult to salvage. So it's essential before venturing into newer radial procedures, one revisits the anatomy and learns it. This is by no means an exhaustive lecture, but this is just to make you appreciate the fact that there is a need for relearning the anatomy for a GA surgeon before going into AWR. Thank you.
Thank you, sir, for a very a descriptive, a very detailed description of the anatomy, which is so much required for inguinal or abdominal wall hernia repair. This anatomy has been there forever, but it's only in the last 10-15 years that we have started looking at it closely and trying to analyze and understand it for the newer AWR procedures. Thank you very much.
Thank you so much, sir. Now I would like to invite Dr. Abhimanyu Kapoor from Regency Hospital, Kanpur, and the topic is AWR procedures, understanding the acronyms.
We will take the questions at the end of the session so that it can be more composite. Thank you.
Very good afternoon and thank you to the chairpersons. So my topic is acronyms in AWR. Well, those of you who are already into AWR will find most of the terms familiar, but those where the units are not dwelling deep into AWR will find it very amusing, and also sometimes it feels like you are stranded and not able to comprehend. So abbreviations, they are becoming now borderline indecipherable. because both language as well as techniques, they are evolving at a very, very fast pace. We know acron means the tip and onuma means name. So let us take this example, light amplification by stimulated emission of radiation. So we all know we pick the first letter and that becomes the acronym laser. So this is used to save space and avoid repetition and also avoid readers distraction. There are some rules when acronyms are to be used. They are used without periods, like we always read NASA, UN. Then they are supposed to be used in a text when you are using that at least 2 or more times. No point using an acronym if you are going to use it only once. And at the very first mention, make sure that you write the expanded form, right? One of the strongest pitfalls of acronyms is ambiguity. So, just a few days back, my chartered accountant, he hired a new intern and he called me up. Entry in the books is of IESG. I was in the middle of a surgery, so he must have Googled. He said, "Sir, what is this? Iraq and Afghanistan service grant?" I said, no, the other one. I'll talk to you later. Then, since we had acquired a robo, then he thought, oh, it must be some robotic process automation. But ultimately, it dawned upon him that in fact, it was Indian Association of Surgical Gastroenterology. Acronyms can be very, very ambiguous. Other important pitfall is they are sometimes very, very sounding alike. We all have heard homophones. The ones which sound alike may spell or mean different. Homographs where the spelling is the same but they again may spell where they mean different. And homonyms where it is either of the two. Let us take these. TRAM. We all know it as transverse rectus abdominis myocutaneous flap. But TAM is totally different. It is transabdominal retromuscular repair, and then came TAMR. That was transabdominal midline reconstruction. So, to simplify acronyms, let us classify them as to where they are being used. We can use them classification of anatomy of AWR or diseases of AWR. We can use these acronyms to describe several surgical techniques, and we can use these acronyms in some AWR related clinical conditions. The list is actually very, very exhaustive. I have just highlighted the most common ones that we use like ARS, anterior superior leg spine, external oblique, etc. Then surgical techniques. Again, the list is very exhaustive. Common ones, BTX, we use it for Botox. ETEP, we know it is extended totally extraperitoneal. GP, RVS. I will be covering these acronyms in some detail. It is actually a very, very long list. Next is we use prefixes. When you are going to do a procedure, it can be either open or laparoscopic or robotic or hybrid or lab converted to open. We started further complicating these acronyms by adding prefixes. These are the common ones. R denotes robotic, O is open, L is laparoscopic, H denotes hybrid. Well, E, it may either denote extended or enhanced vision or sometimes endoscopic. So you have to be intelligent in that aspect also. Then there are some clinical conditions where the acronyms are also there, like central mesh fracture may be called as CMF. LOD, very famous, loss of domain. So let us, in a very, very brief cover them. PST. Well, it is component separation technique. We all know it was described by Ramirez et al. When we are releasing the anterior components, it becomes ACST. When we are releasing the posterior components, like doing a TAR, it becomes PCST. And TAR is transversus abdominis release. So, when we are repairing such a large hernia endoscopically, then we have to do some sort of a component release. Here, as you can see, we are doing a TAR, a transversus abdominis release. And as you can see, it is with the help of a robotic instrument, so it becomes a R-TAR. Then a very famous acronym is ETEP-RS. The small e, as I said, is extended or enhanced view. The TEP is totally extraperitoneal and RS becomes Rives stopa. So it is sneaking in, fixing up and coming out before the peritoneum even notices. So a small video wherein we just sneak beneath the rectus abdominis, stay above the posterior rectus sheath, do what is called as the crossover. Then we repair the defect and any defect in the ERS, that is the posterior rectus sheath, and just slide in a mesh. This is ETEP-RS. Then we have heard this so often, GPRVS. So that is giant, great or giant prosthetic reinforcement of the visceral sac. It was described by Rinistopa. Here we are actually covering both the myopectineal orifices. So like we are covering each and every hole, and we are reinforcing with the help of sometimes a very large or sometimes even two meshes. Everybody knows IPOM, but if apart from doing IPOM, we are also closing the defect, we call it an IPOM plus. Mylose, a fancy name, not done very often. It is mini or less open sublay operation. So this is again like ETEP, a sublay repair, but here the surgeon goes through the hernia. It is transhernial repair, wherein this special assembly is deployed, and then in the same sublay position, the space is dissected and an adequate mesh is placed. Then parastomal hernias, they are a big point of contention. So PPHR, it is named after the surgeon Polly. So Polly's parastomal hernia repair. As you can see in this, this MRI shows a large hernia which is going through the stomal orifice. We reduce the bowel and then we take down the posterior rectus sheath. In this we also have to do the TAR. Let me revise, that is transversus abdominis release. Then we incise the PPRS component to lateralize the stoma, the bowel that is entering into the stoma, and we place a mesh between the rectus abdominis and the flat muscles, and the floor is formed by the PPRS, that is the posterior rectus sheath peritoneum complex. So this is how this PP Polly's parastomal hernia repair is done. So here we are lateralizing the bowel, closing the defect with the help of continuous suturing with a barbed suture, and then we just close the defect after deploying a polypropylene mesh. Then another common thing that is often used in acronyms is PPP, that is called a preoperative progressive pneumoperitoneum. When the patient is having LOD, loss of domain, then we use PPP. Then another form of a cola which is called a scola. So there we go in the subcutaneous plane, and we, just like in an open surgery where we are placing the mesh over an aponeurosis, we create a subcutaneous base, insufflate it, and then repair it. So this technique is actually good if we are having diastasis of recti along with small hernias. It actually makes the abdominal wall very snug. So that is a scola. Then smart procedure. It is stapled mesh stoma reinforcement technique. Well, we all use this stapler while we are doing stapled hemorrhoidopexy, but this can also be used to reinforce the terfine through which the bowel is to be taken out. So we take out the disc, we catch hold of the anvil, and then deploy the assembly. This assembly incorporates a rim of mesh which is stapled along the turfine. Similar to SMART is what is called as a storm, that is stapled transabdominal ostomy reinforcement with mesh. So here in the tar plane, we incorporate the anvil, take it out, and this is just a variation of the previously described SMART repair. Well, TARM. This technique was innovated actually by one of our Indian colleagues, Dr. Ashwin Masurkar. TARM recently has become very famous, and it is not to be confused with the tram flap. So here we incise the posterior rectus sheath, hence we enter the retrorectus space. Then we create the entire place of sublay mesh, and after taking down the hernia and its contents, we repair the defect. If needed, we reinforce the midline, the diastaticized linea alba, and then we place the mesh, and finally we close this PPRS, that is the peritoneum posterior rectus sheath complex. Then something called as a tape, that is transabdominal but partial extraperitoneal repair, wherein you are just covering the lower part, and on the cranial part you may be using a dual mesh. Then there may be TARP, TRUMP, TAMR. Now this is very interesting, transabdominal midline reconstruction, wherein we can deploy an endolinear stapler to actually staple two posterior rectus sheaths together. So these all innovations have actually ushered in what we call a hernia renaissance that actually has been brought about from something like 2015 onwards. Another is ETEP PP. This is a new kid on the block where we do ETEP, but rather than placing the mesh in the retrorectus space, we place the mesh in the preperitoneal space. It is a beautiful technique. We land onto the posterior rectus sheath, clip below the arcuate line, and from there we travel upwards. The journey takes us into the preperitoneal plane. There is no need to do steps like crossover, no need to divide the PRS, and we can have the best of all the worlds and actually deploy the mesh in the preperitoneal plane. So all the acronyms that I have used, you can take a picture of this. These are the two main seed articles. One is published by Dr. Ramanna, and other one, these will give you a broad overview. So I am an SHO. This is what Sherlock said to his friend Watson in elementary. In my not so humble opinion, acronyms are easier and faster to express. They avoid being overly repetitive and verbose, but there are major risks. One is ambiguity, and in some countries the use of acronyms is illegal in medical records. So there should be a consensus as to which acronym is useful and which ones need to be discarded. Thank you very much.
Thank you very much, Dr. Kapoor, for updating all the names which has come in the hernia, abdominal hernia. So hernia is growing very rapidly, and a lot of new terms, new things are coming gradually. So we'll take question in the last. So I will invite the last speaker of this session, Dr. Vivek Bindal. He will speak on loss of domain in the abdominal wall.
At the outset, I'd like to thank IASG and the organizers for making this session a part of the proceedings and inviting us to speak on these new techniques on abdominal wall reconstruction. I think loss of domain is something which is a very difficult thing in our practice. We, if basically if more than 20% of the abdominal contents are outside the abdominal cavity, and typically it is considered a loss of domain, although there are many definitions which I'll just go through. And when the abdominal cavity loses the capacity to get that bowel back is a problem. So here you can see these kind of patients who have almost the entire bowel inside the hernia sac, and then we calculate the hernia sac volume with the peritoneal cavity volume. What are the difficulties in loss of domain? Basically, you are unable to close the defect. If you put back the entire viscera inside the abdomen, the peritoneal cavity is unable to take that viscera without consequences, which can be respiratory complications and raised intra-abdominal pressure and abdominal compartment syndrome. So in these kind of patients, you see the hernia, and most of these are recurrent hernias. Like this patient had 4 hernia repairs earlier, laparoscopic open, then 40 BMI, and a large hernia, mother of a doctor. And they have been roaming all over. These kind of patients who are not getting reduced under anesthesia also. And one needs to pre-operatively plan, decide what is to be done. This patient, young patient, pharmacist, after augmentation cystoplasty, and he cannot even get up from the bed because his lower abdominal muscles are totally dysfunctional, and to get that thing back in the tummy is a very, very difficult thing. Now, patients having multiple previous operations, like 5 hernia surgeries done, mesh 2 times mesh removal done because of infection. So these are the patients which require a lot of planning and different techniques. And the question comes, why to operate? They are living, and it's a good question which should come to your mind. Whether you want to have a dead solution, a living problem is better. Because the non-compliant abdominal wall leads to a lot of problems. There is reduced intra-abdominal pressure, poor bowel function is there, decreased satiety, obesity because of reduced activity, reduced diaphragmatic exertion because abdominal muscles are also a part of respiration, alteration in spine curvature, lot of backache, inability to move, chronic mesenteric and visceral edema, skin stretching, poor quality of life. So a lot of these patients come to you after knowing that it's a very risky operation, but still they are so much disturbed that they will come and still seek the operation, and many of them sign their wills before coming to your operation theatre. So it's no less than malignancies, and the problem is these non-compliant abdominal walls, very well shown by Dr. Parthasarathy in his talk. You see how the lateral muscles contract when there is loss of linea alba. The lateral muscles would contract and bunch up, and there is loss of elasticity. So Tanaka published this paper in 2010, and thereafter Sabah index and component separation index as well as CT volumetry have been used to objectively measure the loss of domain. And Tanaka divides the hernia sac volume by abdominal cavity volume, and the component separation index is the angle made by the separation. So if you put, you can see in this image, you put an angle from the separated edge of recti to the aorta and then divided by 360. The Sava index is basically the hernia sac volume by the total volume. So either 25% of Tanaka or 20% of Saba is considered loss of domain, although it is a very, very superficial definition, because a lot is decided by the abdominal cavity compliance, the wall compliance, and one can see in the, if the patient is recumbent and the contents are reducing, and you can pinch the skin and the muscles up, it is a good indicator that the loss of domain is not that significant. So morbid obesity with a large hernia defect is a predictor. Very large defects more than 12 centimeter, 15 centimeter, non-reducibility in large hernias, and Tanaka or Saba index of more than 20%. Poorly compliant abdominal wall, recurrent hernias, because of previous meshes, the abdominal wall becomes non-compliant. These are all predictors of loss of domain. And this is a nice paper, by Mike Rosen and group, which basically looks at the different uh, publications on loss of domain and the different sort of definitions. Christie et al. Published the component separation index, which said that more than 0.21 of the angle ratio would mean that a component separation is required. And Petro et al. Said that more than 20% of Tanaka index is loss of domain. Tanaka in his paper said more than 50% is loss of domain and require PPP. Again, very well said by Dr. Abhimanyu Kapoor, LOD and PPP. So, what are the problems during surgery? Difficulty in reduction, adhesiolysis, closure of defect, reconstruction of midline, achieving good mesh overlap, and how to prevent abdominal compartment syndrome. And there are a lot of post-operative problems that can happen, and one needs to prevent these mesh infections and rupture of PRS, intestinal obstruction, and abdominal compartment. So when we look at the intra-abdominal pressure, intra-abdominal hypertension has been graded as grade 1, 2, and 3, and 4, depending on the levels of pressure. Whenever we do an incision hernia repair, on an average, the abdominal pressure increases by around 3 millimeters of mercury after an incision hernia repair. And so when we look at these abdominal compartment syndrome, the IAP is typically in grade 2 or grade 3, that is more than 50 millimeters of mercury. So, it is not similar to the trauma or critical IAP, the ACS syndromes which we are seeing. So they are called the quaternary abdominal compartment syndrome, not the primary, secondary, or tertiary, which are seen in other clinical situations. So here the bowel is okay, there is no translocation, so you have a bigger shock absorber there. So a practical thing is to look out for pulmonary plateau pressures. When you start an incision hernia case, you are suspecting loss of domain, you ask your anesthetist to look at the pulmonary plateau and the pulmonary peak pressures. And then at the end, at the closure, if your rise in pulmonary plateau pressures is more than 6 millimeters of mercury, that significantly denotes a loss of domain, abdominal compartment syndrome potentially, and that patient should be possibly kept on ventilation for 24 to 48 hours so that the muscle relaxation continues and the abdominal cavity volume increases. So this is an important thing. It is more useful than direct measurement of intra-abdominal pressure. So when a patient comes with loss of domain, what is to be done? We need to pre-optimize. They should lose weight. Botox is a good adjunct. Progressive pneumoperitoneum preoperatively again is a good thing which can be used. Component separation will most probably be used. Visceral resection is the last resort in some cases, and intraoperative facial traction is the new kid on the block. So these are the strategies. Coming to the weight loss, dietary therapy or meal replacement are the standard weight loss things. Now we have very potent medications, GLP-1 analogs, oral and injectable semaglutide as well as dulaglutide, which can be used. Endoscopic balloon is something which patients who are not willing for bariatric or other therapies, they can be put on endoscopic balloon with GLP-1 and they can lose significant weight. And bariatric surgery definitely is an option which can be done, and the hernia repair can be done once the patient loses weight. But a lot of these patients don't want to undergo other surgery. There is a very good paper by Archana Ramaswamy in Surgical Clinics of North America, those of you who want to read this. Then there are other preoperative essentials. Those who are smokers, they have chronic hypoxia. The collagen formation is not good. They have vitamin C deficiency. So they should stop smoking for at least 4 weeks, and they should not smoke in post-operative period. The diabetes should be well controlled, at least less than 8% HbA1c, better to have less than 7%. You should evaluate for chronic liver disease. Many of these patients have underlying cirrhosis. Reality index is very important. Now with age, there is muscle loss, and that is an important thing to be looked into. Chest optimization, give these patients incentive spirometer for a month to optimize their chest, look at the COPD if there is any, and nutritional assessment. So build them up, give them proteins, give them high protein diet, give them some assess them nutritionally and make their nutritional status better. Then if you feel that the closure will be a problem, botulinum toxin A is an important adjunct. It blocks the presynaptic release of neurotransmitters at the neurovascular junction, and basically it causes reversible paralysis of muscles, and we use it 3 to 4 weeks before the surgery. This is the Botox that we use. It comes in 50, 100, 300 units, and it's an expensive medication. We use 300 units of Botox, 150 on each side of abdominal wall, diluted in saline, and we inject at 3 points on each side. So in the mid axillary line, we will inject it just below the costal margin, just above the iliac crest, and in between these two. And at each point, we inject it into internal oblique, transversus abdominis, as well as external oblique. So all three muscles are injected. And TA, whether to inject or not, is because if you are going to do a transversus abdominis release, injecting into TA is still debatable, but most people would do it. This is how it is done under ultrasound guidance. It is just done a month before. It's a simple outpatient procedure. Takes around half an hour, and in under aseptic precautions, we'll just make the patient lateral and put the needle in and inject it. So so here you see the 3 points which I was speaking about. And after Botox is injected, the patient is sent back home with chest optimization. So these are the kind of patients. This is the preoperative scan with large loss of domain. You can see the entire small bowel is out. And so after Botox, there is some release and the decrease in the defect size. Then one can use progressive pneumoperitoneum. It was described in 1940s, although it is something which is having its own pitfalls, because I'll talk about that. But it improves the tolerance to intra-abdominal pressure. So you can use a percutaneous technique, or you can use a laparoscopy followed by catheter insertion. We initially instill 1 liter to 1.5 liters of air, and daily installation of around a liter of air is done. The end point of installation of air is the discomfort or pain by the patient. We use an abdominal binder to prevent the entire air going into the hernia sac, and they are put on low molecular weight heparin to prevent DVT. And they are totally on respiratory exercises, and we do it around 3 to 4 weeks after Botox. So this is a diagnostic laparoscopy from the Palmers that gives us a sneak peek. We always do it under anesthesia in OT. And then you look at the hernia also. We put in a Ryle's tube, and this is how it is strapped. And then this is how the three-way valve is attached, and the air is pushed into the peritoneal cavity. And this is in the lying position, and then in the sitting position it becomes better, because in the lying position patient can tolerate more air, but when they sit up they have sudden pain. So it is better to make the patient sit and put it so that your endpoint better. So post PPP you can see that there is some expansion, and then intraoperatively there are a lot of other things. We have to preserve the sac, we have to develop peritoneal flaps, we have to plan for component separation. Visceral resection is the last resort. We don't like it. PRS closure alternatives, you should have certain, there are meshes like vicryl mesh or a bioabsorbable mesh. Facial traction is an important thing, and skin closure, abdominoplasty, and plastic surgeons also have a role, and you can have a wound vac therapy. So, Ratio-10 system, this is a hernia system which is basically applied on the abdominal wall. The sutures, this is Girion Lil, founded the Ratio-10s, and we basically, put sutures on the sides of the edge. 6 sutures on each side, there is a Ratio-10s carrier, and this is the suture plate. So we apply these sutures here, and it will these sutures by 14 to 18 kilograms of pressure. So it leads to elongation of lateral muscles and pulling of pressure. And this is 1 year after the abdominal wall reconstruction using Ratio-10s in a loss of domain patient. You can see how good is the cosmetic and the functional result. So we always had a concern about the lateral muscles getting pulled with so much of pressure leading to fracture or some sort of lateral problems, but we have not seen it in practice. And actually it has allowed us to do loss of domain cases by laparoscopy. So, even in laparoscopic cases, we have been using Ratio-10s and facial traction, and now in robotic cases also. This is how it would look like finally. I think in the interest of time, I'll just conclude by saying that loss of domain requires good knowledge and skills of abdominal wall reconstruction techniques. Preoperative optimization and decision making is the key to success, not the intraoperative techniques. So preoperatively, if you can plan well and optimize the patient well, that is the main thing. Intraoperative, the buttocks, separation, peritoneal flap, facial traction, 5 main adjuncts, I would say, for loss of domain. Thank you so much for your kind attention.
Thank you, Dr. Binder. Very descriptive about the loss of domain and its management and complications. No, open for the questions.
Thank you.
Can I kick off the questions by asking you, Dr. Bindal, you deal with a lot of loss of domain cases. How do you diagnose and how do you monitor your patients post-operatively for compartment syndrome?
Yes, sir. So I think very nice question. First of all, we look intraoperatively at the rise in the pulmonary plateau pressures. That is an important thing. If the rise in pulmonary plateau pressure is more than 6, then we will be, concerned about the post-op abdominal compartment syndrome. Post-operatively, hemodynamics are an important measure of their abdominal pressures. How well they are doing in terms of their pulse rate, tachycardia is an important indicator. And we also measure the intra-abdominal pressure through the Foley's catheter using the urinary bladder as one of the measures. So, although we have seen that clinical parameters along with the central venous pressure and is more of an important thing along with the ileus which the patients have and the judgment, the abdominal girth as well as your abdominal examination will let you know a lot of stuff about it.
Dr. Bindal, Hesio-10 hernia system is better than component separations or not?
So fascia-10s, I think both have their own roles. So component separation, if you are doing a posterior component separation, it is more to provide a posterior cover. And fascia-10s is more for anterior defect closure. So it can possibly replace the anterior component separation. There have been a lot of problems with anterior component separation. All of us know the skin flap necrosis and the wound infection rate is very high. With fascia-10s, that need of anterior component separation is mostly gone.
Dr. Bindal, sir, what is your policy regarding if you have done a very large hernia, done component separation and posterior component separation? So what is your policy about extubation of the patient postoperatively? You will keep the tube overnight and see all the parameters tomorrow and then extubate, or you will try to extubate just after the surgery?
Right. So I think this is a part of our planning, and we basically plan these patients for at least 2 to 3 months. And we will optimize them, and we try to optimize them to a level where we can extubate them on table. So our endeavor is always to try to optimize the patient to a level that they can be extubated. But then intraoperatively, depending on how the surgery has gone and how the pulmonary peak pressures are behaving, we may keep them on overnight ventilation as an elective thing. But most of our patients get extubated on the same day of surgery. And I think again, so that what sir was asking, a preoperative planning in these patients is of utmost importance so that you don't have to have all these post-operative bad outcomes.
Any questions from the floor?
Can I ask one question?
Yes.
Yes. Good afternoon, sir. I'm Dr. Vikram from AIMS Bhubaneswar. I have a question regarding the progressive pre-operative pneumoperitoneum. That how do you deal with the air getting into the hernia sac and the sac getting enlarged along with the abdominal cavity also?
Yeah, very good question. In fact, that's why we use abdominal binder. So we compress the sac with an abdominal belt so that the air doesn't go into the into the hernia sac, but it goes onto the diaphragm above the liver and the spleen and just pushes it up. So basically, still a lot of air will go into the hernia sac, whatever you may do.
Patient also has a loss of domain, so you cannot apply the binder forcibly.
Yeah, absolutely. So there will definitely be a significant portion of air going into the sac, and but still you want to just reduce, and that's why it's not very much used. So we use it maybe in less than 10% of our LOD cases. Second thing is they tend to do, if you put the abdominal binder, they tend to develop emphysema. It tends to seep in. You can develop subcutaneous emphysema, and that could be another endpoint of these patients.
Okay. Thank you.
Hello, sir.
Yes, sir.
This is a completely different question. Do you suggest a standard textbook on abdominal wall reconstruction? Is there a standard textbook?
So there are very good textbooks by Michael Rosen. Michael Rosen has an atlas of abdominal wall reconstruction, and they recently came up with the second volume. And other textbook on abdominal wall reconstruction is by Yuri Novitsky. So they are the two good textbooks on abdominal wall reconstruction: Michael Rosen and Yuri Novitsky. Thank you.
Thank you, Dr. Bindal. Thank you, Dr. Parthasarathy and Dr. Kapoor for a very engaging session. Thank you.
Thank you, sir. Now we have a case-based panel discussion on abdominal wall reconstruction. Our topic is AWR tips and tricks. I invite the panelists for this session, Dr. Abhimanyu Kapoor, Dr. Soumya Kulhar, and Dr. G. Parthasarathy to kindly take their seats on the dais. And I once again invite Dr. Vivek Bindal to kindly proceed with this session.
All right, so I think we have an interesting discussion, and we'll try to make it more interactive. So case-based discussion is always good, and we have very good panel with us. So all the audience there, all of you should consider yourselves panelists, and please come over to mic and comment in between. So don't wait for the end of the panel for Q&A. Just comment. So we have a wonderful panel with us. This is Abhimanyu Kapoor, a wonderful surgeon, Parthasarathy and Soumya. So having worked with all of them at various places, I think it's a pleasure to be here. So okay, we'll start with small hernias and move to more complex situations. These are simpler hernias like umbilical hernia or epigastric hernia. So primary ventral hernia. I'll start with Dr. Abhishek. This is a patient who came to you. What you would do? What is your preferred approach? A 3 centimeter umbilical hernia.
Yes, Dr. Bindal. So these are very common situations. Patients sometimes may be asymptomatic or having some vague symptoms. The way I approach them is in a holistic point of view, we should start from their overall comorbidity profile.
Please continue. I think
and as I recall the picture that was shown, the patient was having a slightly seemingly a higher BMI, must be around his 30s, and he seems to be having a umbilical hernia. Yeah. So such a patient, I would definitely first promote him to take care of his comorbidities, to start reducing weight, to optimize him, and then we should embark upon offering him a repair.
What procedure would you do?
In such cases, I would like to do I can offer him either a TAPP
ventral TAPP, which can be laparoscopic.
So you will do minimally invasive repair or open repair?
I would do a minimally invasive repair.
TAPP ventral?
Yes.
Or
ETAPP, and that depends whether he wants to go for a robotic or a laparoscopic.
So laparoscopic TAPP, ETAPP robotic.
Laparoscopic TAPP, laparoscopic ETAPP, or robotic TAPP.
He is taking your exam because he spoke about the acronyms, so he's not throwing away those acronyms at you. So, this is basically what Dr. Abhimanyu is saying, that he's going to do a pre-peritoneal minimally invasive repair. Don't go into that ETAP, PP and all that stuff, but a pre-peritoneal minimally invasive repair is his choice. Dr. Partha.
My way to approach this patient is, first thing is, does he need a surgery or?
Yeah, he needs a surgery. So he's symptomatic for this.
So I think I would go with an IPOM. It's a simple workhorse fix for all these small umbilical hernias.
IPOM. Any case for open repairs in umbilicals in your practice?
Most of them, when I do, it's because of anesthetic considerations rather than.
Soumya?
If the skin condition on that is very bad and it needs removal, then maybe. But in my practice, generally not. I would go with an IPOM or a tap ventral. But open is definitely an option for small umbilicals.
Great. So, how many of you would do an open repair for these umbilical hernias? Please raise your hands in the audience. How many would do an laparoscopic IPOM? And anyone for laparoscopic pre-peritoneal repair? Okay, so most hands for IPOM. So but I think so. IPOM has been the leading repair for these. Can you have my laptop on the screen? Audiovisual people. Can you have my laptop on the screen rather than your laptop? So these are the various options which are there. And you can, but practically speaking, IPOM is the most commonly done minimally invasive operation for these. Although it has challenges, it has its own share of problems of intraperitoneal mesh and tax and a lot of pain. And that is why pre-peritoneal repairs are taking, kind of a significant chunk of these repairs. Difficult to do, better done with robotic, easier done with robotic. So now this patient has a 5 cm primary hernia. So the hernia size increases. It is now W2 by EHS classification. Soumya, what would you do for these larger hernias?
Either an ETAP-RS or maybe a robotic. Which mostly will be retrorectus.
Retrorectus repair.
Yes, because it's a 5 cm hernia, little obese patient. Definitely an IPOM plus is not a good idea. Open is not again a good idea. This is definitely manageable, minimally invasive. So, according to my practice right now, robotic, but definitely ETAP-RS is also possible.
Any difference from the panel?
Well, in such cases, we are getting a picture of the abdominal wall. Here, I would also be interested in looking at the images. Because in hernia, the neck size or the defect size may be small, and what seems on the outside may be very big.
Right.
So the defect size will be very relevant. Second important thing is, in such cases, the width of the rectus abdominis muscle on either side. So as to say whether I will be able to deploy a sublime mesh without the need of doing any sort of a component release or not. So they would be the deciding factors. And again, as I am a strong proponent of not placing the mesh inside the peritoneal cavity, I would prefer to do a E-tap in such patient.
Okay. Would the payer decide your choice? Would the insurance company or the payer of the patient decide your choice? If the patient is CGHS beneficiary and they are only getting 10,000 rupee mesh, and you wanted to do an IPOM, but then how would you do it? Or what would you do? Does it affect your choice in your practice, Dr. Partha?
If the case is something like the first case where you showed, where you have multiple correct options, it wouldn't matter.
Yeah.
I would choose the next best one, which is economically fine. As the hernia size increases, my level of compromising on the surgical choice will come down, and I will stick to the best procedure for that hernia.
I think, yeah, truthfully said, so a lot of payer issues are affecting our practice as hernia surgeons. And, as the complexity increases, most of the hernia surgeons would not want to be dictated. But I think it's an important thing. So primary ventral with divarication, like these young females, Dr. Soumya, young females having a lot of divarication issue. Would you go onlay, scola, or would you go retrorectus, or would you go open, or would you not do anything?
Parity first. We need to know if she's completed her family.
Yeah.
If she's completed her family, you can offer definitive repair. If not, and if she's asymptomatic, most of them are asymptomatic with more of a dragging sensation and a visual thing which they say that the abdomen is sagging. In such patients, you should wait for the parity to be completed. If the family is complete, you can first see what is bothering her more. If it's and how the abdomen is. If the laxity is not too much, it's more of the divarication component which is bothering, then you can offer any one of the proponents, like doing either a robotic tar rope or an ETEP RS. You will have to strengthen the entire, after application of the linea, you will have to strengthen the entire area with a mesh. So the mesh has to be long, covering the entire retrorectus area. But suppose that she feels that the abdomen pannus is too much, it's a very saggy abdomen, you should offer them abdominoplasty basically. That I have seen in my patients gives a lot of immense satisfaction, I would say, because post-pregnancy the abdomen is so lax that they're very worried about that, and that itself causes a lot of back pain, pelvic dysfunction. So sometimes abdominoplasty, and I do that along with the plastic surgeon, really helps.
Yeah, I think it's a functional problem also, very rightly said. They have back pain, they have inability to work, and after family is complete, either you can do an open abdominoplasty, or you could do a reef stopa repair, a retrorectus reef stopa with a total repair of the lineal by. Yes, Dr. Partha.
When I have patients with a lot of divarication and a very small umbilical hernia, I will be very reluctant to do an ETEP in them, because by nature of the problem, the linea is very wide. A wider linea is bad for ETEP because you will end up with a component separation for that. So you have a lady who is multiparous, has a thinned out linea, retracted rectus muscle. My choice would be a laparoscopic plication of the divarication with an added mesh for the small hernia. I would not prefer a retrorectal repair in such patients.
Very important point. I think what Dr. Partha is saying, that the linea alba is widened to 9-10 centimeters. Very difficult to go across the linea without damaging peritoneum. So one should be knowing their own limitations. There are surgeons who would be able to do that. Doing the component separation is not something which you should end up in these patients. So if in your hands you think that you're going to end up in component separation, it is better to not do an ETEP RS. But if you think you can complete an ETEP RS without component separation, you can save peritoneum, you can use a robotic system for that, or you can save it laparoscopically, then an ETEP RS is a good choice which gives good outcome. Dr. Abhimanyu.
Well, sir, in this particular case, one thing that actually should be absolutely avoided is doing an IPOM. I have come across several patients who are having very wide diastasis, lax abdomens, and someone would just patch them up. So that does not give any sort of a satisfaction or robustness to the abdominal wall. So that perhaps should also be an important take home for the audience.
Absolutely, I think because most of these patients think that this is a hernia. So although hernia is on the belly button, but they would think that all their problems is because of that belly button hernia, and surgeon is going to repair that. And absolutely right, it's not going to give any benefit, but it's going to make that disease more worse. So instead of a painless swelling, now she will have a painful swelling.
Okay, I would just like to add that divarication has to be treated definitely. Such a large divarication, it causes a lot of functional disturbances in the abdomen. So we cannot not address it.
It's a field defect. If you don't address the divarication, the patient is going to develop a recurrence from somewhere else. Plus, it is a field defect. So, and this understanding has changed over last many years. Earlier, divarication was not treated. Now it has to be treated with umbilical hernia. Okay, so this is some, you can do it lap, TPP or TARUP. So what you do in a pre-peritoneal repair is you reduce the contents, create a peritoneal flap, and then strengthen the abdominal wall, reconstruct it with sutures, and then put in a mesh. So this pre-peritoneal repair basically would allow you to put the mesh outside the peritoneal cavity. There is no fixation or minimal fixation. So this is how the peritoneal flap would look like. There is no violation of the retrorectal space. So the Reeves Topper space is left, and you are able to repair these small defects in a very good way, and also the divarication. And this is how the port position looks like. Normally in laparoscopy we would sit and operate. In robotic we would always, anyways we'll sit and operate. So I think, and this is how the mesh is placed. Now there are midline incisional hernias. These incisional hernias, like divarication, are field defects. So you will see Swiss cheese defects in all these incisions, and most of these incisional hernia needs to be strengthened throughout. From the entire incision needs to be taken care of. So this is a large infraumbilical hernia, which is M345W3, and this is post-radical hysterectomy, post-open radical hysterectomy. What would you do for this, Dr. Bhimanyu? What's your choice for this patient?
For the management, I'll start with imaging.
Yeah.
I'll not be repetitive in saying preoperative optimization, but I would like to get an imaging of this patient.
Right.
Once through those scans, if it comes to therapeutic options, I would definitely like to offer a minimal access technique, which may be laparoscopic or robotic, and I would harp on either a TARM or an ETAP, along with, if needed, a posterior component separation.
Right. So retrorectus repair, minimally invasive, either transabdominal or extraperitoneal, with or without posterior component separation. So I think that provides a very good functional outcome. So this patient underwent an ETAP RS, laparoscopic, and this is how the functional outcome is. If you are able to close the defects, and the good thing is that infraumbilically there is a lot of preperitoneal fat, which would lead to you'll be able to close the defect without a component separation. So whenever you are looking at infraumbilical hernias, you are usually better off. So this is an upper midline incisional hernia post laparotomy. 2 laparotomies done, and now she has a big incisional hernia with divarication, you can see. So Dr. Soumya, what would you do for this lady?
Again, I need a CT for this first. So all these hernias which we have seen in the last probably 3-4 scenarios, all of them should require a preoperative CT for us to plan how the muscles are, how wide the defect actually is, and how are the lateral muscles. Because these kind of big midline hernias, so that you don't have a recurrence, you have to do a good repair. It's how you would do a biliary anastomosis. The first chance that you get to repair such a thing should be the best chance that you have. The more recurrence will happen, the more complications you'll end up with. And so this patient, I would say, would need a bilateral TAR. You can go either way. You can go either open, minimal access, robotic, in a whichever way possible. I would say in my hands, it would be robotic maybe. And essentially looks like a bilateral TAR, but I would wait for the CT if you have one.
So so I think very important thing that you should have imaging, and on CT scan it's a 10 centimeter wide defect. So what sort of robotic approach or minimally invasive approach you would use in this?
I would do transabdominal retromuscular and then along with TAR. So I generally do 6 port, 3 lateral on each side.
Right. So 3 lateral ports on each side, that is the transabdominal approach. Okay, alright. So the other approach which can be used is ETAP and inferior crossover. So if you have an upper midline hernia, you can do an inferior crossover, and this is this lady after ETAP, inferior crossover, and even lateral TAR. And yeah, so I think open repair is also a good option, and one needs to understand in their own hand as to what would be good. Now,
Dr. Vinder, in the previous case, one message is what we should not do is an IPOM, what we should not do is an onlay repair.
yeah. I think that is an important thing because we are talking of sublay repairs, retroactive repairs. They are much better. They give much better outcomes. You should not do an intraperitoneal or an only repair. And we still get so many patients treated at very good centers with only repairs and recurrences. So this is a 35-year-old female, open incisional mesh hernioplasty. And this is the scan. So this has, Dr. Abhimanyu Kapoor's patient. So this lady had a cesarean and open incisional mesh hernioplasty. I'll run the scan again, and question goes to Dr. Parthasarthi as to what would be his approach. What can you see on the scan? Can you just describe the scan for the audience? Are you able to see it on the console there?
Yes. She obviously has a recurrence of hernia in the lower part of the incision, and there is some moment of infraumbilical divarication also.
Right.
And
can you see something here like
this? That is more. There is an undulant with a wavy structure is there, which is most probably the mesh which has got pushed out of the hernia.
Right. Yeah, so very important. This is the mesh. This is the previous mesh which has been placed, and this wavy structure is the pushed out mesh, and then you can see the bowel loops here, which are totally jumbled up and adhered to the mesh. Here. So yeah.
See, there you have to develop a knack of actually identifying the meshes on a CT. There will be some meshes which just can't be seen at all. They are the ones which are the lightweight proline meshes. Then there will be meshes which cannot be directly visualized, but there will be indirect cues as to trying to identify the location. So there will be some sort of a fibrous thickening in the tissues adjoining them, some waviness, and some loss in the normal thickness. But some meshes, especially the thick EPTFE meshes, they are the ones which can actually be visualized on a CT scan. In this particular case, we can actually see a mesh which has got blown up into the defect, and we can see the bowel that is nicely adherent to the mesh. So this is a case where we should be prepared to do some meticulous bowel adhesionolysis from the mesh.
Right. So I think all of us who go into abdominal wall reconstruction deal with a lot of recurrent hernias. In fact, more than 50% of our patients have had a mesh repair earlier. And one needs to see where the mesh is placed, what plane the mesh is in. And on CT scan, you basically see the mesh plate, the mesh along with the fibrosis and not the mesh itself. So many times, if you use even an absorbable mesh, you will see those mesh plates. And all of these are mesh lined hernias. So when would you remove this mesh, Dr. Soumya? You have a recurrent hernia. In what cases would you remove the mesh in your repair?
In this particular case,
What is in your practice? In what circumstances would you
only
remove
if
the
it's
mesh?
bothering with my repair. Not all meshes have to be removed. Sometimes you have to take the meshes down along with your flap, use part of it as your flap. Sometimes you have to remove it. In infections, you definitely have to remove it. But most of the times, is when they are very much to the intestine, you have to make it a point that you try to keep the mesh maybe on the bowel a little bit and bring it down. Looks like you've done the
So
same.
this is a post-IPOM. No, this is a separate, different case, but this is a post-IPOM recurrence. You can see the tags. We are going sublay, and this is the mesh plate. So in a post-IPOM recurrence, when would you remove? So
in an IPOM, the mesh will come down along with the flap.
along with the flap. But if the patient has history of obstruction,
then you'll have to do
then you'll have to do the adhesiolysis and remove the mesh. So if the patient has bowel symptoms, obstruction, then you will, or mesh pain, mesh related pain, then you'll have to take out the mesh. Otherwise, you can leave these meshes in. You don't have to remove all the meshes which are there. And so, what do you do for these post-IPOM recurrences, Dr. Parthasarthi? Yeah, very common scenario if you deal with recurrent hernias.
Post-IPOM patients, my decision making pretty much will be same like a primary ventral hernia. One thing I'd be prepared is I will expect less pliability of the posterior rectus sheath when I try to close it. I'll be more prepared to go for a unilateral or a bilateral TAR. Despite it being a small defect, you might have to end up doing a TAR because the pliability of the midline will be affected because of the fibrosis and the mesh. So that is one thing which I'll plan in advance. I will not make any attempt to remove the IPOM mesh while doing if I'm doing a minimally invasive approach like an ETEP. I will not make an unless, like you said, if the bowel is densely adherent, my attempt will only be to free the bowel from the mesh and not to remove the mesh from the body.
So yeah, I think important points. One of the things is that if it is an intraperitoneal mesh, now you go sublay, you are a plane above the mesh, you go above the tax, above the mesh plates, and then you place in a mesh. This is an important thing, and you prevent dealing with these kind of bowel adhesions. If you go transabdominal in these patients, you will have to first lyse the adhesions of the mesh with the bowel and then go up. But still in ETEP, these kind of bowel adhesions will come in, and they can be very well dealt with robotic techniques if done well. So I think post-IPOM recurrences are an important part. So this is a patient with appendicectomy, a hysterectomy, then an IPOM with a 20 by 25 centimeter mesh, and now she has a large recurrence. She came to us many years ago. Now, and on CT scan, she has a disruption of linea seminolaris. This is 10 centimeter wide hernia defect on the right side with the medial margin reaching up to midline. Dr. Abhimanyu, what would you do in your practice?
Imaging again very prudent in this case.
That's why I told you the report. Yeah.
Yes, and so in this I'll have to do a right-sided TAR, enter into the prepatternal plane.
So minimally invasive, MIS.
Yeah.
Okay. So you will go MIS, ETEP, leave STOPA,
and TAR.
And TAR. Any difference on the panel? Okay. So how many of people here in the hall would attempt these kind of cases minimally invasive? Just raise your hands, please. How many would prefer to do them open? Okay. How many would refer?
I would do open.
Okay. Great. So I think many people on each side, but yeah, minimally invasive is a good option here because the other part of abdomen is virgin. This is post robotic ETEP TAR, and this was done 5 years ago. Still, the patient is doing well. She came, but now I think we should close because the cases will continue. The time is over. Yeah. So, any questions from the audience to the? Now we have 10 minutes of Q&A. Okay. So we have 10 minutes of Q&A. So, any questions from the audience to the panelists to us? Please come forward. You can ask a case scenario. You can ask your practice, as in dental hernias are very common, sir.
Any suggestions on when to repair ventral hernia? Go for a surgery in ventral hernia.
Yeah. So
Without
I think
actual defect. I mean, just divarication.
Oh, just divarication.
Yeah. When would you repair a divarication?
No hernia divarication. Soumya, would you want to answer?
That case, we have to do a lot of study on the abdominal wall, as in understand with the detailed history how it's actually affecting the patient. Many men do tolerate a lot of divarication without having any problem, but some of them have very bad backache, especially in female postpartum. There'll be a lot of pelvic dysfunction. So, based on how bad it is, functionality, we can first put them a lot on rehabilitation and physiotherapy to improve the divarication. And then once it's not improving, or if it's improved and the muscles have improved to a certain way, after due discussion, it can be taken ahead. There is no time per se, I would say, that can be recommended that right away we have to repair. Without a hernia, divarication repair will depend a lot on the functional status of the abdomen.
The most patients that we come across would be multiparous women, isn't it? With divarication and obviously an image problem
Yes.
and also functional problem.
Yeah.
So it's very difficult to decide when to intervene.
Yes, sir. So if the parity is completed, I would definitely say putting them on a good rehab program will be very important. In fact, we have a dedicated program on abdominal wall rehab where one of our physiotherapists works very well with them, teaches them how to do it. We reassess after 6 months and then we decide about surgery.
I think very important, very contentious issue. And divarication as such without hernia is something which we have not been operating. But now with the current understanding, we know that in a subset of these patients, they would benefit with repairs. And we need to identify that subset and offer repairs in those. Dr. Partha.
The dictum I follow on practices, the patient comes with asymptomatic divarication, thinking that it's a hernia. There is no symptom, and they are not symptomatic or they're not worried about the cosmetic effect of it. We leave them alone. If they ask us if I do good exercise and diet, will this go away? I tell them no, it won't go away. If they have symptomatic divarication and in terms of they are worried about it cosmetically or they have some sort of dragging pain, I give them an option that either they can do exercise and that can strengthen the back and decrease the symptoms, or they can go for a surgery. If they ask if the divarication can lead to a hernia, I tell yes. But if they ask does fixing necessary to prevent a hernia, I tell them it's no. I hope it's this is a set of questions which we face every day, and I have sort of thought over and have ready-made answers for these things. This is a working thing which I think is fairly based on good evidence and logic.
There's a very practical thing of there's an app called ACQHC, Abdominal Core Health Quality Collaboration. It's a free application. You can download it on your mobile and you can ask your patients to download it. It has all the exercises listed based on the symptoms, and if the patient has a hernia repair, they can do those exercises and then they can maintain their core health. So I think that's something which we have been using in our practice and very, very replicable for different practices. Abdominal core health quality collaboration, sir. Now it is working. Now it is working.
The hernial just like the one where the mesh is stuck, there is room for a hybrid procedure. You know, I mean, I haven't discussed the hybrid part. When would you really consider this very small skin incision and then put a mesh from?
Very, very, I think very valid point, and hybrid procedures have a big role in all these hernias. The patient already has a scar. Many times that skin part is thin and that has ulcers also. So doing a part of it minimally invasive, I actually had few slides on hybrid repair, and if they can just project the laptop, I can show you one, and you can just revise the scar. You can those adhesive part on that CT where we saw the bowel was bunched up with the mesh. You can safely lyse it and then put in the mesh. So you can do some dissection minimally invasive. Also in the learning curve, hybrid repairs would always have a role till the time the surgeon is competent. And if you can project the laptop once more, please. Audiovisual people. So, do you do hybrid repairs, Dr. Bhimanyu?
Yes, definitely, lots of them, and they are very handy, especially in the scenarios you described. When the scar is very ugly, stretched out, then we will get the opportunity of excising it, doing a safe adhesionolysis, sometimes even closing the PPRS, and then we can re-enter, place the mesh with laparoscopic approach and finish the procedure.
Right. So typically when we do a hybrid, what we would do is we would open it and then we will do everything open. So meaning you dissect the plane. If you have to do a tar, you do the tar, and then you open that part and then you close the PRS, ARS, put in the mesh through that incision only. So You don't have to go back MIS. So I think also hybrid IPOM plus, which we used to do earlier, you close the defect from outside and then you put in an intraperitoneal mesh for a larger coverage. That is something which we used to do before we started ETEPS. So hybrid procedures have a good role.
Even with these advanced surgeries, I would say hybrid approach is a very prudent approach in many cases. And it saves you a lot of time and helps you do safe adhesolysis at times as long as, and also remove the unnecessary things.
And in fact, if you don't do a hybrid, many times patient will say that you have given me such an ugly thing. Now it's all ugly. The skin is not gone. It's the hernia is there. So that expectation part of the patient also needs to be discussed in preoperative phase. If they want the skin to be excised, you have to plan it that ways. And you have to tell them that if you are going to do MIS, then the skin scar will remain as it is. So
excuse me.
Yes,
sir, I have a question to the panelists. Regarding 5 centimeters defect hernias, panelists agreed on ETEP-RS. My question is, in how many cases do you actually end up doing a TAR while doing the ETEP-RS? So is it worth doing a TAR or adding a TAR to that 4 to 5 centimeters ventral hernia?
Yeah, I think see for a please.
Earlier on in the learning curves, the surgeons would, very hurriedly resort to TAR. But now there are so many TAR salvage options in especially this much of a width hernia. We can utilize the peritoneum of the sac and avoid a TAR. We can desufflate the abdomen and still manage without the need of a TAR. So there are so many TAR salvage options. One should go deeper and try to utilize them also.
Yeah, I think if you are a good, if you have good experience, up to 8 centimeter hernias can be dealt with by Reeve-Stopper technique only. So you can save a lot of peritoneum, you can save a lot of sac, and you don't need a TAR. In fact, we audited our own cases over last many years, and initially we were doing TARs for more than 6 centimeters, and now we are doing it for more than 8. And in robotic, we are actually able to do a Reeve-Stopper for up to 12 centimeter hernias. With these more preservation of peritoneum, especially with robotics platforms, you can deal with W3 hernias, as we call it in EHS, with just Reeve-Stopper without a TAR. And you are absolutely right. We should not be doing a TAR for a primary 5 centimeter ventral. If you think so, then you can do an IPOM plus. That's a good choice.
Sir, my second question, sir. Large ventral hernias, should the approach be midline and do a TAR and approach the ventral hernias, or you approach large ventral hernias through the same ventral scar?
What we're like midline hernia or a lateral hernia?
Lateral hernia, sorry.
Lateral hernia. So lateral hernias are a totally different ball game altogether. It would depend. You can go through the midline and do the TAR and approach them, or if you go through the lateral, if you are doing a retroactus repair, it is easier to go through midline and then go laterally rather than going through that scar. And that's where role of hybrid approach comes in. You deal with the midline Reeve-Stopper space with minimally invasive technique, and then you can revise that scar laterally to access the lateral space. If you get what I'm saying, if you go fully open, then you have to do a midline linea alba incision and then go laterally, do a TAR, and then deal with the hernia. But if you don't want to give the patient another scar, then you do the midline part by ETEP Reeve-Stopper technique, and then you revise that scar, and from that open area you can deal with the rest of the part. But I think doing a sublay repair is a good option. Anything you want to add on?
Yeah, since this is a forum of GI surgeons, one of the most common scenarios we come across is that the patient had a laparoscoma and that healed with a very, very fragile scar. And subsequently, let us say the patient needs to undergo the next surgery, say a repair of hernia or adhesiolysis. I've often seen the surgeons, they give an incision which is elliptical and go about excising the laparoscoma scar. I would strongly suggest that that is a bad approach, because we are going to waste the scar as well as the peritoneum. So we should go bang through the center of the laparoscoma and try to purchase as much of peritoneum as possible, in order to prevent doing stuff like component separation.
Right. So what Dr. Venu Kapoor is suggesting is preserve the peritoneal flap in these patients, and that could be done even with a lateral incision or midline incision. If you just remain very superficial and just excise the skin part, then still you can preserve the peritoneal flap.
So, is it possible to get after TARS? Can we get again hernia, and how to deal with those cases?
Dr. Partha?
Yeah, that's what I was telling in my presentation also. As you start doing more and more advanced AWRs, along with the success they give, the failures become more and more difficult to manage. Definitely, post-star hernias do happen. We don't want to see them. But one good thing is, because following a TAR, you give a very wide mesh coverage. It's very unlikely for patients to come back with very large recurrences. Number one. Second, if the patient comes with a very large recurrent hernia, it is most probably there is a Spigelian line injury or complete devascularization, denervation of the rectus muscle during the. It's probably a long TAR. But whatever which happen after a proper TAR are small, you can get away with an IPOM in such cases. This is where people have to go back, and in those situations, even though it is not common, it is not suggested to do in the same time. You can't do anterior and posterior, but in desperate situations, you can tackle the recurrence with an anterior component separation, because you've already run out of options.
You refer it to Dr. Parthasathi to attempt it.
Another technique we haven't talked about is peritoneal flap technique. And that is also a very good technique. For many large hernias, it prevents TAR, also for lateral hernias. And as far as 5 centimeter defect goes, if the 5 centimeter defect is epigastric or M1 area, you will have to do a TAR even in the right stopa plane to get a good coverage, even if it's a partial TAR. So I think it depends on where your 5 centimeter hernia is.
Right. So if you want to get, so TAR is going to give you the posterior cover, but if you can preserve the peritoneum minimally invasive, you can still prevent a TAR in M1. But yeah, anterior cover will be definitely a difficult thing in the subxiphoid area. Any other questions?
Sir, should we go back to perforator preserving anterior component separation technique?
Why?
To avoid TAR, to get more anterior rectus sheath mobilization.
No. So they are two different things. TAR basically gives you posterior cover, and it doesn't give you the complications of the anterior component separation. So that has been for long, and that's why word of hernia moves towards posterior component separation, because there has been a lot of complication with the anterior component separation.
Perforator preserving anterior component.
Yeah, still, but with even the perforator preserving ACS or even the endoscopic ACS, which you just do with lateral ports, there are still a lot of wound related issues. And I think TAR gives us much better results. But yes, anterior component separation has its own place in patients, and now with fasciotense, the role of anterior component separation is still reducing. So it has come down significantly. I think the time is over. So thank you so much for the invitation again. Thank you, panelists, for your wonderful comments.
Thank you so much, sir. Next is another panel discussion, which is based on safe cholecystectomy in difficult clinical scenarios. And the panelists are Dr. Yusuke Ome from Tokyo Women's Medical University, Japan, Dr. Ashish Singh, SGPGI, Lucknow, Delhi, from Muzaffarpur. I invite you all on the dais. I invite you to kindly take your seat on the dais. So you all are requested to come up on the dais. Then our moderator, Dr. R.A. Sastry from KIMS Secunderabad. I invite you, sir, to begin with the session.
Good evening. It's such a common topic, safe cholecystectomy. I don't think you have a conference in the past few years without addressing the safe cholecystectomy. A lot of guidelines are established. Now we know what not to do with cystectomy, but I think it's worthwhile recapitulating the basic principles and with illustrative difficult cases. I welcome my panelists, Dr. Om, Dr. Bhatendra Kumar, Ashish Kusing, and Nikhil Gupta. Now, when we say a safe cholecystectomy, we mean it should be safe to the patient and to the surgeon, with no collateral damage and no scope for litigation. A difficult gallbladder may be a little difficult to define, but any cholecystectomy that is expected to be more difficult than a routine one and which incurs increased surgical risk as compared with a standard cholecystectomy should be the difficult gallbladder we are talking of. Now, just to recapitulate on the accepted tenets for safe cholecystectomy, the critical view of safety must have heard T number of times, knowledge of anatomical landmarks and the relevant variations, the comorbid factors, predictors of difficulty, preoperative and operative, the concept of timeout, intraoperative strategies in difficulties, operative adjuncts, and bailout strategies. I'll just go through what a normal cholecystectomy and a safe cholecystectomy is. Now we talk of a hepatocystic triangle as opposed to a callus triangle, which is a little broader than the original callus. The critical view of safety. Now this is very important, and to achieve the critical view of safety before you clip any tubular structure, 3 criteria need to be satisfied. One, the hepatocystic triangle is cleared of fat. The lower 1/3 of the gallbladder is separated from the liver to expose the ductal structures. And 2, and only 2 structures should be seen entering the gallbladder, as illustrated here. Now, what are the landmarks? As you enter through a laparoscope, you try to look at the fundus of the gallbladder, the umbilical fissure first, the segment 4, and you should identify the umbilical fissure and well, can you have the pointer? You can see these are the landmarks to start with, and then you try to identify the hilar plate and the cystic plate, which are crucial, and the infundibulum of the gallbladder, the Rouvier sulcus, and the line of safety. All you do is above the line of safety, and the planes of your starting of the dissection to get the safety vision. I'll run through some of these. So this is the, how you to complete the posterior dissection, and now the cystic plate is exposed here. The lower third of the gallbladder is lifted up, and you have the cystic plate exposed, and you see the lymph node as a marker for the cystic artery, and now the CBS is achieved. You see there is a communication between the anterior and posterior. Only 2 structures are entering, and you're seeing the liver through the space. Now the cystic artery is divided, and this is the final cystic plate, intact cystic plate. This is what you plan to achieve. Now getting on to the difficulties in gallbladder. What are the predictive factors? I think let's first take on to what are the preoperative factors you would consider before you embark upon a cholecystectomy. So I classified them into factors obscuring normal anatomy in acute cholecystitis and chronic cholecystitis, factors affecting the operative exposure, and other conditions. I've listed some of them here. Please go through this, and the panelists can add on, because these are the issues we are going to discuss. In an acute cholecystitis, gangrenous, emphysematous, perforated gallbladder, chronic cholecystitis, thickened gallbladder wall. These are all preoperative factors. A shrunken, contracted gallbladder, and prior abdominal surgery, morbid obesity, and if you have a suggestion of aberrant anatomy, Mirizi syndrome, cirrhosis, and other comorbid factors. Would you like to add any more factors? I don't think we'll have enough time to discuss many of them, but that's the reason why I've taken myself onto some of to list all these conditions. The operative factors are shrunken gallbladder, the unclear anatomy and hepatocystic triangle, undiagnosed liver cirrhosis, and you find yourself that you're not progressing, and a suspicion of aberrant biliary anatomy. Now let's get on to acute cholecystitis. Here is a 55-year-old man, recurrent biliary colics for 4 years. Sorry. Somebody help, it's gone. Projection, please. He has a a 5-day history of acute right hypochondrial pain. A 5-day history of acute right hypochondrial pain with fever, no chills, treated with analgesics and antibiotics, and has a tender gallbladder swelling with guarding, a leukocyte count of 18,000, LFT is normal, and ultrasound shows classical acute cholecystitis, thickened edematous walls, and pericholecystic fluid. Now, the question is, in acute cholecystitis, what would be your policy? Do you always tend to operate on them or delayed? I think Dr. Om has raised this question earlier, delayed. Dr. Om, please.
Most early cholecystectomy is the best, I think. So soon after the patient come to our institute, soon we perform the operation.
Yes, any other?
So there are no suggestions about the medical condition of the patient. What is his ASA score and all that should come into consideration.
Okay, so you want to assess
to OT,
yeah,
especially after 5 days with 18,000 count. PRP also must be quite raised.
I raised that question because irrespective of the comorbidities and the local factors, there are people who would not operate after 72 hours. That is the reason I raised this question. Any person who wants to operate beyond 72 hours?
No, sir. As a policy, like if it has been more than 3 days and patient is having very high counts, I would rather continue with antibiotics, or if PCC is required, we'll put a PCD and manage this patient conservatively for some time, because it's a teaching session, and it is not about the experience and capability of a particular
It's
surgeon.
a standard guideline. It's totally acceptable. But then all patients are not same. Now, for example, this particular patient on the fifth day of acute cholecystitis has no systemic features. He appears to be settling. Do you make a difference for this kind of patients to avoid the morbidity of acute cholecystitis?
Definitely in a patient who is very well preserved, but still patient is having a right hypochondric tenderness and guarding and the counts are high. And if the patient is fit from the surgical anesthesia point of view, definitely we should give a try to these patients, and early cholecystectomy should be done at least up to 7 days.
Yeah, 72 hours is fine. So you have the other factor of severity assessment. You would assess the severity, and now you have the Tokyo guidelines. Anybody would like to take up Tokyo guidelines, and whether you really strictly follow the Tokyo guidelines in acute cholecystitis? Dr. Om?
Now, in Tokyo guidelines is improved after 70 hours from onset if the institute has experts. The early cholecystectomy is recommended. So that it depends on the where that depends on the situation where expert surgeons and
Yeah, it's
laparoscopic
acceptable.
yes.
Now, grade one, definitely, there's absolutely no fight over whether you want to do a cholecystectomy or not. But what about grade two and grade three? Anybody would venture intervention at this stage? And how exactly would you decide on operate or not within 72 hours?
Thing is, I think we would require a sectional imaging in these patients. Here, contrast CT scan is good enough because it will tell us whether the patient might be having some underlying GB perforation or there might be some sort of peritonitis. So a cross-sectional imaging is required. And if the patient is sick, like if a grade 3, then definitely we would go for a non-invasive or a minimally invasive technique by getting
Grade 3 is not really based on local factors, but the systemic factors.
Yes.
So I think the systemic assessment is much more important than the local assessment for an experienced person. Yeah. Let us see some of these.
Even in local factors, as grade B also includes emphysematous, gangrenous cholecystitis, there is no point waiting in those situations. Have to be taken to the OR and put to surgery. Gangrenous gallbladder, emphysematous gallbladder, you cannot wait for the gallbladder to perforate and cause systemic complications, isn't it?
Um, the perforation, a contained perforation in the gallbladder is not really an indication for an exploration, laparoscopic or open. You will manage them by a percutaneous cholecystostomy.
Emphysematous gall.
Emphysematous is different. Yeah, gangrenous, frankly gangrenous. Gangrenous would be your approach. Laparoscopic. Any of these conditions, radically.
Sorry, almost all cases are performed laparoscopic surgery because difficult case of laparoscopic surgery is also difficult in open surgery.
Yes.
Not different.
Okay, so you would
Laparoscopy with low threshold for open surgery.
with open conversion. Okay, that's fine. So the here is the I think it's a grade one type of acute cholecystitis, only distended gallbladder, which would aspirate and decompress it before you do any dissection. So the risk factors for difficulty in acute cholecystitis would be difficulty in manipulating and retracting the gallbladder, edema, large stones, necrosis, or gangrene, and obscure hepatocystic triangle from acute inflammatory process. Now, here are two instances of difficulties. Yes, there are clear adhesions, although not very thick fibrous adhesions as you would find in chronic cholecystitis, but separable, not with much difficulty. But then, see, as you proceed, suddenly you find that there is a local peritonitis, there is pus there. So what would you do under such circumstances? You find pus there. As you dissect, yes, you start finding pus here, there is a perforation, and some stones are spilling out.
So, whenever we find such sort of scenarios, and
Yes.
actually nowadays it's very common because diabetes and all these complications are a lot more common and epidemic in our centers. So what happens is we have to complete it, and laparoscopically they can be managed. Tips and tricks should be that we should stay very close to gallbladder. Especially, we should try to go from the medial side towards the lateral side because many a times what happens is in such patients, colon, it tends to get hooked up towards the lateral aspect of the gallbladder. So if we go from medial to lateral, we would be able to take down all the important structures, especially duodenum and the colon. And since the gallbladder is very friable, excessive traction should be avoided because that might lead to avulsion of
So what would be your maneuvers inside the through the laparoscope? You're not able to hold the gallbladder because it's very friable or it's already perforated or gangrenous, and then there is a constant spillage. So what would be your threshold for conversion at this stage?
Sir, at this stage, if the anatomy makes you comfortable, you can easily go ahead with the dissection and easily you can identify the anatomy. That probably you can continue with the laparoscopic approach. In case you find difficulty and you feel like open approach with tactile sensation, I'll be better handling these patients, you can convert. But the threshold has to be like low. And at this scenario, just mere like presence of pus and spillage of it, you need not to convert it to open.
Would you consider a cholecystostomy and at this stage?
No, sir, I think because most of the times we are able to get through by doing a cholecystectomy, but suppose the adhesions are very dense and we are not able to differentiate between the adjacent organs, then definitely a safe cholecystostomy by putting a drain, try to remove as much stones as possible and come out as the best option.
Yes, I think local factors are not that important. Most of the times you'll be able to manage them laparoscopically. But if a patient is compromised systemically and then you want to curtail the procedure, maybe that is the type of cases where you would resort to a cholecystostomy and come out fast. Now, a large stone in the Hartmann's pouch obscuring the vision in the callus triangle. This is given by Dr. Bhatendra Kumar sir. So, would you like to comment on your what are the problems of a large stone in the Hartmann's pouch?
Yeah, in this particular case, even if there is a very large stone stuck at the neck, still the surgeon has been able to do very well. Particular case, there is nothing else required to clip the artery and the duct, removing the.
We'll go to the Miller syndrome more of this a little later. If you can move the head, the stone and the infundibulum from the callus triangle and get the safety triangle, yes.
Otherwise, opening the Hartmann's pouch, stone and the other option. That could have been used in most of the other situations.
Any other comments on this difficulties?
This patient, the Hartmann's pouch could be lifted up, but some cases, Hartmann's pouch is and cystic duct has severe adhesion. So in that case, we soon should open the gallbladder and remove the stone first. So we can check, we can determine, and we can identify the whole of the cystic duct intralumen side.
Yeah. Now that we have dealt with the problems in acute cholecystitis, the other problems, previous upper abdominal surgery, you can take some clues from the previous presentations. Now you have a upper abdominal surgery, both vertical and rooftop incision there, and a patient has symptomatic gallstones. What would be your strategy in this kind of situation? Yep. Any of you can take.
First, with a single port from the virgin point, we can have a look of the abdomen from inside, how dense those adhesions are. Does this can be dealt with laparoscopically? Or
Which virgin points are you suggesting? Which do you think will be the safe?
Like for this patient, it may be the palmar point, palmar area, or slightly below that. You can go in and try to see. And it depends on what operation has been done, actually. It is not only the scar, what previous abdominal surgery has been done, and you might also require an imaging to see what are the underlying structures, how densely those are stuck to the abdominal wall, and then you can decide like what areas you
Yes,
can.
the first port probably here you can see the mesh and how it's the mesh is the omentum is adherent to the mesh. So the first port is a crucial one in any of these circumstances. Definitely, you would not prefer an umbilical port because that's the area where most of the adhesions would be there. So site other than umbilicus, uh, palmar point or open access in a open in any abdominal quadrant which is generally say opposite to the area of previous surgery. That would be the ideal situations. And inspect once you inside the first port, inspect the other areas of port entry clearly and release the adhesions. And you may have to put in ancillary ports for adhesiolysis because you don't have access to those adhesions. Did you have occasion any time to go through the adhesion itself and go to the gallbladder area and operate without completely adhesiolyzing?
Yeah, there has been situations where the momentum is densely stuck to the anterior abdominal wall, and you find a space from through which you can insert your camera and go up to that like right upper quadrant. Then there is no need to like absolutely dissect out the momentum from the abdominal parietal.
Yes, as long as the omentum is transparent and there is no colon or intestine behind, and you're not likely to injure, yes, that is an acceptable technique, except when the trocar slips, you may not be able to get into the exact track again. So you have to be watchful of that. Morbid obesity. Now you have the whole abdominal wall hanging down. What kind of strategy will you take in this kind of situations?
Morbid obesity, umbilicus becomes pendulous. Sometimes may go up to pubic symphysis.
Yes.
So umbilical first port being umbilical sometimes becomes very difficult. In that situation, your first port may be right subcostal.
Much above the umbilicus, maybe just about 15 centimeters from the sternum.
Right angle entry. Other working, especially the right lower port, inside diagonally. Otherwise, they put it a right angle, and then it would be very difficult to manipulate the instruments.
Abdominal wall, yes, it should be directed towards, not a
towards
tangent.
gallbladder.
Okay,
Towards
yes.
gallbladder. Diagonal insertion.
Yes.
That is advisable, I think.
Okay.
And especially in the morbidly obese patients, the upper abdominal fat is usually less as compared to the lower abdomen. So the ports in the upper quadrant of the abdomen are much better placed, and they will have minimal transabdominal traction while performing the surgery.
You also have the problem of a liver which cannot be retracted because of bulky and fatty liver. So you may have to use extra instruments to for retraction of the liver. In one study, implementation of a 1,200 calorie diet for 2 weeks prior to surgery had reduced the fatty liver bulk. But well, this is just one suggestion. How much it is helpful, we do not know. Cirrhotic livers. What are the problems and how do you tackle them? You have cirrhosis diagnosed before, and the patient has a symptomatic gallbladder.
Cirrhosis, I hope we are taking child A or
Yes, so it's very important
child B.
Yes, very important to decide on the child status, the liver function. Child C, I'm sure you would not like to operate with any hurry. Definitely, the mortality and the problem rate is very high in child C, 50 to 83% mortality. Yes, the problems
There
are.
may be,
Yeah.
again, there may be problems in insertion of the ports. Because in cirrhosis, we expect umbilical veins to be open. It has to be infraumbilical, number one. Then the whole abdominal wall has to be transilluminated to see other collateral veins on the abdominal wall. Injury.
I would like to know collaterals in the areas of Porter and in the areas of in the around the gallbladder. I think it's very important to assess the portal hypertension and the varices.
So first of all, like I would like to get an like CT scan
Yes,
to
very
map
important.
the hilar structures and collateral surrounding. And it is not only with the cirrhotic patients. If the patient, it's a common scenario for EHBUA patients coming for like cholecystectomy.
Yes.
So it is a policy to like map those areas, how big collaterals are, how dense those are, and then to plan a surgery.
Yes, a CT in the portal phase is absolutely important. And entry, preferably open entry rather than a varus needle. Yes. Extra port to facilitate retraction and exposure. And you must have advanced energy devices with you for a hemostasis. You should have either a ligashore or ultrasonic coagulator or harmonic. And most important thing is when you remove the gallbladder, stay out of liver bed. You do not violate the cystic plate at all because that can cause uncontrolled bleeding. And if increased collaterals are identified and things are getting out of control, a subtotal cholecystectomy or even abort the procedure in the interest of the patient. Now, in chronic cholecystitis, the problems are slightly different. You have plenty of time. It's not an emergency. You may have a severe desmoplastic reaction causing difficulties in retraction, exposure, and manipulation of tissues. You have a small thimble gallbladder, contracted gallbladder deep in the liver, and you're not able to identify the gallbladder even. So these are the situations. And Mirizi syndrome. Now, Mirizi, we know, is a common hepatic duct obstruction here, as you see here, extrinsically by a stone in the Hartmann's pouch, and of varying degrees. The pressure can be completely obstructing the bile duct, or it can even be fistulizing it. You have various grades. Now, if you have a Mirizi syndrome suspected, how would you tackle them? What kind of preoperative preparation would you need, and would you like to operate on them directly? What would be your take on Mirizi?
Usually, these Mirizi syndrome patients have some sort of liver function test abnormalities. So, preferably, even a non-contrast MRCP is more than enough to delineate the biliary anatomy. And if
Biliary anatomy, okay, yes. You have the suspicion, and you have a dilated common hepatic duct and a normal bile duct, and with a big stone in the
I would
gallbladder.
prefer to have an MRCP beforehand,
Okay.
before proceeding for the patients with suspected Mirizi.
What about ERCP?
Yes. Sir, if the patient is in cholangitis, and then only we should prefer an ERCP. Otherwise, the studies have shown that those who have undergone ERCP, they have done better in Mirizi syndrome. But if it's a type 1 Mirizi, in which it's slight indentation, or even up to type 2, even without ERCP, we can still go for a subtotal cholecystectomy and perform the surgery with the removal of the stone. Or however, if it's 3 and above, and preoperative ERCP is definitely helpful.
So these are the results: a conversion rate of 41% and complication rate of 20%, a reoperation in 60% systematic review. Now, so that is the reason why if a Mirizi is suspected, and some people prefer an open surgery, you should also assess your own skills of doing a hepatocogenostomy, which may be needed in some of these patients. These are the things which you take care of in a Mirizi. Sometimes, as soon as you put in your laparoscope, you know things are going to be difficult. What are those early signs of difficult cholecystectomy? Would you like to see these and assess your own situation and go ahead? I think it's very important. For want of time, I just listed these issues: a thick gallbladder wall, firm adherence of duodenum, colon, and stomach, liver pull down around a shrunken, hardly visible gallbladder. These are the issues. And this is the kind of situation where you see just a thimble gallbladder. A difficult cholecystectomy. This is Dr. Nikhil Gupta, your own. Would you like to talk on what difficulties you faced on this?
Basically, many a times what happens is when you are operating upon a patient with a difficult gallbladder, duodenum or some other organs might be adhered to the gallbladder, and it might be difficult, or it might not be easy to separate them from the underlying gallbladder. And since we know that we are not dealing with malignancy, we should err on the side of gallbladder rather than the duodenum or colon. And we can even open them up so that we can find the plane of dissection. Just below that, we are able to separate them and we can complete the cholecystectomy without harming any other organ like duodenum or colon. So taking a piece of gallbladder and opening it up is an option when we are dealing with such type of adhesions.
Yeah, we'll come to the strategies, operative strategies later. So basically, it's important not to have a preconceived notion in a difficult gallbladder that these structures are bound to be there, and you act upon that, because sometimes you are almost convinced that these are the structures. And divide small pieces of tissue at a time while in callus triangle. Don't take bulky dissections and carry the dissection to critical view of safety. When you cannot achieve the critical view of safety, we'll come to that situation. Now, aberrant anatomy is another important area. Now, we have a video here. Please look at it carefully and tell us what are those things which you should not have, which should not have been done by the surgeon. Yes, go ahead, please. Any of them?
I think they have already clipped the structure without. They have already clipped one structure posteriorly below the Rovia sulcus.
Yes, and they have not dissected they have not achieved the
critical view of safety.
Yes, critical view of safety is not obtained here. The lower third of the gallbladder is not reflected. They have straight gone into the callus triangle and they have ligated, clipped it here. And yeah, as you proceed is now. I'm just running through this. Yes. Yes. Even here, the dissection is not complete here. You have not visualized anything here and you have started clipping. These are the things which should be avoided. Yeah. Ultimately, as a senior surgeon, is had some doubts and started going fundus first. And in the process, opened up the gallbladder. There was spillage of stones. Yeah. Here now. Again, dissection is not complete. There is one structure which is clipped here. There are two more structures, two more ductal structures, tubular structures here. Yeah. See, ultimately, as you see here, there are three clips, three ductal structures are clipped. What do you think has happened?
Sectoral. I'm just hazarding a guess.
Yes.
Sectoral duct, posterior sectoral duct.
Yeah, it's possible because this dissection is not complete and the first clip is quite high up and it's entering. But then how are these two connected? Any other possibility?
It might be a simple fibry fatty tissue also, and where the clip has been applied. It's not necessary that it might be an underlying duct.
Well, this happens to be a duct, three structures. Yes, you can see the three lumens there. So it's very important. Say when the anatomy is not clear, this kind of situation, what should be your strategy? What would be your strategy? Okay, you will try to achieve CVS and you are not able to achieve CVS. Then what? How would you tackle?
Sir, first of all, I'll take a pause. I'll reorient myself.
Yes.
I'll see all the anatomy relevant anatomical landmarks, whether
Yes.
I am doing something right, whether
Yes,
I have
take a
gone.
break and yes.
Second thing is, if there is someone, I'll ask for some second opinion.
Okay, a senior or a
Like what
junior
I am
second
proceeding
opinion.
may not be right. and I'll take multiple opinions. If even after all these things, it is not clear what I am dealing with, I might consider a cholangiogram.
Yes, I think cholangiogram is an absolute must here. The anatomy is not clear. You will definitely call your seniors or call anybody. And but still, the delineation of anatomy is crucial here because CVS is not achieved, and it is not achievable in spite of. So the anatomical variations which are important in a cholecystectomy is this aberrant right posterior sectional duct joining the cystic duct. This is the most dangerous, like this. Say this duct which is joining the cystic duct, and this is both all the three are clipped. So the other issues are sometimes the cystic duct and the common hepatic duct are fused together in a fibrous band or in a thick inflammatory adhesions or large impacted stone we're not able to separate from here. These are all the situations which you could face. And in this is the kind of situation where you would think that this is a single tube. You divide it, clip and divide, and you see two lumens here. This is the most important situation which you should try and avoid. And some of the maneuvers are retraction maneuvers, which is crucial. It's very fundamental. How when you pull the infundibulum towards the right shoulder, the CBD looks like the cystic duct in a single line, whereas the your infundibulum is retracted down towards your right foot. Then there is an angulation developed. So these are all very primary things. Now, no progress in a difficult cholecystectomy. What to do? Do you give any time when you see, say, as soon as you enter the abdomen, you would know it's going to be difficult? Are you going to set timelines?
Actually, sir, time should never be a criteria. But if I'm not able to proceed, say it is taking more than 15-20 minutes or half an hour more as compared to normal, I think it's time that I am going to fall into a trap where I am going to end up
Exactly.
more damage.
Yes. So stop and look for red flags. Now, what are those red flags you are looking for on the table?
First thing is, sir, if you are not able to achieve the CVS, the duct is very wide.
Yes.
I think this is a cystic duct, but if it's more than 5 mm or something, which is that means medium or large clip is not coming with ease. I have to rethink. It might be an underlying CHD or a common bile duct.
Yes.
A large pulsation. There might be a possibility that it might be an aberrant right hepatic artery and not a simple cystic artery. And
These are all the red flags I have listed. Please go through them, and if you want to add any more, please. These are all the situations sometimes which you know in your practice you pass them as normal, as a normal variation. So it's important. And at this stage, you do a cholangiogram or any additive procedure to delineate the anatomy, the ICG or an operative ultrasound. Now, operative cholangiogram. It's very important to do an operative cholangiogram properly and interpret it, not just do a cholangiogram and see some contrast in the bile ducts. The C-arms and the visibility and operating table and the angulations, the postures, they're all important in delineating and visualizing the proper cholangiogram. Like this cholangiogram, would you be happy with this?
But usually, cholangiogram is performed after the injury. injury. So before the injury, we usually don't use cholangiography. So only the cholangiography doesn't secure the safety, I think.
Yes, not as a routine. Yeah.
It doesn't secure the safety in all cases.
Yes.
But definitely, if you find some difficult situations where you cannot ascertain what is the anatomy right now, you can do a cholangiogram to be more sure and delineate the anatomy.
Yeah, what I was referring to is incomplete cholangiograms. Here, the bile duct itself is not seen. And here, this is a classical situation where bile duct is normal. You're sure you have not injured the bile duct. You're concentrating only on the bile duct. Whereas actually what has happened is this. These things can be missed if you don't interpret it. Now, ICG is a new kid on the block, and it has a lot of advantages, definitely, because it doesn't involve any intraoperative manipulations, and it is constantly that. It's not just one time. And well, this is one which is given by just another 5 minutes, 2 minutes. Dr. Bhattendu, your video here. You want to talk on ICG?
No, ICG, people have started taking it up. It's a helpful thing, no doubts about it, but it has to be given in correct dose at correct time before surgery. Otherwise, you have sometimes you have
Intraoperative, intraluminal.
Also, it can be given intraoperatively. It can be instilled into the gallbladder along with contrast, like in IUC also. Those can be combined. There are a lot of options.
Okay.
That always be helpful.
Yeah, we are getting warnings. Other important thing is a timeout. You take a timeout in between. 4 situations where you take a timeout are first, as soon as you enter into the abdomen and you find a hostile environment there, or after identifying fixed landmarks before dissection of heterocystic triangle, before you divide a tubular structure, and when faced with ambiguity. So the options are these. Operative options should be, they're simple. Mostly it's either a subtotal cholecystectomy or a simple drainage or a pure conservative management. Now, partial cholecystectomy and a subtotal cholecystectomy, fenestrating and reconstituting, which one would you prefer, depending on the situation, obviously?
Sir, if it's highly friable and reconstituting is not possible, then fenestrating. Otherwise, preferably it should be reconstituting.
Yeah.
Because the biliary complications are much less as compared to the fenestrating one.
Yes. Yeah. I think we have come out of the last one now. It's not opening. Anyway, I think these are the situations which we wanted to discuss. Last, if anyone wants to add any particular area which was not covered, you're welcome as a final comment. Anyone wants to add anything? So we have covered mostly the normal, how normal safe cholecystectomy should be done, and what are the predictive factors preoperatively, and what are those predictive factors of difficulty during surgery, and how to evaluate them and how to tackle them, and most importantly, not to have a conformational bias. I think these are the few lessons for a safe cholecystectomy in difficult situations. Thank all my panelists for their wonderful contribution and thank the organizers for the opportunity. Any one last comment? Any comments? I'm sorry, this topic is so wide that we could not involve the audience, but last comment of the commission. Anybody wants to add something? If none, thank you all. Yeah, please.
But some it will be just like peanut-like size.
Yes.
Why should one do cholecystectomy?
Why should you?
One should go for cholecystectomy.
Why a cholecystectomy? Yeah, it's absolutely a valid question because that simple gallbladders generally just open into the bile duct with a wide cystic duct. At surgery, you would wonder why you have operated at all with all that difficulty. It's very valid.
I got two complications with simple gallbladder with senior surgeons.
Yes.
And another case, one surgeon looking for absent gallbladder.
Yes. I know. Yes. It's a very valid situation. And
one more point, Dr. Shastri, you have given all the reasons to find the bad gallbladder, difficult cholecystectomy. But if there is any suspicion of any mass, that in North India, gallbladder cancer can also be sometimes proposed difficulty in cholecystectomy. So that should also be kept in mind.
Oh yes, definitely yes. Thank you all.
Indeed, an enriching session, sir. Thank you so much. We'll proceed with our next session, and the topic is evaluation of liver SOL. Our speakers, I would like to invite them. Dr. Rajesh Day from New Delhi, I would also like to invite the chairpersons, Dr. Arya Shastri, Dr. Supriya Sharma, SGPGI, Dr. Jaswant A, and Dr. Asara T from Thailand to kindly take up their seats on the stage. I welcome you all on the stage. Over to you, sir.
Yeah, we are forewarned by the organizers to cut short the proceedings as much as possible because we are running quite late. Please, speakers, please feel free to voice your opinions, whatever you want to say, but try to be brief and stick to time. The first speaker is Dr. Rajesh Day. He'll be speaking on evaluation of liver SOL.
Good evening, everyone. Uh, I'm from Max Hospital, Delhi. I'll speak about the evaluation of liver SOL, and I would leave out the common things like hydatid cyst, hemangiomas, and all those things. And I would like to bring out certain equivocal topics which we face in our day-to-day practice, like this image on the right side, which shows an apparent contrast enhancement and infiltrative mass. It's actually an Echinococcus multilocularis lesion. So most of my talk will be not on the common approaches or the common SOLs like FNHS and adenomas, which are repeated ad nauseum in different forums, but we'd like to focus on what issues we face in our everyday life, in our everyday practice, and going to where the SOLs are, why are they there, in whom are they there, how many of them are there, and what do we really do with those SOLs is actually not in the part of evaluation, so I'll skip that part. So most of our practices, I was asking my colleagues before making this presentation as, do you really get patients primarily or very nascent patients? Most of our colleagues, we get patients who are referred from somewhere, or they come to us for second opinions, or someone known to them sends us calls or reports, and they come with a lot of assumptions regarding their diagnosis. And this is exactly what we want to discuss in this August forum, that in our specialist practice, patients come to us with reports, either an ultrasound or a CT scan, and what to do next with such patients. So it will mainly focus on the approach, the imaging modalities we do, and the role of tissue sampling in liver SOLs. And as with everything, it's the interpretation that is everything, images, what the patient tells, what we see in the labs are actually data points, and how we interpret them and make meaning out of them is what is more important to us. In the Indian scenario, what we've seen, there are multiple such publications from different medical colleges all across India. I took one from the Sub-Himalayan region of India. So most of the liver SOLs that come to the practices are more commonly in males. They're more commonly benign. Liver abscesses are very common in our day-to-day scenario. And amongst the malignant lesion mets are more common than the hepatic primaries. But it's so very important to speak with the patient and the attendants. That's an essential part of evaluating a liver SOL, is where they're coming from, which part of the country they're coming from. This lesion with such an infiltrative lesion I was showing in the other picture, it's actually an Echinococcus multilocularis from a patient who had come from a Central Asian country. So what they do, where they come from, also plays a role. And this is one thing which we often find in our practice is patients with abscess or infective conditions. We expect them to be coming with pain and fever, but when they come to our practice, they would have got multiple days of antibiotics. They would have received multiple analgesics, so they may often not have any pain when they present to us. They may not have had fever when they present to us. And another thing we always look for in our liver practice is the presence of stigmata of cirrhosis in such patients would come to us with reports of a liver SOL. So this image shows small nodules it's an MRI of the liver on the right side. These are actually caseating granulomas in a patient with no pain or fever, but when we sampled and evaluated for tuberculosis, they came positive. She's on ATT and doing well. Similarly, this shows multiple cystic lesions. She's a 56-year-old man from Delhi police, drinks occasionally. We are all thinking of malignancies, this, that, but actually it turned out to be liver abscess, incompletely treated, inadequately treated. And he came to us around 3-4 weeks after his onset of symptoms with mild pain and all. So what I'm trying to tell is that evaluation and assessment of SOLs in the liver should always take into consideration the history and his background and where he comes from. So why I put this graph is in our practice also, we see more and more HPV cases coming nowadays, whether it's because of more awareness amongst people or is it because of more incidence of such diseases in the community is something epidemiologists should study. But the HPV part of gastro practice has sort of boomed in the last couple of years, which we have filled. So when you look at the labs for patients who had come to us with liver SOL, the points we mainly look at are whether the platelet count, which is very important because if the platelets are less than 1 lakhs and the patient, it often signifies a clinically significant portal hypertension, and it often excludes a patient from a resection as a possibility of treatment. Also, raised bilirubin and raised alkaline phosphatase often denotes obstructive pathology, but we have also seen patients with hepatocellular carcinomas with tumor thrombus into the bile ducts presenting with direct hyperbilirubinemias. And the tumor markers often confuse us in the liver practice because many patients with cirrhosis often have raised alpha fetoprotein or CA19-9 or CA125 even without any evidence of any malignancy anywhere in the body. So all these reports have to be assessed in the background of such background liver disease and the native liver disease. So once we get such a patient, obviously we'll do an imaging and what imaging to do, whether to give oral contrast or not. And the omnipresent question of nephrotoxicity is always there while evaluating liver SOL. Why I bring up this point is very important because we are often at loggerheads with our radiologist who suggest not to give any contrast because of some creatinine is 1.2 or 1.3. And as we know, contrast agents can be ionic or anionic, soluble, insoluble, negative, and positive. I'll not go into this, but generally Visipec and Omnipec, they are low osmolarity contrast agents, and the degree of nephrotoxicity is really not much with low osmolarity or isoosmolar contrast agents. Similarly, with hepatobiliary agents for MRI, the incidence of contrast nephropathy is really, really low. Multi-hands, however, is sometimes available in India. Primavist is not available in India. What this chart shows is that the contrast agents that need to be used during a MRI also depends on the history of the patient, what you are suspecting, and the nature of disease that you are suspecting. Because if you are suspecting if you want to differentiate an FNH from an adenoma, or you have a oligometastatic disease, probably hepatobiliary contrast agents like multi-hands is better. Or if you want to evaluate the liver, if you want to work up a lesion that is seen on a different modality, the other ECA-based, extracellular-based contrast agents are preferable. This has a value in clinical practice because there will always be repeat and additional examinations. However, choosing the correct contrast agent can help the patient before the exam is even performed. And the Indian College of Radiology has its standard guidelines, which is very useful actually for us surgeons to look at and ensure that our radiologists are on the same page as with us, because the quality of images depend on the phases, the machine they're using, the timing of the machine. If they don't instruct the technicians properly to take a proper arterial phase or a triple phase scan, the reports are and the images are often not representative enough, and we all end up in a dilemma as to what to do next. So similarly, these are recommendations. I will not go into the depth of it. And the scanning phases like the pre-contrast phase, the hepatic arterial phase, venous phase, and the delayed phase, these are very important. And communication of the surgeon with the radiologist is very important, that scanning is done properly in those phases. Otherwise, the picture gets completely muddled. And as I was telling, there's been a lot of debate whether to give contrast or not. But most of the recent publication, even coming from the nephrologist group, tell that you should do a contrast imaging when and if it is required. And this is a guideline from the UCSF hospital. They tell that no patient should be denied any imaging investigation that is critical to clinical management. So even the KDIGO group in the National Kidney Group in their 2020 guidelines has suggested that if the EGFR is more than 45, the risk of contrast-induced nephrotoxicity is very low, and we can go ahead with giving contrast. And even if it's less than 30, then the risk is only 0 to 17%, and even they suggest that we give them some IV saline before doing the imaging. I'll not go into the LIRAD's classification of HCC. All of you are familiar with it. And this is the another scan, another picture which shows almost the similar thing as I was telling about giving the contrast hydration to prevent AKI, and especially in the high-risk patients who are diabetics or those with hypertension or those who are taking metformin, it's important. And when we are evaluating liver disease, we should always evaluate the background liver disease, whether there is an evidence of cirrhosis or portal hypertension. That's very, very important, because that evaluation gives us clue as to if we are planning for a resection, how much to resect, what is the future liver remnant. And often in a cirrhotic liver, when you are looking for SOLs, what confuses the radiologist and us is the presence of regenerative nodules or dysplastic nodules or transient arterial dysplastic nodules. They are often, our radiologists tell that these are only THADs and they are not to be worried about. So regenerative nodules are mostly well circumscribed. They're focal proliferations of normal functioning hepatocytes less than 2 centimeter, and they have their usual characteristics. Good radiologists can pick them up. And I've brought the subject of regenerative nodules because many patients with occult cirrhosis come with such regenerative and dysplastic nodules, which need to be followed up carefully. Coming up to the role of biopsy in evaluating SOLs, there are some reports that cytology is as good at biopsy, and biopsy can be a core needle biopsy or a fine needle aspiration biopsy. And many papers and publications are there to show that they are almost equivalent results. And the EASL guidelines suggest that biopsy is suggested at least after 2 inconclusive radiological examinations. So I just told, and one important part of evaluation is intraoperative evaluation to assess for inoperability and for changing decision making, converting a major anatomical resection to a non-anatomical resection, depending on the liver volume and the remnant liver volume. PET CT, however, in our practice, we are a bit skeptical about using PET CT in general assessment of metastatic primary liver cancers, because they are not very good in picking up brain mets and all those distant metastatic things. And HCC, a higher SUV, has a poor prognosis, as you all know. So more or less a working algorithm is to take a good history and perform contrast imaging and move accordingly if it's cystic, it is asymptomatic or symptomatic, and proceed accordingly. So these are a series of recommendations. They are there in the American College of Radiology recommendations, and they give us which it's very useful for us to look at what they think is appropriate or which may be appropriate and which are usually not appropriate. It depends on the size of the lesion and on the background liver disease and how the primary investigative modality. Like if it is more than 1 centimeter liver lesion on ultrasound, the next suggested appropriate imaging is probably an MRI or a CT abdomen with IV contrast. So these are all these things. I'll skip them because of paucity of time. And the ASLD group also suggests that liver biopsy should be considered in patients whom the diagnosis is in question. As I was telling, aspiration biopsy, core needle biopsy, cytology, in a good hands, good pathology hands, they give equivalent results. And in another important tool in our armamentarium is doing hepatic venous pressure gradient. This is important because it gives a measure of total hypertension present with a person with HCC. If it is more than 10, our resection decisions depend on that. So while interpreting SOLs, I guess rather than the content, it's the context which is the king, and we should not hesitate to perform multiple imaging procedures. And the role of biopsy is really come down in the recent years, and in only very selected cases, we may need a biopsy to do prove a liver SOL. Thanks.
Thank you, Dr. Rajesh. In view of paucity of time, I think we'll have to keep questions for the last.
Okay.
Thank you so much. May I call the next speaker, please? Dr. Kishore from Bangalore. He shall speak on ALPS versus PVE and how to choose between the two of them.
Good evening, everybody. Thank you to the organizing committee for this opportunity. I think it is in keeping with the theme of the conference. So what I'll do is, we all know that ALPS is a high-risk surgical procedure, and we know it is associated with more morbidity, but it does give a lot of hypertrophy, and it gives hypertrophy in the fastest amount of time. We know that. But apart from that, I'll try and discuss the nuances as to how we choose between the various modalities. And it would be amiss if I don't discuss hepatic venous deprivation also, because that is part and parcel of liver augmentation procedures these days. So how do we decide what to choose? It really depends on hepatic factors like what is the FLR before the procedure and what are we expecting post-procedure, what is our threshold, what is the status of the underlying liver. And whenever we choose a procedure, we always look to see if it is safe and what are the complication rates we expect and what is the efficacy of the procedure in terms of regeneration, how much volume will it give and in what time it will give. And of course, does it compromise oncological outcomes? And we also look at age and performance status of the patient. This is especially important because we know that with the ALPS registry data, that patients who are older than 67 years and patients who have biliary malignancies, that's the primary hilar cholangiocarcinomas, these people do poorly with an ALPS. They have high morbidity. So it's important to choose your patient right. And of course, in the real world, we have to look at costs and logistics and what expertise is available at your local center. So all these factors come into play when one is deciding what sort of procedure to choose. Portal vein embolization is considered the gold standard because it has minimal morbidity and it has extensive data now from the time when Professor Makuchi described it. And the downsides are there is a significant dropout rate of about 20 to 30%. I think half of it is because of tumor progression, and maybe more than half is because of inadequate hypertrophy of the FLR despite a PVE. Liver vein deprivation, that is blocking off the hepatic vein in addition to the portal vein radiologically. That is attractive because it has morbidity similar to PVE and hypertrophy similar to an ALPS. The downside is it's still an evolving procedure. Data has to accumulate, and the conversion rate and the kinetic growth rate are still not as much as ALPS. ALPS, of course, is a entirely surgical procedure. It has the fastest kinetic growth rate, and there is evidence that maximum number of patients do go into their second stage surgeries when compared to other procedures. And it can also be used as a rescue option when radiological procedures fail. The downsides, higher morbidity, especially in hilar cholangiocarcinoma, and patient selection has to be really good, as we have learned over the years. And it is important to emphasize that oncological outcomes are not inferior to radiological procedures. So I'll look at the evidence very, very briefly. What I want to do is maybe discuss what I have understood and present a distilled algorithm as to how to choose between procedures. The evidence part is there. I'll go through it a little quickly. So when we compare PV and ALPS, there are many studies. This is the latest from Queen Mary's. So what they have shown is the resection rates and the hypertrophy rates are obviously much better with ALPS. And this is largely in child day cirrhotics. And they found that the morbidity rates and mortality rates are quite comparable. And survival rates, that is oncological outcomes, were also similar. So they tend to recommend ALPS in their center as opposed to a PVE. Note that this paper did not have any hepatic vein deprivation. So the reasons for failure of PVE, like we discussed, are tumor progression and inadequate hypertrophy of FLR. There are 3 randomized control trials on this topic, PVE versus ALPS, and all of them seems to suggest that outcomes are similar to ALPS and PVE, but of course the patient selection is important. In this study, the outcome of 2-stage resection is actually overall survival is quite less. So that was one of the criticisms of the study. This is again a Chinese study. They looked at ALPS versus PVE plus stays. And what they found was patients with ALPS had a higher amount of resection. So ALPS patient had a significantly better survival than PVE. And when they compared the patients who were resected, ALPS and PVE had similar survival. So it is the progression to resection which is giving patients a survival advantage. And in the PVE group, patients who did not undergo resection had a poor survival. So HVD, that is hepatic venous deprivation versus PVE, this is a landmark study where they looked at functional assessment of the liver using a technetium scan. And what they found is in the HVD group, the volume also increased significantly compared to PVE alone, and the function also with technetium significantly improved as compared to only a PVE. So what they essentially found was the HVD group is much better, and morbidity also was similar. And a systematic review also seems to say the same thing. So there are a couple of randomized control trials which are being undertaken right now, the HyperLive trial and the Dragon trial. This will probably give a better answer as to whether HVD is really better than PVE. When we look at HVD and ALPS, this is a retrospective study, again a French multicenter study. What they essentially found that their primary endpoint was successful resection, and ALPS actually had a much better resection rate as compared to HVD. But they found that morbidity rates were similar. There were some important points like biliary tumors did bad, and of course functional assessment was not done in this study, and morbidity and mortality was still there, and colorectal patients did much better than hilar tumors. So how do we choose? So should we let the tumor biology play out? So if you just do a PV and wait, it actually selects out the patients, and people who progress, I mean, they don't get offered surgery. And that way we will select good biology tumors and you'll get good survival on paper. Or if you can also opt for a sequential approach where you do a PVE, then a HVD, and then a rescue ALPS. But the issue with that is patients who actually complete resection with, of course, a little extra risk, they seem to have a definite survival advantage as compared to patients who drop out due to progression or inadequate FLR. This is especially so in colorectal liver mets. So I think it's really worth the trouble with ALPS to do this surgery. And we should remember that regeneration which occurs is different. The mechanisms are different when we use different methods of liver augmentation. And during the waiting period, different tumors they respond differently. So we have an incomplete understanding of this, but it's important to remember this. And I think the reasons why ALPS fails or why we say that the complications are high, because one is of course bile leak and sepsis. Second thing is if you take on child age cirrhotics for HCC or patients with post-chemotherapy livers or cholestatic livers, so the decompensation can occur after the first stage. And generally ALPS, when all other modalities don't seem okay, patients with high-risk tumors are taken up for this procedure. So it may be multifocal tumors, so lowest FLR possible. So obviously complications are higher. And it is an important concept that although the liver grows after ALPS very rapidly, the function may not keep up with the size growth. So studies have shown where they've done biopsies from the FLR after the first stage with ALPS and PVE. And in the ALPS group, the hepatocytes are immature. So there are a lot of the biliary canaliculi are not grown well. So these immature hepatocytes actually don't function as well. So they say the liver is big, maybe there is edema, there is a lot of fat, so it may not function as well. So how do we avoid the complications? The segment 4 should be vascularized and bile leak should be avoided in the first stage. And of course, proper selection of patients with chronic liver disease so that decompensation is minimal. And there are a lot of technical modifications described in ALPS, like it can be done robotically the first stage or laparoscopically, or only a partial transection is known to result in as much hypertrophy as a full transection. And there are a lot of other modifications which are described, like radiofrequency assisted transection. So all these things actually reduce the morbidity of ALPS. And of course, functional assessment is a must before taking up a patient for second stage surgery. So this is the algorithm which I wanted to discuss. So if the patient is a candidate for surgery and the standardized FLR is between 25 and 30, so we can see which type of tumor we are dealing with. If it's a hilar cholangiocarcinoma, I would think hepatic vein deprivation is good. If it is a HCC, maybe a rescue ALPS after a HVD. If it's a colorectal liver mets, probably ALPS is better. And for patients with SFLR between 30 and 35, maybe a PVE for hilar cholangiocarcinoma, HVD for HCC, and ALPS or a HVD for colorectal liver mets. Now, why I'm saying this is because colorectal liver mets generally are bilobar, and the first stage involves clearing the FLR. So ALPS is probably best suited for this, and the data from the ALPS registry also indicates that this strategy converts more patients to surgery and therefore results in a survival advantage. For HCC, again, there's a risk of decompensation because most of them have some underlying liver disease. So adopting a non-surgical approach for hypertrophy is better. And for a hilar cholangio, which is a slow-growing tumor, it may be sensible to do a radiological procedure. And because bile leaks and patients with PTPD and cholangitis do very poorly with an ALPS, they have high mortality. So that's why a radiological procedure, HVD for low SFLR and PVE for a slightly higher SFLR may be good. Less than 25, one has to be very, very careful. And probably a extended hepatic vein deprivation where the MHV is also occluded, or a modified ALPS with RHV. This, of course, it's a one-to-one decision. Many patients may not be candidates for surgery. If it's more than 35, you're in a comfort zone. So what I would like to end with is liver augmentation procedures. We have to consider keeping in mind the overall profile of the patient and the biology of the tumor. And I think liver vein deprivation is here to stay. I think once the RCT results come out, It will probably replace PVE as a procedure for low SFLR patients. And of course, ALPS, we have to choose our patients properly to get good results. Thank you very much.
Thank you very much for finishing in time. So we'll have the question answer at the end. Thank you for your comprehensive talk.
Thank you, sir.
So may I now call upon Dr. Nikhil Agarwal from Delhi to talk on hilar cholangiocarcinoma, choosing the correct liver resection.
Thank you. Thank you, organizing committee, for this opportunity. And Dr. Kishore has given a very good overview of volume augmentation in liver surgeries. I'll be talking about hilar cholangiocarcinoma and which liver resection to choose for hilar cholangiocarcinoma. And before that, I'll talk briefly about how to optimize and prepare these patients for surgery. So let's just introductory customary slide about what is hilar cholangiocarcinoma. It's a tumor of the extrahepatic bile duct and it's most common form of cholangiocarcinoma. Right? And the goals of surgery for hilar cholangiocarcinoma is complete resection of tumor, R0 resection, which will entail excision of extrahepatic bile duct, a significant portion of liver, and then we have to leave a liver which should be of adequate size. So we call it functional liver volume, FLR, and it should have a good venous and hepatic drainage. We'll add some more procedures and steps. We'll talk about that later. Now, how do we work up these patients? Good quality imaging, generally a triple phase CT scan. Some centers would be okay with the MRI scan, a contrast MRI. They will also give us biliary anatomy. And we can do PET CT, but not very helpful because these tumors are desmoplastic. They don't take up FDG. FAPI PET is coming up there. And obviously there is role of cholangioscopy and direct cholangiography through both approaches, either through a ERCP or a PTBD approach. Now, if we look at the classification of these tumors or resectability, so we all are aware of the Bismuth-Colruyt classification, and this is a basic which we have to remember by heart because that's what helps us choose the liver resection, whether it's localized to the extrahepatic bile duct, below the confluence is involved, more towards the right, more towards the left, or if bilateral confluences are involved. There's another classification which was suggested by Jernagin et al. And this also takes into account the vascular involvement and atrophy of the liver, whether it's contralateral, bilateral, and based on that, we can decide upon resectability. And then we can use the NCCN guidelines, which they have completely, I mean, in 8th version, they did major modifications. They all have some limitations, some advantages, and NCCN works best. It has good determinant of resectability and correlation. Who are unresectable patients? We all know medically unfit patients. Cirrhotic patients generally will not undergo surgery for hilar cholangiocarcinoma if the patients had metastasis. Bilobar biliary confluence involvement, main portal vein involvement, and bilateral vascular involvements were used to classically considered unresectable, but there are centers which are doing these procedures now. Now, the next step, we have to talk about preoperative biliary drainage, and Dr. Kishore very nicely summed it up. But generally, when it comes to hilar cholangiocarcinoma, most of the centers in India are doing PTBD, and Japanese mainly do ENBD. I mean, there are pros and cons of that, but if you don't do drainage, there is the risk of liver dysfunction in these patients. And the lower the FLR, the higher the requirement of biliary drainage. So if you FLR is very high, if you have a 50% FLR, you can get away without doing a preoperative biliary drainage. But if FLR is low, then we'll have to do preoperative biliary drainage. And different centers use different cutoffs. Some centers use a cutoff of 30, some 40, and some 50. But most of the centers will use a cutoff of around 40. There is no optimum number of bilirubin which should be drained, but most of the centers are liberal in draining their livers. And obviously, there are some absolute indications for biliary drainage, which we all know. These are like cholangitis, malnutrition, renal failure, if we want to give neoadjuvant, and if we have to do PV. There are multiple approaches. As we said, most of us do PTBD. You can do ENBD, you can do ERCP. There are pros and cons of that. Cholangitis is more with ERCP, PTBD is more precise, less cholangitis, but there is a risk of seeding. It is external. ENBD is inconvenient to patients. They don't tolerate it. Sometimes they pull it out and it gets dislodged. When it comes to FLR, obviously we want a good FLR, generally more than 40%. Some centers use 30% cutoff. And for hilar cholangiocarcinoma specifically, we would prefer to use PVE. ALPS has shown very high morbidity with hilar cholangiocarcinoma. There are two techniques of doing PVE. One is ipsilateral and one is contralateral. Both have their advantages and disadvantages. But ipsilateral is like safer but technically demanding, while contralateral is easier, but there is a risk of FLR damage. And 0% mortality, very low morbidity, 8 to 27% increase at 3 weeks. You scan the liver. If you have adequate hypertrophy, you can go ahead with surgery. Right? And the curve, something grows like this. Initially, there is rapid hypertrophy for 2 years, then there is 2 weeks, and then there's a plateau phase, and then it slows down. This is what a picture looks like, and this is pre-PV and post-PV, and then you kind of go ahead and resect these tumors. When it comes to surgery, we have to achieve an R0 resection. We just talked about what do we want. You have to add lymphadenectomy, which is hilar lymphadenectomy. You cut the bile duct, reflect it up, remove all the lymph nodes as you do in gallbladder cancer surgery, and then you do a biliary reconstruction. Your FLR should has good arterial venous supply as well as drainage and a biliary drainage. Precise knowledge of anatomy on preoperative scan is mandatory, and you should have a good overview because you can't change plan intraoperatively. So you have to plan and then go. There are a lot of variations, and you should be aware of all of them in your patient based on imaging. So you have to very carefully look at the scans before you even plan surgery, and you have to kind of memorize the scan of that particular patient on the day of surgery. It should be 3D printed in your mind before you do this. There are various approaches. There are local approaches advocated. We can do a standard right, standard left, extended right, extended left, anatomic right trisectionectomy, about caudate and vascular resections. The diagram on the right shows where in terms of biliary transaction we will do, whether it's an extended right and all. So if you just move from right, it's from extended left to extended right, sorry, opposite side. And which resection we are going to do, it depends on extent of biliary infiltration, whether vascular involvement is there, how much FLR is there, and what is the anatomical variations or anatomy there. Based on this, we will decide which approach we will take. Local hilar resections have been described, but generally they are associated with higher recurrence rate and poorer survival. They are not advocated. But still, in very well selected patients, maybe if they are high risk patients, we can deploy some of them with lesser morbidity and mortality compared to a standard hepatectomy, but generally they are avoided because of non-oncological better non. If a lesion is centrally located, like if it's not gone too much on the right side or the left side, you can either choose a right hepatectomy or a left hepatectomy. There are advantages and disadvantages of that. Most surgeons will use a right hepatectomy because longer extrahepatic course of left duct, the right side is closer to the confluence. So there is more vascular involvement on the right side. And there are anatomical variations are also more on the right side. But it's easier to construct the right hepatic artery because it is wider. Now, if we look at the data from or series from the centers, like this is a large series where they classified this into two. So type 3 cholangiocarcinomas, like 179 patients, total, and 103 patients had right-sided involvement, and 35 had more left-sided resection. So if you look at the comparison, you see PVE was required more in right-sided resections because the left volume is low, right? But the complications were more when you did a left-sided resection. So left has more complication, right? But PV, but most of the time, apart from these two differences, they were comparable in terms of both survival and in terms of survival, both OS and disease-free survival and prognostic factors. Obviously, this was not one of the prognostic factors. Prognostic factors were T-stage advance and lymph node metastasis. If we look at the metastasis, it comes up with the almost same thing, equivalent survival. Right hepatic group with have higher requirement of portal vein embolization, increase overall complications, more mortality. This was in this and more PHLF, while lower with higher like arterial and venous reconstruction with equivalent oncological outcomes. Now, if we have tumors which are more advanced, maybe going towards both sides as well as vascular involvement is there, then the options are right trisectionectomy. We generally tend to call them extended right hepatectomy and left trisectionectomy, which is extended left hepatectomy. Extended right hepatectomy is resection of all the segments except 2 and 3. Generally, we remove around 80% of the liver in this. And this is less technically difficult than a left trisectomy. And this is a commonly done procedure by most of the surgeons. And you can see that's how we go about this. And the lowermost diagram is the completed procedure. If you do left, where is more left-sided predominance, but if you see most of the series, this is an uncommon procedure. Approximately 5% of the procedure are extended left hepatectomy in most of the series. There are various reasons for it, more anatomical variations, the plane is not right, the liver transaction surface is very long actually, and but if you use this procedure compared to the standard right hepatectomy, your R0 resection rate increases and you get a 7 millimeter increase in the margin compared to the standard left hepatectomy. These are some anatomical variation which you should be aware of when you are doing an extended left hepatectomy, especially the supraportal artery, which curves over the portal vein and then goes to right posterior side. So you have to preserve this. And this is the specimen. This is a anatomic right hepatic trisectomy has been described by Nagino et al. And here what you do, you go behind the left portal vein in the umbilical fissure and you divide the branches behind it. So by doing this, you will be able to go to the left of the falciform ligament and divide the bile ducts there. So you get some additional margin. So some patients can get an R0 resection with this procedure. And caudate resection is mandatory because if we look at the studies by Nimura et al., most of the patients had their caudate ducts involved with the tumor. So generally, it's a good idea to resect the caudate. That's the best way to get R0 resection, and it improves survival and better margins without giving the patient any morbidity and mortality. So I guess vascular dissections can be used if required. So if some vascular involvement is there, be it artery, portal vein, they can be resected and reconstructed. There's slight increase in the morbidity. Some of the series will say that the morbidity doesn't increase. And survival, some series will say equivalent survival to resections without venous resection. And some series will say inferior, but they are generally a good idea to be resected. And if we look at the outcome of resections in hilar cholangiocarcinoma, we get a survival rate of close to 5-year survival of 40%. And if we see large series, over a period of time, the complication rate decreases and the survival improves. Thank you. Taking questions after this.
Thank you, Dr. Nikhil Agarwal, for your presentation. We will skip for the question and answer for the next. I'm sorry, because we're running out of time. I would like to invite Dr. Anon Chotilot Nilamit from Thailand. He is a president of the Thai HPB Association. He will present in a topic about the challenging surgical management of HCC with biliary tumor thrombus. Please, Dr. Anon.
Thank you, Dr. Asala, and thank you, Chairman. First, I would like to express my gratitude for invitation me to join this conference. I have no conflict of interest for this presentation. For SCC with bile duct tumor thrombus, the jaundice is common symptom in initial diagnosis of SCC, but it usually occur in the advanced state and due to diffuse liver involvement by the tumor. So the obstructive jaundice is quite rare. It's around 1% in the many cases of series, the large case series from China and from Korean Japan. SCC may involve the bile duct in various ways, such as the tumor thrombus protruding into the bile duct, or the floating tumor thrombus obstruct the bile duct. In some cases, there is the problem of hemophilia cause obstruct of the bile duct. And infrequently, an obstruct bile duct may result from direct tumor compression, or sometimes it has a lymph node metastasis and the lymph node compress to the distal bile duct. You the first describe ACC with bile duct thrombosis in 4 types. Type 1 and type 2 is mean in the primary or secondary branch of the main hepatic duct. And the type 3, the tumor involve the common bile duct, and type 4, the floating tumor thrombus in the distal bile duct. There are still significant difficulty and challenging for the diagnosis and the treatment because cholangiocarcinoma is quite common in Thailand and it's more common in obstructive jaundice patients. And sometimes cholangiocarcinoma is present with a peripheral enhancing mass, and sometimes have the right IPNB, have an enhancing tumor. So it's mainly mimic for diagnosis with ACC with tumor thrombus. The typical radiological finding of ACC is enhancing mass in the cirrhotic liver and the mass protruding into the bile duct lumen. So these are typical finding of ACC with bile duct thrombosis. Usually for ACC with the bile duct thrombosis is more complicated than the tumor without thrombosis because we assess the obstructive jaundice and cholangitis is difficult because the patient may have a chronic liver disease, and sometimes it's difficult to determine if a child A, B, or C. And so for preoperative biliary drainage for this case is difficult because some case bile duct is a minimal dilatation, and sometimes when we do endoscopic stent, it's causing hemophilia. And for the treatment of the tumor like this, usually require major hepatectomy, so it may complicate with post-operative liver failure. For the treatment of the bile duct thrombosis, surgical treatment for the type 1 and type 2 is a right or left hepatectomy. But for the type 3, the tumor involve the hepatic hilum. There are 2 options: is a hepatectomy with tumor thrombectomy and hepatectomy with bile duct resection. The hepatectomy with tumor thrombectomy, the advantage is less surgery and no biliary enteric anastomosis. But the disadvantage is the spillage of the tumor and can cause a recurrence in the bile duct or the tumor dissemination in the peritoneal cavity. If you see the histology of the bile duct tumor thrombus, the cancer cell usually just attached to the biliary epithelium and often can peel off with a surgical removal, not required by the resection for this location. For the hepatectomy with extrahepatic bile duct resection, the advantage is more margin and less tumor foiling, but the disadvantage is mean require hepatico-jejunectomy. For the recurrent disease, when we do chemoembolization for the treatment of recurrent, if the patient have a hepatico-jejunectomy, it may cause the liver infection to the liver necrosis after chemoembolization. Hepatectomy with extrahepatic bile duct resection is recommended for when we suspect the direct invasion of the tumor into the bile duct confluence, or if the tumor thrombus is very extensive, it means may have a neovascularization, blood supply to the tumor, and direct invasion to the bile duct wall in the tumor thrombus. Require hepatic hilar dissection. I would like to present my hospital experience about the tumor thrombus. Like this case, around 20 years, we have 37 cases of SCC with bile duct thrombosis. Mean age of them is 55 years. And most cases have abdominal pain with jaundice, and some cases present with acute cholangitis. For the investigation, average total bilirubin around 10 milligram per deciliter, and rising of alpha-1 hetoprotein is 70%. Surprisingly, CA19-9 is rising in some cases around 50% of the CA19-9 was taken. And most cases have chronic hepatitis B or C or alcoholic cirrhosis. For the treatment and result, 2 cases we identify as a terminal case and just palliative care only. And they die within 2 months. And 4 cases are unresectable, so we do only corticotomy and remove tumor thrombus. But the survival is very poor, just a few months after surgery. We have 31 cases, resectable case, so resectability rate around 80%. In the Judah type 1 is 4 case, and type 2, 3 case, type 3, 22 case, and type 4 is 1 case. For the treatment result, the mean tumor size is around 6 centimeters. We can do POBT barely in just 7 cases because the other case bile is dilate enough. In 1 case to do ERCP for remove blood clot. The surgical result, we do hepatectomy 8 cases. The second order or third order of the bile involvement. And hepatectomy with tumor thrombectomy in 7 cases. And hepatectomy with bile resection in 16 cases. We have 4 cases to do laparoscopic hepatectomy for the procedure. For the short-term result, we have 2 cases of post-operative mortality due to liver failure and sepsis. 19 cases without any complication. In 10 cases, we have for complication, we have 5 bile leakage in 16 cases of bile resection, and 2 cases have abdominal internal infection, and 2 cases of transient liver failure. For long-term result, the recurrence rate is around 50%, and we have a disease-free survival for 1 year 60% and 5 years 48%. For the pattern of the recurrence, we have recurrent tumor thrombus 2 cases in the remaining bile duct, and most of recurrent pattern is liver metastasis. The survival curve of 29 cases of survival rate, we have a 3-year survival rate around 70%, and 5-year high as 65%. 18 cases are still alive with mean follow-up of 96 months, and 14 cases without any recurrence, and 6 cases still alive within more than 10 years. When we compare to in the subgroup analysis, hepatectomy alone no data for this. And when we compare the hepatectomy with bile resection and with tumor thrombectomy, so significant between the survival of the between 2 cases. And when we compare the survival curve between resectable ACC or without bile thrombosis in the same period, no survival significant. It's the example case. This case has the tumor in the segment 4 and the large chordal tumor directly involved the bile duct. For this case, we do hepatectomy left side and including bile duct resection. The patient have died within 18 months due to lung metastasis. And this case, left hepatectomy with tumor thrombectomy, 15 years without recurrence. And this case have a tumor in the caudal lobe and direct invasion into the bile duct and causing hemophilia. Left hepatectomy with bile duct resection and caudal lobe resection. We have a recurrence and die within 7 years after operation. And this case look like a hilar cholangiocarcinoma because we cannot detect the hepatic tumor inside the liver. But after surgery, like hepatectomy with bile resection, the tumor is a SCC because the tumor had a small tumor nearly bile duct confluent and direct invasion into the bile duct. The patient still survived 14 years after operation without recurrence. And also, like this case, look like hepatic cholangiocarcinoma with hilar involvement. So we do the right hepatectomy with hilar resection, and the patient still 15 years without recurrence. And for this case, the tumor located in the caudate lobe, and we do the right hepatectomy with hilar resection, and the result is not quite good because she died 13 months with liver and renal metastasis. For the recurrent disease, if we do hilar resection and have HJ anastomosis, after chemoembolization, the infection complication is should be careful because we have incident for this. And we have they have a large Korean and Japan multi-center study. Okay, I want to skip this. So conclusion, SCC with obstructive jaundice due to bile duct tumor thrombus is not hopeless case, and surgical treatment is a challenge. Aim of operation are merely decompression or curative tumor removal with or without bile duct resection. Thank you. May I announce the meeting next year in Bangkok? Just one minute. Okay. We have APHPBA Congress next October next year. Official Congress we know is Queen Sirikit National Convention Center. And we have two living legends from Japan, Professor Masao Tanaka. He will talk about the IPMN. He is like a father of IPMN. And the next living legend is Professor Chao Long Chen. He will talk about liver transplantation. And in next meeting, we have an international consensus guideline for management of IPNB. It is the first consensus guideline in the world for IPNB. And we have three chairpersons from Professor Zhang from Korea and Professor Kubota from Japan and Professor Lovila from Thailand. And we also have 25 experts from 9 countries for do the IPNB consensus in our meeting. And we will present in the first day of the meeting in the first day meeting next Congress. And for the scientific program, we have 80 speaker in the keynote session and more than 100 speaker in the symposium session. And now the invited speaker almost accept for invitation already. And we have around 10% of speakers from India also. And we have 7 parallel session and 3 main hall and 4 breakout room. So we have 7 parallel session. And also we have United States and European speaker and renowned speakers such as Pierre Clavian, William Janakin, Lenny Adam, Thilo Hackett, and Pavik. Key date for this. Next November, we will start abstract registration in the 1st November. And in the end of January is the last chance for super early bird registration. And April is the end of a summit of abstract. Thank you so much.
Thank you, Professor Anand. Due to paucity of time, we are already running several minutes late. We call this session to a close. Thank you to the speakers. All had a very wonderful presentation. Thank you.
Thank you so much, and thank you to the panelists as well. Now proceeding with our next session, which is based on surgical research. The topic of the next discussion is Big Data versus RCT in GI surgery by Dr. Vikram Kate. Chairpersons for the session are Dr. Diban G. Lucknow, Dr. Sumesh Kestha, RNR, Dr. V.M. Dayal, sir, IGIMS, Dr. Utpal Anand, AIMS, Patna. I request you all to kindly take your respective seats on the dais. I also invite Dr. P.C. Jha, sir, to kindly come up on the stage.
May I request Professor Vikram Kate to deliver his lecture on big data versus RCT in GI surgery.
Good evening to everybody. And at the outset, I'd like to thank the organizers and the conveners of ISG who have given me this opportunity to share some of our experience. Now, when it comes to big data versus randomized controlled trials in GI surgery, which is better, it is difficult to give a logistic answer in 10 to 12 minutes, but I'll try my best and will give you an overview of what we think about it. Now, if you look at this picture, this sums it up. You can see that we have a lot of evidence, and on the top we have the RCT sitting there, but now we have definitely lots of questions and queries people have in their mind whether it is necessary always to do a randomized control trial to have a good outcome and a better output from research. Now my talk will cover brief about study designs, an overview of RCT concerns, an overview of big data analysis, big data concerns, which is better, and a bit of summation. Now when it comes to study design, it is an overall strategy chosen to logically assimilate the different study components so as to effectively address the research questions. That's the prime target of it. And it should be research question based, and it is not that we pre-decide a study design and then form a research question and then do the study. Now if you look at the levels of evidence here, at the top we have meta-analysis of RCTs, systematic review of RCTs, and of course good RCTs. They sit on the top, and then you have the other observational studies. And if you look at it, you can see that as we go on the top, you have the bias keeps on reducing. Now actually what is bias? Bias is the systematic deviation of the study results, what we want, which are inferences from the truth. So it deviates from the truth. So what you are seeing, the outcome may not be the outcome. And if you have a substantial bias in the study, you will not get the correct research outcome from that particular study design. Now these are the study designs, and you can see here that primarily divided between interventional studies and observational studies. Now for a long time people used to think that observational studies cannot give a good substantial evidence as compared to randomized controlled trials. But with the availability of the EHR's electronic health records, now we see that definitely we can get a huge amount of data very quickly, and with the help of that, now we have the big data analysis, which is now competing for the efficacy with the randomized controlled trials, which come into the group of interventional trials, interventional studies. So a little bit about the observational studies. It is not that all observational studies have to have big data. Even if you have good observational studies, it can give rise to good outcome. If you look at these studies, what we have done, they're not very large numbers, maybe 100 patients or that, but definitely we could do some classifications based on that. If you look at this other study on esophageal strictures, there also we could give something about an algorithmic approach, how to do it. So all these things indicate that observational studies do have a role, a lot of significant role in literature. But today we'll be looking up at observational studies which target the big data. Now, when we talk about treating a patient, evidence-based medicine, we have to have a clinical judgment about that patient. We have to see what is the best available evidence that will help the patient. And of course, you have to match with the patient's values. Then only you can have a good role in the treatment of that patient. A bit overview of randomized control trials. They are called control trials because we control the eligibility criteria, priori hypothesis, primary and secondary endpoints to address the hypothesis, methods for enrollment, rigorous monitoring, and of course have the stopping rules. Why they are sought after? Because randomized control trials are traditionally considered the gold standard of evidence. And if it is a well done randomized control trial, or you have a systematic review or meta-analysis of randomized control trials, the research output from that actually forms the basis for the treatment. Now, if you look at this, some of the RCTs, what we have done, they even now they get a good position. This is in the DDW at SSAT sessions. So it's in presidential plenary, and then usually practically all the RCTs were in the plenary sessions, and even this summer also this RCT we had presented in the presidential plenary, indicating that still there is a lot of preference for RCTs. Because randomized control trials, the output which comes from that, it is considered to have the least biased, and a good well done RCT has still got good takers. So what are the types of RCTs which are done? This is one of the most commonly performed RCT, that is the parallel arm RCT, where you have two arms, one is the interventional arm and the control arm. The outcome measures are mentioned there. Primary, mostly it will have a single primary outcome. It can have more than one primary outcome, and then there are secondary outcomes which are very nicely mentioned in most of the RCTs, because nowadays RCTs have to follow the consort checklist. Then the eligibility is predefined, ensures that participants meet the criteria, then we enroll it, and then we allocation concealment is done. And then we have the standard eligibility criteria on the basis of which we admit the patients into the study. But the problem is when you have this eligibility criteria which are very narrow and rigid for that particular RCT, it becomes a con for RCT, which I mentioned below, that generalization of the results becomes a problem. And of course, you have to calculate the primary outcome based sample size. So that is what is mentioned here. So like that, we calculate the sample size. Now, when you do the analysis from an RCT, usually it is always preferred to do an intention to treat analysis, which is defined as all patients who are randomized have to be considered for analysis. Even if there are dropout rates and all those things have to be considered, and then you do the analysis. Per protocol analysis is not considered a good way of analysis, and ITT is the least biased and most conservative. Now, this is an example of an ITT analysis. It can be seen here that on the left hand side, what is the red color? That shows that the denominator is 43. That is what should be used for all types of analysis. And it is not that following the dropout of the patients you use 39 or 37. So that gives a good measure from the RCT, and the output is least biased. Trial monitoring is done for randomized controlled trials. It's institutional review boards, IRBs, or the ethical committees, they monitor it, and they are independently monitored for adverse effects, serious adverse nature. And then if there are some problems, like if there is a risk from the intervention, or there is a too much benefit from the intervention, or it is an ineffective intervention, all these circumstances, these are stopped. So these are a few of the investigator initiated trials what we have done in the last few years. Now, what are the concerns? Surgical setting, it may be difficult. Equipoise in surgical setting may lead to problems. Surgical procedure is skill dependent. Again, randomization might become a problem. Blinding might be a difficulty. Resource sensitive, you require money for it. And then sometimes if it is delayed, that also can lead to problems. As I mentioned earlier, rigid inclusion criteria can lead to a problem in generalization, extrapolation of results. Blinding is difficult. New intervention, if a surgeon is testing a new intervention, the surgeon would not like to randomize that particular intervention and continue to do that. So that becomes a difficulty. And if there is a lot of loss to follow up and non-compliance, then the output is bad. Because if you have many patients out, then in ITT analysis, you will not get the correct results. So do we have something which can be an alternative to randomized control trial, but it is not a randomized control trial. So that is what is big data. Essentially a part of an observational study. Consensus about the definition is not clear. Right hand side, I have already mentioned, high volume should be large volume. Velocity, you should be able to retrieve the data very fast. It should not take months and years to retrieve. Variety, it should have a good diversity. Veracity, the facts should be very clear and the quality should be good and it should give a high value. This is what is the 5E model for a big data. This is the Framingham study which has generated so many publications, one of the classic big data analysis. So this is one of the studies on curative hepatotomy for hepatocellular carcinoma. Although the number is not very large, but still we can see here from the Taiwan Cancer Registry, we have got good results to show that the antivirals are similar to each other. So these are other examples. In the first example, 1.5 million patients were included to see the role of proton pump inhibitor in pancreatic cancer. In the other one also, 500,000 patients were included for the analysis. So this is a really large data. So advantages, easy and cheap, retrospective, often provides sufficient power, useful for rare conditions, as I mentioned there, includes wide variety of patients and allows a participant hospital also to have a benchmark compared to other hospitals. So what are the concerns of big data? Very large data, even if there is a small difference which is insignificant, it will show it as significant. So type 1 error can happen. Data mining people can do, and sometimes coding errors. Administrative databases for reimbursement might not note those things properly, diseases, so that can create a problem. And then registry database is a preferred thing, but there also it can be sometimes inaccurate. These are other problems of big data: diagnostic accuracy, missing data, and the most important thing, because any observational study will have, is the bias. Confounding bias, that becomes the major problem for treating any patient. So that is where we have something called as the propensity score matching analysis. I'll just give this from the illustration. This is one of our randomized controlled trials. If you see the table, this is the table of the characteristics matching on both sides, and you can see it that the p-values are not significant. RCT, it will always get matched. But if you see here on the left hand side, most of the points what we are seeing there, it indicates that there is a gross difference between the age and other parameters. So they will affect. But if you see the right hand side, once propensity matching has been done, it has got matched. This is almost like a randomized control trial. So that is what, so can we bridge explanatory, that is the conventional arteries, conventional RCTs, test hypothesis in ideal circumstances, pragmatic randomized control trials, they do in real world situations. So that's the answer, a forward movement across the RCT from a conventional randomized control trial to a pragmatic trial, efficacy trial versus effectiveness trial. So the key points from this: study designs in medical research can be broadly classified as basic, blue sky research, what it is called, observational and interventional studies. Big data analysis, the type of observational study, are being more used now to overcome the limitations what we have in randomized control trials. And it also includes a wide variety of data in real world conditions. Observational studies are always from the database, from the real world conditions. And as I mentioned, explanatory RCTs, the conventional RCTs we can do later on with the pragmatic RCTs, which can be again in the real world data. And again, you have to match and see the benefits and limitations of RCTs and big data. And a good way will be to do a triangulation. That means you take the advantages of big data, advantages of randomized control trials, and then get the answer for a high level evidence. So ladies and gentlemen, again, study design is an overall strategy chosen to effectively address the research question. It is determined always by the research question and not vice versa. Thank you very much for your kind attention.
Thank you, Dr. Kate, for an excellent overview of the current situation as far as medical evidence and use of trials. We will have the discussion at the end. May I invite the next speaker, Dr. Avinash Tupe from KM Hospital, who will speak on collaborative research, the way forward.
Thank you, Mr. Chairman, and Vikram for really putting the whole concept of RCT, how it is difficult into surgery. As you all aware, doing surgical RCTs are most difficult, and therefore most of the RCTs in surgical journals are related to the medicines or drugs or nutrition rather than the surgical principles. However, collaborative research is coming up over a period of time and it has its own advantages and limitations. So I'm going to review and just give you next 10 minutes. The collaborative research has become increasingly popular in the academic world with proliferation of the interdisciplinary research. As over last few years, we have seen that the walls between the various disciplines have been breaking in many of the universities, whether it's Harvard, John Hopkins, or anywhere, where the departments of medicine and engineering and others are really breaking up. So that's where the collaborative research has been really coming up. So what is collaborative research? Collaborative research is a type of research that involves multiple individuals or groups working together to achieve a common goal, and the type of research is often used in areas such as medicine, technology, and education. It involves sharing of resources, ideas, and information. So with collaborative research, each participant brings his own unique perspective, his own skills, and expertise to the research project. To allow the project to benefit from a variety of perspectives and ideas, it also allows participants to learn from each other. Now, collaborative research can be conducted at a variety of ways. It could be done in person as well as online, and it can also conducted by various methods, what we call as a mixed methods, qualitative and quantitative. It can be surveys, interviews, focus groups, and a wider range of perspectives. Additionally, it can lead to newer discoveries as the participants can draw on each other's ideas. Collaborative research can be classified into different ways. It could be institutional context, where you have either university, college, or institute, where you will find multiple kind of areas can come together and they can be the collaborative research. However, there could be number of academic fields can come together, something like humanities and social sciences and natural sciences. They can come together and then they can have a collaborative research. Now, this is very important that you go beyond your area of interest and start working on this. These are very difficult to do in a randomized control trial or even big data analysis. The third is disciplinarity. Now, this is where the major change has come in last few years. I think there are many universities now are giving double degrees. I remember many European degrees now give 6 years course, and at the end of which they would give an MD and also an MTech. Now, going beyond that, they are now giving a particularly kind of a research which involves various kinds of disciplines, and it could be physics, chemistry, biology, and medicine. Together, they could be there. Interdisciplinary collaborative research is again, which is very commonly, I think people have been doing it now. Multi-institutional collaborative research. This is where you find the classic example is Netherlands. The kind of papers which have come from Netherlands and their Amsterdam All group, these are multi-institutional studies, and they are the ones who can collect large amount of data. And for everything what we normally would like to see in GI surgery, they would have some kind of a group which would be giving paper. Now, such a thing we are not able to do in our country, but this is the way to really go ahead. Another thing is cross-cultural collaborative research. This is where the different cultures come together, something like African culture and the American culture and Asian culture, something like that, to understand a particular research topic. But every time we say this is an American data, this is not working in our country, this is a North Indian data, this doesn't work in Bihar, Now, there has to be a cross-cultural study. And international collaborative studies, this is where it has been coming. Now, if you really see importance of collaborative research, it increases the accuracy and validity of results. That's what they, claim. By working together, researchers can cross-check facts, compare results, and assess the different methods. Now, collaborative research also can promote innovations, combining diverse perspectives, generate new ideas, and new discoveries. Of course, there are a lot of ethical considerations in the collaborative research. And if you really see, there is always patient privacy, informed consent, data security, and ethical use of research findings. Now, this is something which I thought is very important today, and which I think previous speaker also really said, and which is very difficult if you are doing it across the world. I would like to give few examples of collaborative studies which are going on over last few, years. This was a very nice paper from August, September 2024. This is the last month this was published. And this is where the global surge and the NIHIR, they really started these various kind of studies where community engagement, benign hub expansion. And if you really go through their studies, they had done 3 basic studies, what are called as a global 1 surgery. It's outcome of the emergency abdominal surgery. And this is one of their few collaborative studies where they have 10,745 patients, 375 centers, and everything. And then they came out with various kinds of parameters like what is 24 hours mortality in lower middle income groups, countries versus other countries, what is the 30-day mortality higher, and this was published into BGS 2016. And you look at these kind of studies are now coming up. The second was wound infection after gastrointestinal surgery worldwide. And this was again published in Lancet Infectious Disease. And look at the population, they looked at almost 7,339 patients, and they looked around all over many countries, and they came with the drug resistant bugs, wound infection more common in, again, these kind of parameters they come out. Then came improving surgical outcomes in different places, patient identification and follow-up, especially multidisciplinary research for outcomes of cancer, breast, stomach, and colorectal. So now what is happening, this movement is coming up where people are now gathering together and they are building up these groups and trying to develop now collaborative research. Now, this is not so easy to do because it requires definitely funding. It requires a lot of collaborations, networking, trying to collect data into same format. Now, these kind of experiences we tried to do or experiments we tried to do in our country, but they failed. I realized we tried to do some registries, only 1 or 2 net registries have been successful. But otherwise, if you find many of the kind of data collection online in our country did not work, but now they have been trying to work at a global level and trying to these kind of collaborative research to find out some kind of conclusions. Now, these kind of studies are still at a level of say infection or outcomes which are non-surgical. Most of them are trying to find out whether we can compare it, which many times you could have compared with the routine papers also. But now with the collaborative surgery, it has more validity because it has been conducted in a little satisfactory way. This was a very nice article which came in BJS in 2022. And it said collaborative research in surgery, a rising tide lifts all boats. Very interesting editorial, you should really read. But the most important part I want you to read is the single center retrospective study of extravagant, highly subspecialized surgical techniques based on a small case series is dead. We must recognize that the time and energy spent by researchers and staff is better served in answering bigger questions that will translate into tangible improvements in patient care on a national or a global scale. As a community, we need to put patient benefit first and fully support multi-center prospective collaborative research. Now, this is what is the message they wanted to give. I'm sure everybody understands this message, but to convert it into something kind of a collaborative research in our country has been very difficult. Though our associations again are trying. The only successful, I thought, countries which could do this were Japan, Netherlands, and some of the European countries where they collate the transplant data and all that kind of thing. But other places, I think, especially routine GI surgery, they are not able to really do this. This was another good initiative called as an academic surgical collaborative, a trainee research collaborative. Now, this was quite recent kind of a collaborative where the resident himself can be involved into this kind of a research. This was from BMJ Open 2023. And they said how surgical trainee research collaborative achieves success as a mixed method study. They tried to involve qualitative plus quantitative study. And in fact, they said trainee surgeons are mostly motivated to engage into these trials, and trainee engagement into these trials can enhance through the building relationship of key stakeholders. So they were trying to use trainees for this collaborative research than established surgeons. So there are a lot of benefits and advantages of collaborative research. I'm sure if you go through literature, there are enough number of studies are coming up. Increase access to the resources. There are multiple people involved into this. Improved communication and collaboration. Today, I think communication and collaboration has improved tremendously. And with mobiles and laptops, I think we can really have in these kind of collaborative studies. Creation of new ideas and perspectives. Of course, there are some limitations and disadvantages. Collaborative research can be difficult to manage. You have to have a good manager to do this. Takes longer time to complete. It is expensive because you have to involve so many people. Collaborative research can lead to a loss of control. A particular center may lose its control, and this is what most of the fears surgeons have. It can be difficult to replicate because again, this is something which we need to think. So this was one scoping review in 2021, current status and future perspectives of collaboration in surgical research, a scoping review of evidence. And what it really said, it said collaboration is crucial for advancing surgical research. Addressing challenges and leveraging technological innovations will improve research efficiency and outcomes. Greater integration of information technologies. Like today we have telemedicine and shared data, and enhance global collaboration with LMICs, and encouraging data reuse and sharing to avoid duplication and maximize. So I think the world is changing from RCTs to big data analysis and now towards the collaborative research if it is possible over a period of time. So to conclude, actually, collaborative research is a valuable tool for researchers in many different fields. It allows for sharing of resources and ideas and can lead to new discoveries and advancements. It is important to keep in mind, however, that this type of research does require dedication and coordination among participants in order to be successful. And I think this is where the most crucial point is to bring everybody together on a same page. If you are able to do it, I'm sure India can also do this collaborative research. Thank you so much.
We can have one or two questions from the audience if.
Chiranjeev.
Just recently, Dr. Vinay Kapoor last year has collected data throughout the country, you must be aware, on the carcinoma gallbladder. So is this data collection, which is retrospectively, can we call it a collaborative research, or it is just a consensus information guidelines?
The kind of
But certainly
collaborative
what you
research.
talk is it takes away the bias which Dr. Kate has
Right, sir.
highlighted, which is usually in the RCT. That bias is certainly removed in this collaborative.
Dr.
What would-
Khandelwal, the biggest problem is the quality of data which is retrospectively collected. You know, we really don't know if somebody is talking about CA gallbladder from any center. Are you sure that retrospective data of 10 years ago had all the parameters which were well documented? Now that's where the problem is. So if you are able to assure that the quality of data is good and then it is put properly and then or the documents are properly, I'm sure. But for that, you need to have a protocol or format which is previously calculated. Therefore, many times you find these retrospective studies in our country, they have a issue about data. But if the data are good, I'm sure they are collaborative research.
Yeah, so my comment would be it is the time for the societies to kind of come to the fore and bring these people together for collaborative research. Like you said, for customer gallbladder, the format should be decided by the society, and whoever wants to join should join. Then you will have reliable data which can be useful for the community.
Sure. I think we have tried this before. There's so many ideas people have used this. I've gone through so many times the discussions, but this has not really worked out. Maybe probably the The generation Z and generation X would take now lead and they would do this. That's what I personally feel. I think this is what we have to really, good networks we have actually, but we are not able to convert them into collaborative research. Sure.
Thank you, sir. Thank you very much. Let's conclude the session. Thank you.
Thank you so much. Last but not the least, our next panel discussion is based on approach to PNET with or without men syndrome, case-based panel discussion. I would like to invite the panelists, Dr. Vikram Chaudhary from Mumbai, Dr. Kunal Parashar from Patna, Dr. Abhirasha Anand from Patna, Dr. Shekhar Kechri, Radio Oncology Patna, and Dr. Arvind Kumar, Oncology, stage and take their respective seats. Also invite the moderator of the session, Dr. Puneet, kindly come up on the stage. Thank you, sir.
I think a lot of people thought the net meant the chunni, where, and they all escaped away through the net. While my panelists get together, 5 of them, so it's a proper panchayat. We're going back to local self-government. We have Vikram, Kunal, Shekhar, Abhilasha, and Arvind. So there's so many, societies giving various suggestions, guidelines, a whole lot of departments involved, a lot of specialties. I think we really need a sort of a Mahapanchayat to actually look at all these issues. So we're not, since this session has been about controversies, we're not going to, so wherever this is a surgical society, we are well aware that if a complete resection is possible, wherever, whether it's a primary or the metastasis, then surgery is the best treatment, no doubts about it. All the other treatments come in only if either it's beyond that or the patient is too sick to undergo surgery or any other contraindication. So we'll restrict the agenda to certain items because I think given the time, we won't be able to cover the entire thing. So basically, we'll be covering dual phase imaging, biomarkers, biopsy and grading, metastatic disease, and the men, at least an approach to the men. So to come to the first case, youngish guy with pain abdomen for 10 months associated with generalized weakness and weight loss, which is usually at variance with the usual metastatic disease. Even liver mets in nets comes in, absolutely hale and hearty. This comes with an accidental report of, so this he's come in with this kind of symptoms. Ultrasound shows multiple hypoechoic liver lesions and a pancreatic body lesion. The biopsy suggests to grade 2. The Chi-67 is 10%. Has received already long-acting monthly sandostatin for 3 months. However, not much relief in symptoms, and now referred with persistence of the abdominal pain. So what would the panel think about imaging approach in this case? So I'm doing it reverse because a lot of times we get stuck in this towards the end and then there's no time for that. So the important points we wanted to make was wanted to be covered. Yeah. Vikram, you want to start off? Take the.
Endocrine tumor and it's a grade 2. Yes, so we could go ahead with a gallium-68 DOTA PET CT.
Showing nice metabolic activity. So ultrasound and CT, while good, imaging tools anatomically, I think the functional is probably much more important, isn't it? So what is the difference between all these DOTA, TATE, TOC, NOT? The proliferation indices don't match with the sort of clinical status and the disease burden that we are seeing. Is there a need to do any other imaging?
So
yeah.
so the DOTA is the linker.
and that tate comes from the octreotide, and whatever knock comes from octreotide. So that is the actually version. You can see that is the DOTA is the linker from the gallium-68, and this is tate, TOC, knock, all are similar. And this is the depending upon sometimes, somatostatin have the type five receptors. So this is actually binding to that particularly TAT. If you can see that is type 2, its binding is more. And then if you talk about the TOC, this is again bind to the 2, 3, 5, and knock again to 2 and 5. These are the difference you may say, but almost investigation wise, this the term almost similar and have that same advantage.
So, so the only place where probably it's not that good is it? Yeah, Vikram, you want to add?
Clinician probably it won't make a difference because they just have to order a gallium-68 DOTA. The pet specialist who is going to whatever is available at that institute or center is.
Yeah, that's probably just as good. The differences are not that much. It's just that gallium is a shorter acting, so it's more sort of diagnostic. The for therapeutic you use the similar tagging, but for longer acting analogs, lutetium, yttrium, and all those. So and insulinoma is probably the only one where these are not that effective. So you use Xend in the GLP receptor kind of ligands. So what about FDG?
FDG PET, definitely for such cases, you can ask for it. Ideally, in ideal situations, FDG PET is not recommended for the grade 2, but dual imaging may help you in different way. That is the scenario. And for once there is the rapidly progressive disease or grade 2 or well differentiated grade 3 tumors, in these situations, FDG PET can help it out. And there is some heterogeneity kind of thing. Then if you may find of FDG avid lesions as well as DOTA, this gallium avid lesions, but you can find it that, but it can be coupled in special situations. It's not like all the times you should recommend for FDG PET.
Yeah, so I mean, suppose cost was not an issue, would you then do both at baseline for every patient?
Yeah, I think FDG PET is for any net lesion which are poorly differentiated, which has lost its neuroendocrine differentiation, aggressive tumors, just like a carcinoma. Now it is behaving like a carcinoma. Then FDG PET will be in the investigation. Otherwise, I think grade 2, it's doubtful. The role is doubtful.
So yeah, so there will be an overlap. So I think there'll be some amount of interlap in all the tumors. It's much less in the earlier grades. It's much more of FDG positivity in the higher the proliferation index. But basically, if it's you should couple it if it is like he said about heterogeneity. If there is a disparity between the clinical course of the disease, this patient has the symptoms are not matching. Yeah, Vikram, you want to say? Yeah.
The disease burden is huge. Heterogeneity is likely there. So the DOTA uptake is not matching with your expectations and the large tumor burden, it is likely that there are other tumor areas which that becomes one of the indicators. Grade 2 disease progression, inoperable no, but at least grade 2 and disease progression are obvious indicators. Grade 2 towards higher grade, beyond 10, what follow. But with exceptions, with earlier patient, some of these patients it will act as a rather than any.
Absolutely, absolutely. I think that's a very crucial thing. Also, I think poor performance status, irrespective of the grade, because you want to pick up all the outliers. You don't want to do any aggressive therapy in these patients. So we can personalize them much more because we know where the FTG is avid, particularly if there's a disparity between the FTG. So the crucial thing is the disparity between the FDG and the. So if the same lesions which we saw on this, if the FDG lesions are more than the octoscan ones, then all the hormone-based treatments are going to fail. PRRT, expensive treatment is going to fail. The LARs are going to fail. So we might as well start them with chemo and other treatments, other targeted therapies. So that's a very crucial thing that if you can do, it's probably a good thing, but with the resource constraint settings, we just saw what settings we might actually use it for. And so that's how it helps us, devise the kind of treatment. I'm not going to go into details for that, but it's pretty intuitive that the ones which are the somatostatin receptor positive are going to respond to all the hormone, the octreotide based therapies. So what about comparing them in this? What is the impact of PET in G1?
Not much impact because as we see the last slide also, the impact basically as the differentiation lost, then only we are able to get something on the PET.
Okay, so it is basically a visual interpretation, isn't it? So that's comparing the PET DOTA with the FDG PET. DOTA PET is the gold standard for the functional nets with a high sensitivity and specificity. Excellent resolution. So we can see very small lesions and the SUVs, we in FDG we are talking about 4, 5, 6, 12. Here you can see up to 30, 40, 50 also. It's excellent for initial staging, response evaluation and follow-up. However, it is limited by availability. PET is much more easily available, but I think it's just an issue of logistic rearrangements, and it is possible. If the caseload is not that much, it can be done either pooled in a certain centers or can be done, at a certain interval, more periodicity, once a month or twice a month or something like that. FDG is not a good tracer for low grade, but excellent for prognostic marker for bad prognosis and a low disease control and progression-free survival. So to sum up, the indications would be a relatively higher grade with a higher Chi-67, early differentiated G3s, and where there's a progression in low grade, which is not explicable, by just the grade alone. And, we've covered all the other association of increased sensitivity. And you can change the therapy, as Vikram said, and step towards more personalized medicine. So coming to the issue of biomarkers, so we used to see a lot of chromogranin and all that. What would you say is the role for chromogranin these days, and any other new kid on the block? The sort of proprietary net test and all that.
Serum chromogranin has got a very poor specificity, so that's not a diagnostic marker, but they are very good for tumor response to any kind of treatment, as well as in follow-up and also for prognosis.
So screening, would you say they're good for screening? So family screening, follow-up of patients where it was high initially. What about HIA, 24-hour urinary HIA? So probably not so much in pancreatic, it's more for the midgut and for the others. What about net test?
It's got a role now, the liquid biopsy, and very good prognostic marker also for follow-up cases. And the values will indicate progression and overall survival.
So, Vikram, you want to add?
So I has been around since last years, but
I think you've done some validation study in Tata as well, isn't it?
that is a REN Laboratories, German lab, which actually does it. They have some, but I don't think it's directly done. That's a limitation, but actually it is a very good test. With a single test, you can actually for disease response.
So very quantitative, isn't it? So because of the number of
we don't have it available.
So, but it's something to look forward to only when there's a demand. All these years we said for hepatectomies that ICG is not available. The moment robotic surgery came, ICG is now in every nook and corner, every gully kucha.
Chromogranin, I would say it's overused, then it helps us. Costly also. Curatively treated patients, follow-up, that would be a better option than imaging, but or at a baseline for prognostic. But otherwise,
high false positivity also, high false positivity in renal failures, proton pump inhibitors, all those. So NetTest does have a lot of benefit. Does look like a exciting thing to look forward to. It is quantitative, so you can actually have values which you can assign and decide whether it is recurring or not, residual disease is there or not, whether we need to change therapies or not. So in combination with those imaging tools, it can be extremely useful, especially when you want to wait and watch as well. So what about the pathologist? What is the role
In the management of net, it start with the role of the pathologist is the cornerstone. We should means a very expert pathologist, because grading is it's not it is a subjective test.
So how would you grade your own pathologist? What all do you want in a good report?
Actually, this see, neuroendocrine is a rare tumor. Ideally, this should be the reporting should be a institutional based, from where the high volume cases are there, whatsoever high volume cases, because what be grade 1 for me may be grade 2 for someone else. So anyone who has working at a high volume center, I can't.
Yeah, so I think what's important is that they need to look for hotspots. So I've seen a lot of reports saying 5 to 10%. So those are not done. So I think you need to have sensitization of.
Expert, somebody who is willing to put an effort to actually manually count the signals. Can't have a good proper actually manually have to count it properly.
So variety of you can actually take photographs of the hotspots and manually count it. That's what they do in my institution. I've seen the Tata reports also. So they actually look at the hotspots only. So the range should not cross the the grades. So it's a single most important prognostic. That's why it's the grade, and the WHO is keeping on. So just to most of you are familiar with this, but Vikram, would you just like to tell us the updates? What has changed in the latest
I think introduction
iteration?
of grade 3 neuroendocrine tumor was the main change. So previously grade 3 was considered as a cancer, small cell or large cell, but now there is something called as grade 3, the well differentiated tumor. Though it is grade 3 and MIB is more than 20, it was more like a well differentiated tumor and not like a NEC. Therefore, it has been identified as a different different entity. And the second change was change of terminology of manic to minin. That was also changed. Manic was little restrictive terminology, which
Mixed adenoneuroendocrine tumor.
but now
So
the
a mixed
all types of
all non-neuroendocrine and neuroendocrine tumors. Absolutely, I think that is also a good. Do you see that this is still in evolution? I personally feel we might be seeing G4 as well. The higher than 655, because they all behave. I'm wondering why they've never been introduced this. I think the pathologist's role has been reducing in all the iterations of both the ENETs and WHO.
It was discussing the pathologist WHO that beyond 50. 7 was their cutoff, but there's such that it beyond 60 another grade.
Because even the treatment changes completely. It has to be a platinum-based therapy and things like that. So that shows you beautifully how the entire survival is dramatically different for each of those grades. And if there are outliers, it's because of heterogeneity and poor sampling. So that's why those biomarkers and imaging tools are extremely useful. So putting them all into perspective, I think you get a better picture of what's going on. So what should be the approach now in this patient? Kunal, you've been keeping quiet.
This patient, as patient is already on LAR, and they don't have much of receptors, so don't expect PRRT to. First, we'll start with chemotherapy.
So there's much more of the FTG uptake as compared to the. Vikram, you want to take that?
So for me, there is a significant DOTA uptake in this patient. It is grade 2. There is an FDG uptake also, so it has a baseline dual uptake, but the predominantly it is grade 2, 10% with significant Crenning 4 DOTA uptake. So this patient is a candidate for PRRT plus minus chemotherapy.
But if you get more lesions which are not DOTA avid but are FDG positive, would you still go with PRRT then?
DOTA uptake more than FDG.
No, I'm just saying, suppose I agree. So,
They're forced to.
so they were coalescent in the DOTA, they were coalescent areas, and in this it was more discrete. But suppose you see extra lesions, would you still? So an expense probably you would not go ahead with PRT,
This
isn't it?
patient probably at my center would go for a trial. We have a trial which is comparing chemo versus PRRT versus chemo PRRT in these grade 2 patients. So if the patient comes in trial, it will be either PRRT or PRRT chemo depending on the arm. If not coming in the trial, considering the disease burden and overall uptake, will be patient counsel for PRRT. And
So would Arvind or Vikram, anybody like to talk about the
Thanks,
NETA 2
sir.
trial? Yeah.
Things are important here as a DOTA uptake and FDG ABA also. That's we should be like what I'm agreed with, that PRRT plus minus chemotherapy, that is the valid options for him. Because PRRT, you can't skip it out like once the DOTA uptake is there. And that has shown a really wonderful results, and 80% has been, that are progression-free disease. And that was FDG AV, definitely you are nowadays centers are practicing this PRRT plus chemotherapy and didn't have that much significant side effect as well. Then and you have to choose some drugs like which are very much tolerable.
So what would you choose for a G2
Yeah,
preferentially?
like see, for the PRRT also what I want to discuss, once there is some centers we are practicing like capsultabine as a radiosensitizer as well. That is very much important drug. But once you take about like this is temozolomide plus
Temozolomide, yeah.
capsultabine, that has been in different solid tumors as well. They have been used in various conditions. That drug is very much useful for such conditions. And PRT plus temozolomide plus capsultabine. That
So
is
Cape Tem is a fantastic combination for this. And I think we have some more personalization possible because temozolomide, you can actually predict the responsiveness by MGMT, methyl guanine, methyl transferase. I think that can predict whether the tumor is going to respond to temozolomide or not. So the second case is I keep hearing this whether we should. It's well known in midgut tumors that you can, if there is a metastatic disease, you can, there is enough evidence that you remove the primary. What about pancreatic tumors?
for that, you will get a lot of series suggest that there is a benefit, but a patient has been treated extensively, treatment options has been stable for years together, and then probably once you either are able to target the liver disease or if the primary is resectable, these are the situations where you would consider a resection of the primary after a stable disease for a long period of time. But not for all, because all these series are there are a lot of series, I know that, and the survivals are reaching usually
Yeah, so some yeah, absolutely. So this I think systematic review shows that
selected patients out of 100 patients, that the 10 patients who were offered primary. And there is a cohort of patients who were not offered surgery, they're not part of this. Yes, it is an option for patients who have a stable disease for a long time, and then removing the primary probably takes away the stimulus, but it's an option for.
so some very soft data, but not very convincing across all the trials. I don't think we can recommend it across the board the way you can for midgut tumors.
Studies, they have also taken the functional tumors. Those cases, there is definite advantage of debulking also.
Right. So yeah, so again, the debulking concept, I think it's now changing. For earlier, they used to say 90%. Now they've got lower thresholds at 70% as well. Midgut, I think another issue is that the primary can get symptomatic also, obstructions and all those fibrotic things that can be there. Pancreatic, that much is not there. So unless they're functional, there's a slightly higher threshold along with the potential for complications. So liver limited disease, anybody would like to take, what are the options in early grade tumor and how do you choose?
It's if just limited to the liver, then obviously trace and tear we can think of at the earliest because it's we have easily available at at almost all the cities. And if not, then other options further PRRT or liver transplant. But I think TACE and TARE local therapy, I think ablative therapy first line.
Abhilasha, do you want to say where would you select for liver transplant?
The resectable metastasis, if we can go for a non-anatomical resection and debulk, then first thing we should go for that. There's definite role for transplant, but depending on the tumor biology, if
So very, very selective. We have those Mazzaferro criteria, very, very selective. Not the way Steve Jobs went and enlisted himself in every program in the country. It's probably you need to show. Yeah, Vikram, you want to say?
Liver therapy, just because there are options, not because a lot of patients, first line treatment, a lot of patients are have PRRT. After that, if your intent is then probably controlling the liver other measures. Otherwise, it doesn't make sense after the liver lesions. And if your primary is in the pancreatic head and if or primary, whatever liver therapy you are going to do is not surgical, have consequence. AE, they can have liver abscesses, other complications. You have to balance those depending where to offer what. The distal pancreatic primary, you offer a liver to balance it out. Again, the liver diet treatment is not for all the patients.
Yeah, just because we have all the options available, that's exactly the point I wanted to say. It's not mandatory that we have to do them. Specifically, transplant, I notice it said very loosely in a lot of places. So it needs much more rigorous criteria that there should be absolutely no extrahepatic disease. There should be a gap between the primary and the appearance of the secondary. So not to be taken lightly. Completely agree. So would one of our onco friends tell us take us through the advanced treatment options in brief?
Treatment options in I think still in pancreatic net or overall in net, it's disappointing. Apart from sandostatin LAR, once the disease progresses, then some patients goes on with Captem for sometimes, and we can add the TKI which you have highlighted like sunitinib and everolimus, but still I think these are some symptomatic relief.
So definite evidence. There is a sort of negative thing about toxicity and all that, but there is definite evidence that you can progress on with the other everolimus, sunitinib.
But I have seen there is one drug, irinotecan, sometimes it do wonder, though in the rare scenario that I have experienced in my whatsoever practice.
Okay.
Irinotecan.
Right. And for the negative, for the somatostatin receptor negative, that's more of your domain, isn't it?
Negative, more or less same, sir. Chemotherapy definitely.
So LAR will probably not be in the
Yeah,
algorithm,
LAR will be not
not
there,
be in the
chemotherapy,
algorithm.
yeah.
So yeah. And if it's a higher Chi-67, then platinum based. Otherwise, yeah, okay. So and whatever fails, you try the other one. So choosing one over the other is more on the acceptability and toxicity profile of that particular drug and the patient itself.
The sequencing is very important here. How do you sequence the patient and how do you symptomatically progressive or something like that? But once you talk about the erlotinib versus everolimus versus sunitinib, that is have got same kind of progression-free survival. You have to choose the drug. I think sunitinib has a little bit more advantage, almost as compared to the median progression-free survival in place of everolimus. And for the once it's positive, definitely you have to sequence very particularly about how you can select PRRT and everything in between, because once it's in between, if you sandwich, that is very important to patient to respond for such patients.
Right. I mean, I'm very impressed with the high dose of everolimus when we give for transplant patients. There's much more of toxicity. So I'm surprised how they've tolerated in those studies. I don't know if it's a trial halo or what is the experience of anybody in the house as anybody with okay. So, but I mean, literature-wise, there is definite evidence for that. So we now come to our next case on men. This is a 38-year-old housewife from Bihar, no comorbidities, upper abdominal pain, retrosternal pain. Ultrasound shows a pancreatic body lesion. CT shows multiple lesions in the body and tail. The endosonal biopsy shows well differentiated net grade 3 with a Chi67 of 30%. FDG PET, no uptake in the FDG, no uptake. So, no uptake of FDG in the pancreatic lesion. DOTA PET, multiple nodular lesions in the pancreas, largest 3 centimeters, SUV of 26. The system AB scan actually shows suggestive of parathyroid activity. So, what would you infer, Vikram?
You said the MIB is 30, but the FDG has no uptake. MIB is probably overinterpreted or whatever it is, but there is a DOTA uptake, but the lesion is 3 centimeter. Patient has symptoms. Patient has parathyroid disease. This is likely a case of a Menn syndrome, is what I imagine. And
Those are the gastrin and chromogranin.
yes. Apart from that, I think parathormone and serum calcium and other evaluations, prolactin levels will be done in this case, and probably a pituitary MRI and germline mutation testing. And yes.
So how long? I mean, how frequently would you like to do those? Actually, if they're not, if the patient is not symptomatic for that, can you get away with things like field, field examinations or?
Problem in men patients is the lesions. There will be multiple lesions. This patient, the excuse for surgery is the lesion which is larger than 3 centimeter. Patient is symptomatic, and it is MIB of 30%. Also slightly aggressive. That's my excuse. Otherwise, patients who have multiple small lesions go out, or if they are metastatic more often than.
Or if they don't respond to the high dose PPIs and all that, yeah.
That's the treatment. So most of the times the observation is the plan, but this patient probably is a candidate for.
So this is MEN1. So endoscopy also shows. So the MDT clinical decision was distal pancreatic splenectomy with parathyroid excision. So that's what was done. Uneventful recovery. The HPR showed 5 tumors, largest 2.6. So those are the MIBs. The parathyroid lesions were just hyperplasia. So they were advised observation and genetic testing of the family. I think that's probably one important lesson here. Is that you can actually screen and find the lesions at a treatable time, or when they're just symptomatic or pre-symptomatic as well, as Vikram alluded. So how would you time? So after 24 months, the son presented with multiple episodes of vomiting. The daughter showed a lesion in the D2, D3 with a large caval node, with now somatocertain receptor activity in the right inferior parathyroid. The genetic testing done earlier showed MEN1 gene positive in the genetic analysis. That's the serum calcium, parathormone, and the node biopsy shows a grade 1 G1 lesion. So after 12 months of follow-up, there's increase in the dyspeptic symptoms. The DOTA shows avidity in the D2, enlarged caval nodes, and low expression in the enhancing nodule in the peripheral aspect of the right lobe as well now. So what would you do?
In this, they mentioned that best option adjuvant.
So, I mean, that is one of the, because it's always been controversial, when Vikram would remember when we did the AP nets in Cochin, we put this neoadjuvant as a treatment. The guy's first slide was, "You must be joking." So, it's come a long way from then in just a short 7 years.
In
Yeah.
retrospect, I feel PRRT was a clean patient could have been avoided. Problem is, when we started, there were liver lesions, planning to observe this patient, not offer surgery. Then probably, but otherwise, even R would have been an option. A PI could have been, but
For symptomatic control. Okay.
and then because it progressed.
So it's still possible to give neoadjuvant and try and get a,
Been avoided is what I
Yeah. Okay. But I mean, I get your point that you're saying it's palliative intent, but you might get salvage of somehow. I think that is the idea of showing this. You might get a salvage. You'll have to hold it a little closer. The salvage is possible with a neoadjuvant conversion therapy, if you like.
If you would have been given that 4 cycles would have been given that two cycles, it's not like it's in
Okay.
every
No.
8 week it has to be
Point.
repeated or 4 cycles. If it has to be given.
Right. Point. Okay.
One more question I also have. The liver lesions were limited to segment 8. They were resectable by liver
Yes.
standards. So why palliative intent and why not go for primary excision and liver
No,
resection?
I mean, in the sense that the intent will be actually once there is metastasis, there is an intent, but you try to convert it into a resectable disease.
Young
Absolutely.
patient, MIB is less, we can go for complete R0 resection.
No, yes, absolutely. If you can, wherever you can remove the entire thing, absolutely, it is the best treatment. That's the starting line. That's the last line as we come towards the end of the thing. So advised to follow up with DOTA after 4 months. That's the brother also had the same genetic mutation, but no clinical disease. So how we need to observe and follow them up again.
4 months is little too early. Metastatic disease curatively treated. R0 resection here even and biochemical, that is some cost effective. Yes, and the brother needs to
Follow up as well. Yeah. Okay. Yeah. I think coming to the end of that. Any audience questions or any questions the panel has, the panchayat has? I think we've saved some time for the organizers. Anything from the largely attenuated, netted out crowd? If not, I think we can call it a day. Thanks a lot to my panelists. You want to say something? Yeah.
Thank you.
Okay.
Thank you, sir.
Well, what an insightful day. Indeed, enriching and enlightening for each one of us. However, this is not an end, but a beginning of a journey towards learning and wisdom. As the official inauguration of this great grand CME is about to begin in few minutes, I request all the delegates and dignitaries to kindly remain seated in their places. I request all of you to remain seated. The official inauguration is about to begin in few minutes. I request once again to kindly remain seated. We are just about to begin with the official inauguration of this CME.
आ जाएगी अब कैमरा मीट लाइट इट गेट बीट लास्ट में
ये आ रहा था ये किए थे वो लोग वहीं पर चेक करा स्क्रीन पे नहीं मेन स्क्रीन पे नहीं देना
नहीं नहीं
हाँ
Please, Mike. Good evening, ladies and gentlemen. I, Ekta, your host today, welcome you all to the iasgcon, the 34th annual conference of the Indian Association of Surgical Gastroenterology, hosted by the Department of Surgical Gastroenterology and Liver Transplant, IGIMS, Patna. This time, the theme of ISGCon is controversies and debates in the surgical gastroenterology, which is going to be a beacon of scientific excellence in the field of gastroenterology in India. We are delighted to unite national and international faculties at one platform to contribute their knowledge and skills to enrich the field of gastroenterology in India and neighboring countries. Now, without any further delay, I would like to invite our chief guest on the stage, who is already there on the stage, Shri Honorable Shri Mangal Pandey, sir. He is already with us in the on the dais. Now I want to invite GV, our President IASG, to kindly come up on the stage. I Dr. Rajesh Kumar Singh, Secretary IASG, to kindly come up on the stage. Next, I feel like to invite Dr. C. Khandelwal, Organizing Chairman, up on the stage and grace his seat. I invite Dr. Manish Mandal, Organizing Secretary IASG, to kindly come up on the stage. I request Dr. Virati to felicitate our Honorable Health Minister, Shri Mangal Pandey, with a floral bouquet. I request Srimati Shweta to felicitate Dr. G.V. Rao, President IASG, with a floral bouquet. Sister Saija to present the floor to Dr. Singh, Secretary IASG. Request Sister Ruby to present floral bouquet to Dr. C. Khandelwal, Organizing Chairman. Also request Sister Saroj to present floral to Manish Mandal. Let's begin our event by lighting of the lamp of knowledge and wisdom. The symbolic moment that signifies the dispelling and uniting minds with true values and progress. Request all the dignitaries to kindly assemble towards the lamp. Now I request Organizing Chairman Dr. C. Khandelwal for welcome speech to come up on the mic.
सभागार में उपस्थित मेरे प्रोफेशनल फ्रेंड्स, ये बहुत मेरे लिए बहुत ही गौरवपूर्ण क्षण है, जबकि आप सब लोगों के सम्मुख आज के इस कार्यक्रम में आप लोगों को पता है कि ऑल इंडिया सर्जिकल गैस्ट्रोएंटरोलॉजी का वार्षिक अधिवेशन मिलन है। उसमें हमारे बिहार के बहुत ही कर्मठ और लोकप्रिय नेता श्री मंगल पांडे जी आए हुए हैं हम लोगों को प्रेरणा देने के लिए और इस कार्यक्रम का उद्घाटन करने के लिए। उनका स्वागत करते हुए मैं अपने को बहुत गौरवान्वित महसूस कर रहा हूं। मैं चाहता हूं कि आप लोग मेरी इस खुशी में आप लोग भी सम्मिलित हों और करतल ध्वनि से उनका सम्मान किया जाए। और उसके बाद तो इच्छा है कि आप लोग जो देश के विभिन्न कोने से आए हुए, केरल से लेकर के और आसाम तक और देश के हर क्षेत्र से जितने हमारे करीब करीब 500 लोग आए हुए हैं, आप लोगों का स्वागत है भारत में, बिहार में, पटना में। इस सभागार में कुछ लोग पटना पहली बार आए होंगे और बहुत से लोग ये सभागार पहली बार देखे होंगे और कुछ लोगों का भ्रम टूटा होगा कि बिहार में, पटना में क्या व्यवस्था हो सकती है। मैं समझता हूं कि जाते जाते आप लोग महसूस करेंगे कि आप लोगों के स्वागत में किसी तरह की कमी नहीं हुई है और अगर कमी होगी तो उसके लिए दोष हम लोगों का है। अदरवाइज बिहार की जनता, बिहार आप लोगों का सर आंखों पर आप लोगों का सम्मान करना चाहती है। हमारे बीच सर्जिकल गैस्ट्रोएंटरोलॉजी के अध्यक्ष आज के वर्तमान डॉक्टर जीवी राव जो हैदराबाद से आए हैं और वहाँ एक बहुत बड़ा हॉस्पिटल के मुख्य पदाधिकारी हैं एआईजी के। मैं उन्हें सम्मानित करते हुए मैं भी गौरवान्वित महसूस कर रहा हूं कि आप इस कार्यक्रम में आए हैं। आप अध्यक्ष हैं, आप ही का कार्यक्रम है और हम लोग संगठन करते हैं, हम लोग आपका सम्मान करते हैं। एक बार जीवी राव जी के लिए भी एक बार ताली बजा दी जाए। हमारे कलीग डॉक्टर रजनीश सिंह जो कि एसजीपीजीआई लखनऊ में हैं और इस संस्था के सचिव हैं, आपका भी स्वागत है। और हमारे बीच बहुत से लोग हैं, मैं नाम बोलना चाहूं तो समय लगेगा। हमारे बीच में काफी इस सर्जिकल गैस्ट्रोएंटरोलॉजी के कुछ पास्ट प्रेसिडेंट और कुछ सीनियर लोग भी बैठे हुए हैं। इंदिरा गांधी के पूर्व डायरेक्टर भी बैठे हुए हैं, डॉक्टर दिलीप यादव, महावीर कैंसर संस्थान के डायरेक्टर सन्याल साहब और पूर्व अध्यक्ष में डॉक्टर आर एस शास्त्री, डॉक्टर काटे और भी लोग यहाँ मौजूद हैं। एम्स के बहुत सीनियर डॉक्टर पीयूष साहनी, आप सब लोगों का मैं व्यक्तिगत रूप से और संगठन की तरफ से, ऑर्गेनाइजिंग कमेटी की तरफ से आप लोगों का सम्मान करता हूं, स्वागत करता हूं और अपनी वाणी को धन्यवाद देता हूं। आप लोग एंजॉय कीजिए इस कॉन्फ्रेंस के, हम लोगों के कार्यक्रम का जो संगठन को और हम लोगों की जो एकेडमिक एक्टिविटीज होगी उसको आप लोग, मुझे पूरा विश्वास है कि आप लोग एंजॉय करेंगे। धन्यवाद।
Dhanyawad, sir. Now, I would like to invite Dr. Rajneesh Kumar Singh, Secretary IASG, to say a few words to this occasion.
Very good evening to this august audience. Honorable Minister, Sir, Professor Khandelwal, Dr. Manish Mandal, the organizing team of iasgcon 2024. Thank you so much for organizing this huge event. And yes, आपने सही कहा खंडेलवाल सर, भ्रम तो टूटा है हमारा। हम सोचते थे कि शायद बिहार में इतना कुछ नहीं हो पाएगा, but seeing this entire big hall, it was a big surprise. And I welcome you all on behalf of IASG to this mega event and hope that we have a great time in the next 2 days. May I request our President, Professor G.V. Rao, to deliver his presidential address at this point.
Good evening, Honorable Minister of Health, Dr. Khandelwal, Dr. Manish Mandal, Rajneesh Singh, past presidents of Indian Association of Surgical Gastroenterology. I feel very humbled and honored to be standing before you as the president of the association. I'm not sure how much I deserve this position. Looking at the past presidents who have occupied this position, at least I thought I could take this moment and pay tribute to all those people who occupied this chair before me. This is a small tribute to all the past presidents of IASG who have made this a big specialty and who have put surgical gastroenterology on the forefront of all the specialties across the country and across the globe. There were several doyens who made this specialty, several people who started this. All of them had made this specialty a memorable one for all of us. This is a small gesture and a token of gratitude from all the members of surgical gastroenterology to all the past presidents who made sure that this has come to this stage. A tribute to all those who made this possible. I must have missed out some couple of pictures, but I made sure I got this data from my colleague, Dr. Pradeep. We have tried to put in everything together to make sure that all the juniors here may not recognize, may not know some of these people. And it is just a matter of this thing to just to pay tribute to all these people. When it started, actually, we never knew actually how this specialty started. It started way back 1980s, actually. Slowly, it grew over the period of time, and it has become one of the most important specialties and most sought after specialties in the field of surgery. At the outset, let me thank the entire executive committee of the IASG for what all they have done in the last 1 year. I cannot mention each one of them, but two people are very important in this executive committee. Dr. Rajneesh Singh, the secretary of the association, and Dr. Sadiq Sikora, immediate past president, with whom I have been interacting for the last 1 year to promote, to help, to conduct some meetings, to help the students build up their career, to help students to interact with faculties both nationally and internationally. I'm not sure how much I succeeded in this, but I owe what all we have done in the past 1 year to these two people, Dr. Sadiq Sikora and Dr. Rajneesh Singh. Thank you, Sadiq, and thank you, Rajneesh, for what all you have done in the last 1 year with me. And I also thank all the executive committee members and the members of all the scientific committees of IASG, each one of them by name, who have made the science of surgical gastroenterology translate very effectively in the last 1 year. And my sincere thanks to the organizing committee of the 34th Annual Conference of Indian Association of Surgical Gastroenterology, each one of them who are making this a big event, and I'm sure there'll be a lot of interactions which are going to help the students in a long way. I just briefly go through what has happened and what I've experienced in the last 1 year, both as a president-elect and as the past and the president of this association. Now, this is a section of Association of Surgeons of India. It's a non-profit organization founded in 1988 by a group of surgeons with special interests in the field of surgical gastroenterology. The primary objective was to promote this subspecialty of surgical gastroenterology, and as of today, the membership stands around 1,400 people. It all started with surgical gastroenterology. People wanted this to promote as a single specialty, but what has happened in the last 2 decades is we started depending on other specialties like medical gastroenterology, oncology, interventional radiology, intensive care, transplantation, research, and it's become one of the most colorful specialties as in today. And we talk about gastrosciences rather than surgical gastroenterology as in today. We are dependent on so many people. Actually, I've seen the panel discussions that are happening. We're dependent on so many people to make this, translate this into a very, very effective thing. Though the primary objective was to promote the subspecialty, and we have supposed to conduct several conferences, both national midterm meetings across the country to collaborate international associations and to help surgeons exchange knowledge and skill. And we're also helping in conducting CME programs across the country. COVID pandemic has hit us very badly. We did not have conferences for 2 years. Subsequently, 2023 was the meeting that we had in Hyderabad. It was literally forced on us to conduct this meeting. And this COVID pandemic changed the entire guidelines in which we are supposed to practice. There were changing medical council guidelines. There were a lot of sponsorship limitations that happened actually, but surprisingly, with a lot of effort and support from the industry, we were able to successfully conduct this meeting in 2023. And I attribute this entire success to my team, led by Dr. Pradeep, who is sitting here in front of you. In the last year, we have conducted several meetings. Actually, Dr. Rajneesh, I think, will give you the details of all these meetings that are happening, both the midterm meetings and also some of these meetings which have been collaborating with the other associations. The most important thing has been to promote oncology and surgical gastroenterology. We have started doing this NCG tumor boards, which would help the students a long way, establishing themselves as surgical gastroenterologists and surgical GI oncologists also. A lot of effort is being made to promote this so that the students of tomorrow, the surgeons of tomorrow from this specialty will not go unanswered or will have their representation in the field of surgical oncology. We planned for a surgical leadership course to develop leadership skills among the thing actually, but this was supposed to be scheduled sometime in November, but now we are scheduled sometime in January of 2025 under the aegis of IASG. But as a preamble to this, we did the meeting on women in surgical gastroenterology. We had about 25 women surgeons who came, joined together, discussed various aspects of their difficulties and their ideas about surgical gastroenterology. And this is going to terminate in a meeting tomorrow morning where they're going to present whatever they discussed during this meeting back in Hyderabad sometime back. I'm sure this is going to be a big thing actually to leap forward to give representation to the women fraternity in surgical gastroenterology. Now it also encourages members to publish their original work and also to research. Unfortunately, there are increasing number of publications that are happening from the field of surgical gastroenterology, but we need publications in high impact journals. And the need of I feel, is some sort of multi-center trials. We've been talking about this. I hope something translates this in future so that we can have these multi-center trials, which will pave us to have some representation on the international forum. Either publish or perish. Actually, we as the senior faculty members of this association survived. But the junior faculty, absolutely, I'm sure, unless and until they're going to publish or perish, it takes a lot of effort to publish, to sustain the entire process of publication. And publication is the only way to grow. And I'm sure publication is the way to prosper also in future. For all the youngsters who are sitting here, unless until you have publications, I'm sure that you'll not have your platform to be standing before the august audience of surgical gastroenterology and talking about your experiences. This is very close to me that I thought I'd take few slides to talk about this. Current day surgical practice and the future of surgery is purely based on research. Hippocrates is one of the greatest physician surgeon. He is also a clinician, scientist, and a researcher. The highest honor that we present on the research is the Nobel Prize, which is instituted in 1901, and it was shared by greatest surgeons and scientists of yesteryears. Sometimes, and surprisingly, there is a decline in the surgeon-scientist species, possibly facing an extinction, and there is a lot of data to show that the surgeon-scientist breed is a dying breed. We had a lot of these people who had made surgical science a real good specialty, but unfortunately, this seems to be a dying breed. And if this continues, I think we're going to miss the road to the Stockholm. Research, basically, it is not necessarily that you're looking into the test tubes and working with some under the microscopes. Actually, there are umpteen number of types of research. Actually, Vikram, all these people have elucidated. Piyush has been the pioneer who's been taking this forward. Umpteen areas where we can do this, from basic science to translational to clinical to population studies. So there is no limit to what it can be done, but I'm sure the youngsters will take up this specialty. Unfortunately, this entire research seems to have taken a backseat even during our clinicals. What we expect is that this research should come back to us during the training period so that the students of tomorrow and the surgeons of tomorrow will take this forward. And there is a lot of difference between a surgeon and a surgeon scientist. There is a lot of difference between a surgeon and a surgeon scientist. And there is a lot to show that there is a lot of data to show that the surgeons must start doing some basic science work because they're the people who are closely associated with the patient care, and they're the patient people who can identify the problems and get some issues or solutions to this. Last few days, we have been seeing that the practice of surgery seems to be changing to minimally invasive, laparoscopy, robotic surgery. A lot has been said about this, a lot of data coming in from various, a lot of publications coming in. But a word of caution, I think you should take this with a pinch of salt whenever you practice this. Caution should be entertained. Evidence should be taken into account before you start practicing. And there should be some empathy when you're practicing this sort of minimally invasive surgery. Not just because somebody is saying that it is the best, I don't think you can take this forward. Artificial intelligence seems to be getting into every part of our life, and surgical gastroenterology is nothing short of it. We see right from diagnosis to patient care and patient follow-up. Actually, it seems to be getting into every part of our clinical life, and whether we like it or not, it's going to get into our practice. Surgical training also has changed from classical training to AI-inducted surgical training. This becomes very, very important basically because as in today, we see about 150 students coming out every year. And we see that majority, or not all of them, majority of them have difficulty in getting exposure to some clinical procedures which are not easily available. I personally feel that surgical training is very, very important. Hands-on skill courses are very important, and IAG is taking this initiative to conduct this to make sure that the students are trained in some of these procedures before they can do this physically. Congratulations to my own team member Shreyash, actually, who during this COVID team has innovated this basic laparoscopic teaching module from a basic thing that is picked up from one of the stores, actually. Incredible one. All you have to need to put is your iPhone or an iPad on top of it, and then you start practicing this. And my own students actually have been doing this, actually have incredibly benefited from this tool that he has developed. Robotics, again, it's a part and parcel, whether you like it or not, people have to get used to it. And then how much you have to use this in clinical practice is based on what your empathy and evidence that comes into clinical practice. There are a lot of simulators that have come into clinical practice that have made training very, very easy. Actually, Pradeep here is involved in the making of this simulator, which is almost mimics a human being in making this. Actually, we also have a robotic simulator. And we have a lot of other data that are coming in to show that how this can be incorporated into clinical practice. And the best part of this is this software which allows the surgeon to compare yourself to yourself, yourself to your peer, yourself to somebody across the globe, so that you know where you stand in clinical practice in the field of surgical gastroenterology. This becomes mandatory in clinical practice. I cannot keep thumping my chest saying that I am the best. I have to compare myself with the people sitting here in front of me. I have to compare people with somebody else across the globe. AI is coming to clinical part, actually every aspect, be it training, academics, everywhere, and also telemedicine seems to be getting in a big way. And this is how we're going to teach, train students in future. There are a lot of discussion among the senior faculty here as to how to take this forward, make hybrid meetings, make telemedicine a part and parcel of this association. We need a lot of to teach the students. I think we need these video data banks, and I urge the future secretary presidents to take care of this so that we have a huge video bank which can be utilized for training. And so much and said about the field of surgical gastroenterology. We also deeply hurt by the violence against doctors. A lot of things have been happening actually, but a lot of these things could be avoided maybe by some basic training that needs to be inculcated during the training period. But IASC strongly condemns violence against doctors, and we have officially sent our own letter of regret to the president about this some time back. A way forward is to believe in application of science to mitigate human sufferings. This is what I feel we have to practice. And to end this, I cannot thank my institution and all the support services that I have from my department, which gave me the honor of standing before this August gathering. I sincere thanks to all my department colleagues who stood with me, all the consultants, and all the registrars who have been working with me untiringly to make sure that I take this glory and I bask in this glory of whatever they're doing. And I sincerely congratulate, and I hope the future of gastroenterology, surgical gastroenterology, is in very safe hands. And I'm sure that the next executive committee will take this forward very effectively so that the students of tomorrow, surgeons of tomorrow, will be effectively trained, and the patient population will be very, very happy with dealing with this. Thank you so much once again for the opportunity given as the president of this association. Thank you so much.
Thank you so much, sir. Now, I take the pride of inviting our chief guest of the day, a person with very dynamic personality and commitment to hard work, whose contribution as a leader needs no introduction. I invite our Honorable Health Minister, Government of Bihar, Shri Mangal Pandey, to kindly address the occasion.
इंडियन एसोसिएशन ऑफ सर्जिकल गैस्ट्रोलॉजी के इस 34वें राष्ट्रीय अधिवेशन में हम सब लोगों के बीच उपस्थित आईएएसजी प्रेसिडेंट डॉक्टर जीवी राव जी, यहाँ उपस्थित डॉक्टर रजनीश कुमार सिंह जी, इस ऑर्गेनाइजिंग कमेटी के सेक्रेटरी डॉक्टर मनीष मंडल जी, चेयरमैन डॉक्टर सी खंडेलवाल जी, यूएई से आए डॉक्टर असफर एम साहब, नीदरलैंड से आई डॉक्टर लांसचोट जेजीबी जी, थाईलैंड से डॉक्टर असारा एंड डॉक्टर एनॉन, अबू धाबी से डॉक्टर विकास गुप्ता जी, यहाँ इस सभागार में उपस्थित डायरेक्टर महावीर कैंसर डॉक्टर तनियाल जी, दुनिया का दूसरा बड़ा अस्पताल जो बन रहा है, पट्टा मेडिकल कॉलेज हॉस्पिटल, उस हॉस्पिटल के सुपरिटेंडेंट डॉक्टर आईएस ठाकुर जी, आईजीएमएस के एक्स डायरेक्टर डॉक्टर डीके यादव जी, डॉक्टर उदय कुमार जी, डिप्टी डायरेक्टर आईजीएसी डॉक्टर अशोक कुमार सिन्हा जी, आज के इस अधिवेशन में उपस्थित देश के विभिन्न राज्यों से आए हुए सभी सम्मानित चिकित्सकगण, बिहार के हमारे सभी चिकित्सकगण और जिन लोगों का मैंने नाम लिया और उसके अलावे भी जो दूसरे देश से सभी चिकित्सक आए हैं, सभी चिकित्सक भाइयों बहनों, आप सभी लोगों का मैं बिहार की राजधानी पाटलिपुत्र की इस पावन धरती पर आपका स्वागत और अभिनंदन करता हूं आपके इस 34वें वार्षिक अधिवेशन में। मुझे इस बात की खुशी है कि 24 वर्षों के बाद इस प्रकार का आयोजन बिहार करने का अवसर मिला है। आईएएसजी के चेयरपर्सन डॉक्टर जीवी राव जी को कि आपने यह अवसर बिहार को प्रदान किया, बिहार को अपने इन गणमान्य सम्मानित चिकित्सकों का आगवानी करने का अवसर मिला और निश्चित रूप से आप सब लोगों के आने से बिहार की गरिमा भी बढ़ी है और मैं समझता हूं कि जब देश दुनिया के लोग अब आज के बिहार में आते हैं तो बिहार की बदली हुई तस्वीर को भी देख के जाते हैं। जैसा कि अभी डॉक्टर रजनीश जी बोल रहे थे, मैं इस हॉल को देख के बहुत सरप्राइज हूं। तो रजनीश जी, बिहार बदल गया है, बिहार अब देश के उन्नत राज्यों में से, और कभी 25-30 साल पहले वाला बिहार कुछ अलग रहा होगा, लेकिन आज का बिहार जो है, मैं हेल्थ सेक्टर की बात करूंगा तो हेल्थ सेक्टर में ये आज कई पैरामीटर्स ऐसे हैं जिन पैरामीटर्स में बिहार नंबर 1 पे है, कई पैरामीटर्स हैं, और तमिलनाडु, तेलंगाना, आंध्रा, केरला, कर्नाटका जिसको बहुत आगे माना जाता है, उससे भी आगे बिहार का हेल्थ सर्विसेज गवर्नमेंट सेक्टर में, प्राइवेट भी बहुत आगे गया है। बिहार बदल गया, मेरे कहने का कुल मतलब इतना ही था। और निश्चित रूप से इस बदले हुए बिहार में आप सब लोगों की आगवानी करके मुझे स्वास्थ्य मंत्री के रूप में खुशी हो रही है। और मुझे जब मनीष मंडल जी ने इसकी जानकारी दी थी, इस कार्यक्रम का आयोजन उन्होंने बिहार में करने कराने का निर्णय करवाया है, तो मैंने उनको धन्यवाद दिया था। और आज एक बार फिर से आप सब लोगों का अभिनंदन करता हूं। और निश्चित रूप से जब ऐसे गणमान्य चिकित्सक, विशिष्ट चिकित्सक किसी भी राज्य में किसी भी स्थान पर एक जगह इकट्ठे होते हैं और 4 दिनों का कोई कन्वेंशन चलता है, तो उसका लाभ तो संपूर्ण रूप से उस डिपार्टमेंट के लोगों को मिलता है, उसके जो फैकल्टी आए होते हैं उनको मिलता है। लेकिन मैं मानता हूं कि जहां भी इस प्रकार के कार्यक्रमों का आयोजन होता है, उससे उस शहर को लाभ होता है, उस राज्य को उसका लाभ होता है, और वहां के लोगों और वहां के चिकित्सकों को उसका जो लाभ होता है, उसके परिणाम देखने को मिलते हैं। चिकित्सकों को भी बहुत सारी जानकारी मिलती है। मुझे अभी मनीष जी बता रहे थे, सुबह 8 बजे से साइंटिफिक सेशन चल रहा है, कल भी चलने वाला है, परसों भी चलने वाला है। और चौथे दिन जो ये कार्यक्रम जिस दिन खत्म होगा, उस दिन आईजीएमएस का जो गैस्ट्रो सर्जरी डिपार्टमेंट है, उस डिपार्टमेंट में केस बेस्ड क्लिनिकल स्टडी वहां पे होगा, और उसके साथ इस पूरे कार्यक्रम का आयोजन का समारोह होगा। तो ये इतने दिनों में जो सब आप सब लोग समेकित रूप से चर्चा करेंगे, उन चर्चाओं का लाभ हमारे चिकित्सकों को होगा, वो भी जानेंगे, समझेंगे, देखेंगे, और निश्चित रूप से उसका लाभ बिहार के आम लोगों को मिलेगा। और जो ये गैस्ट्रो सर्जरी डिपार्टमेंट है, इस गैस्ट्रो सर्जरी डिपार्टमेंट के काम जितने बेहतर होंगे, जितने हमारे चिकित्सक चीजों को देखेंगे, सीखेंगे, तो हमारे संस्थानों का भी विकास होगा। आईजीएमएस ने पिछले कुछ वर्षों में काफी अच्छा काम किया है। और जो गैस्ट्रो इंटेस्टाइनल सर्जरी है, उसका एक विशेष शाखा जो पाचन तंत्र के रूप में होता है, उस पाचन तंत्र के रोग से संबंधित ये सारी जो बीमारियों की चर्चा आप सब लोग करने वाले हैं अगले 3 दिनों में, तो इन चर्चाओं से हम सब चिकित्सक यहाँ कुछ सीखेंगे। और इसमें कई प्रकार की बीमारियां जो मुझे बताई गई हैं, मैं चिकित्सक नहीं हूं डॉक्टर साहब, लेकिन सौभाग्य मुझे मिला है कि बिहार का सबसे लंबे समय का मैं स्वास्थ्य मंत्री जरूर हो गया हूं। इतने समय तक कोई स्वास्थ्य मंत्री नहीं रहा है बिहार में, तो कुछ कुछ आप लोग के साथ रहते रहते मैं सीख गया हूं। इसमें ये जानकारी दी गई है कि 10 एडल्ट यदि हैं, तो उसमें 4 लोग डिफरेंट टाइप के गैस्ट्रो इंटेस्टाइनल बीमारी जो है, इस गैस्ट्रो इंटेस्टाइनल बीमारी से पीड़ित होते हैं। और इसमें गैस्ट्रिक अल्सर, गैस्ट्रो एसोफेजियल रिफ्लक्स डिजीज, हेपेटाइटिस और लीवर से जुड़ी हुई बीमारियां होती है। और हेपेटाइटिस की बीमारी हम सब जानते हैं, हेपेटाइटिस बी, सी, इन सब बीमारियों से हम सब पीड़ित होते हैं, और उन बीमारियों का इलाज आप सब लोग करते हैं। और ये बीमारियां से कम हो, जब ऐसे कार्यक्रम होते हैं, तो लोगों की संवेदनाएं भी जगती है और लोगों के अंदर जागरूकता भी आती है। तो हम बीमारियों से बचाव के भी उपाय सोचते हैं, हम किस प्रकार से ऐसे बीमारियों से बच सके, कैसा अपना रख रखाव रखें, कैसे स्वच्छता रखें, कैसा खान पान रखें, इन सारी चीजों को अपने दैनिक जो दैनंदिनी हम लोगों का होता है, उसको हम यदि बेहतर बनाए तो हम कैसे इन बीमारियों से बच सकते हैं, इन सारी चीजों की भी चर्चा करते हैं। और मुझे इस बात की भी खुशी है बिहार के स्वास्थ्य मंत्री के रूप में कि आज हमारा जो संस्था आईजीआईएमएस है, वो गैस्ट्रो इंटेस्टाइनल सर्जरी विभाग आज पेट और बड़ी आंत, गुदा और यकृत संबंधी जो बड़ी सर्जरी होती है, उस सर्जरी में बहुत अग्रणी काम कर रहा है। और मैं डॉक्टर मनीष मंडल जी को और उनकी पूरी टीम को इसके लिए धन्यवाद भी देना चाहता हूं। बहुत बेहतर तरीके से ये डिपार्टमेंट काम कर रहा है, और उसके कारण बिहार का सम्मान भी बढ़ा है। यहाँ पे एमसीएस की पढ़ाई भी 2018 से शुरू हो गई है, और यहाँ पे 2 लीवर ट्रांसप्लांट भी हुए हैं। एक लीवर को कलकत्ता भेज के हम लोगों ने ट्रांसप्लांट कराया था, क्या हुआ था, लेकिन अनफॉर्चुनेटली उसका एक दिन के बाद डेथ हो गया था। लेकिन हम लिवर ट्रांसप्लांट करें इसके लिए हम सब लोग प्रयासरत हैं। मुझे आज जानकारी मिली है कि कल दिल्ली से मैक्स हॉस्पिटल से, शायद मैक्स से ही आ रहे हैं ना मनीष जी, मैक्स हॉस्पिटल से जो वहाँ के एचओडी हैं लिवर ट्रांसप्लांट को जो देखते हैं वो आ रहे हैं। तो वैसे बड़े चिकित्सक जब बिहार में आएंगे तो निश्चित रूप से इसका लाभ हमको मिलेगा और हमारे चिकित्सक भी इन सारे चीजों से बहुत कुछ सीख पाएंगे। और आजकल तो अब रोबोटिक सर्जरी का जमाना आ गया है, तो इसमें भी किस तरीके से रोबोटिक सर्जरी के माध्यम से हम लोगों का इलाज कर सके, उस दिशा में भी निश्चित रूप से आप अगले 3 दिनों में चर्चा करने वाले हैं। और हम सब लोग भी बहुत गंभीरता से विचार कर रहे हैं सरकार की तरफ से कि हम इस डिपार्टमेंट के अंदर भी कैसे रोबोटिक सर्जरी के काम को आगे बढ़ाएं। तो लगातार इस प्रकार के प्रयास राज्य को आगे बढ़ाते हैं और हर विभाग जो है, डिफरेंट डिपार्टमेंट्स जो है वो इसी तरीके से अलग अलग प्रयास करते हैं, तो संपूर्ण मानव के जो स्वास्थ्य सेवाओं के काम होते हैं वो सभी अच्छे होते जाते हैं, बेहतर होते जाते हैं। यहाँ पे तो ऐसे पूरे देश के चिकित्सक इकट्ठे हुए, लेकिन मैं जो बिहार के हमारे चिकित्सक हैं उनसे मैं विशेष तौर पे आग्रह करूंगा, ऐसे ये एक सुझाव मेरा जो है उस सुझाव को संपूर्ण देश में लागू किया जाए तो बहुत अच्छा होगा। देखिए, कोई बीमारी हो जाए तो इलाज करने के लिए तो आप बैठे हुए और आप इलाज करा देते हैं, मरीज बेहतर हो भी जाता है, उसकी जान भी बच जाती है। लेकिन जैसा मैंने शुरू में कहा कि प्रिवेंशन बहुत जरूरी होता है, कैसे हम अपने को बचाएं बीमारियों से। और इसके लिए जैसे कई डिपार्टमेंट्स हैं जिसमें अलग अलग कुछ डेट होते हैं, जिस स्पेसिफिक डेट को मरीजों को देखा जाता है। तो मैं चूंकि यहाँ पे संपूर्ण रूप से भारत का नेतृत्व करने वाला नेतृत्व और उसके अध्यक्ष यहाँ राव साहब बैठे हुए, तो मेरा आग्रह ये होगा कि कोई एक दिन इस डिपार्टमेंट के सभी डॉक्टर्स निर्णय करें कि देश में कोई एक दिन हम देश के रोगियों को, लोगों को निःशुल्क सुझाव और उपचार देने का काम किया करेंगे। और यदि निःशुल्क सुझाव और उपचार आप एक दिन देंगे तो आप कई लाख लोगों का जान बचा पाएंगे। तो ये मेरा एक एडवाइस है। इस एडवाइस को यदि किसी डेट के साथ आप टैग कर दें तो ये बहुत हिट हो जाएगा, आप ही की तरफ से ये प्रस्ताव आ जाए यदि देश के लिए तो बहुत बढ़िया होगा। और मैं तो ये कहूंगा कि इस अधिवेशन से एक प्रस्ताव पास होकर चला जाएगा तो इस अधिवेशन की सफलता होगी कि यहाँ गैस्ट्रोएंटरोलॉजी के डॉक्टरों ने, गैस्ट्रो सर्जरी के डॉक्टरों ने एक प्रस्ताव पास किया कि महीने के 17 तारीख 22 तारीख किसी भी दिन, मैं दिन भर नहीं करता हूं, कोई 4 घंटे मॉर्निंग या इवनिंग, आप सब लोग बहुत व्यस्त लोग होते हैं, आपके समय का महत्व है उसको भी मैं समझता हूं, तो 3 घंटे का प्रैक्टिस फ्री में करूंगा लोगों के लिए, देश के लिए, और लोगों की बीमारियों से बचाने के लिए उनको अपने सुझाव और टिप्स दूंगा। तो यह आग्रह आप सब लोगों से मैं जरूर करना चाहता हूं। और एक बार फिर से मैं डॉक्टर जीवी राव जी जो हैदराबाद से चल के आप यहाँ आए हैं, मैं आपको धन्यवाद देना चाहता हूं। डॉक्टर रजनीश कुमार सिंह जी को भी, आप लखनऊ से चल के आए हैं, आप सेक्रेटरी हैं। और मुझे पता लगा कि सीएमसी वेलोर के भी डॉक्टर्स यहाँ आए हुए हैं। कल कुछ कार्यों के साथ मैं सीएमसी वेलोर जा रहा हूं। मैं कल सीएमसी वेलोर हॉस्पिटल में ही वहीं के गेस्ट हाउस में रहूंगा भी, और परसों हमारी सीएमसी वेलोर के डायरेक्टर्स और बाकी लोगों के साथ वहां मीटिंग है। तो मेरा भी प्रयास होता है, हालांकि वो दूसरे किसी डिपार्टमेंट का काम है, लेकिन मेरा प्रयास होता है कि देश और देश से बाहर की जो उन्नत संस्थानें, उन्नत तकनीक है, वो टेक्नोलॉजी भी हमारे राज्य में आए। और उन चीजों को, चूंकि आजकल मेडिकल साइंस जो है वो डेली रिसर्च होता है, आप भी जिस डिपार्टमेंट से जुड़े हुए सर्जरी ही करते, आपके पास भी लेटेस्ट इक्विपमेंट्स आते रहते हैं, उसमें नया नया फीचर आते रहता है, फीचर के अनुसार आप कहते हैं कि डेवलप टेक्नोलॉजी के साथ मैं सर्जरी कर रहा हूं। तो लगातार रिसर्च वर्क आज मेडिकल साइंस का एक हिस्सा हो गया है। तो हम भी चाहते हैं कि जो लेटेस्ट होता रहता है उससे बिहार दूर न रहे। बिहार सभी हो रहे लेटेस्ट कार्यों से, जो टेक्नोलॉजी आ रही है, उन सारे चीजों के साथ जुड़ के बिहार भी आगे बढ़े। लेकिन ये बढ़ने का काम तब होता है जब ऐसी संगति मिलती है, जब ऐसे लोग मिलते हैं, देश दुनिया के लोग आके आपस में जब ऐसी चर्चाएं करते हैं, तो बेहतर माहौल बनता है और बेहतर ज्ञान बढ़ता है। आप सब लोग आए, आप सब लोगों ने बिहार में रह के अगले 3 दिनों तक हमारे चिकित्सकों का और अपनी पूरी टीम का ज्ञानवर्धन करेंगे। आप सब लोगों का हृदय से आभार व्यक्त करता हूं और आप लोगों ने मुझे यहाँ आमंत्रित किया, इसके लिए भी धन्यवाद देता हुआ मैं अपनी वाणी को विराम देता हूं। जय हिंद, जय भारत, नमस्कार।
Dhanyavad, sir. Now, we'll begin with the felicitation ceremony. I would like to invite Sir Dr. Manish Mangal to kindly felicitate our Honorable Health Minister, Shri Mangal Pandey, with shawl. Now, I request Dr. C. Khandelwal, Organizing Chairman, to felicitate Dr. G.V. Rao, President IASG. I invite Dr. Saket Kumar, Joint Organizing Secretary, to kindly felicitate Dr. Rajneesh Kumar Singh, Secretary IASG, with shawl and memento. I now request Dr. Sanjay Kumar, Co-Organizing Secretary, to kindly felicitate Dr. C. Khandelwal, Organizing Chairman. Dr. Amarjeet Kumar Raj to felicitate I request Dr. Manish Mangal to kindly propose the vote of thanks for today's event.
Thank you, Ekta. Today's program is coming to an end, and I have to propose vote of thanks. First, I would like to thank the Almighty who has made this program what it is today. Then I want to thank my Chief Minister, Manya Shri Nitish Kumar ji, who has given me all support to arrange this conference, to get this beautiful convention center, which is apt for this scientific program. I want to thank my minister, whom you have just heard, Manya Shri Mangal Pandey ji, who is always keen and on alert mode on any small or big thing happening in world in health sciences and makes it possible that it happens in Bihar. When it comes to IAMS, he has wholeheartedly supported my department. He's gone to the extent of, when I was starting my MCH, I had a lot of problem in that. He made it possible. He went personally to MCI with all officials of health department to say that it is the one of the best institute in Bihar, then why it's not getting an MCH program? I was privileged that he went with me and all the departments to make it happen in Bihar, that all the medical and surgical side of super special department got the degree awarding certificates from there. I want to thank our president, Dr. G.V. Rao sir, who has always picked up my call, and even on minute things, he has always helped me out how to organize, how to do the best. I want to thank Dr. Rajneesh sir, who is a busy person himself at a government center, SGPGI Lucknow, and he has been helping me day in and day out. And from last 10 days, I am almost every day we are in, talking about how to make this program happen at Bihar Patna. I want to thank all the past presidents of IASG. I would like to name few of them: Dr. Piyush sir, Dr. Khandelwal sir, and others who have been here with me today in this August gathering. I want to thank my international faculties, Dr. Sharik Nazir from USA, who has just come right now. Please stand up so that everybody can see that you are here. Dr. Sharik is there with me. He is from USA. He joined late today. Dr. Afzar M, Dr. Lanshot, Dr. Afsara, Dr. Anon, Dr. Vikas Gupta. These are those who have come today, and few are yet to come tomorrow and day after. I want to thank my ex-director, Dr. D.K. Yadav sir, ex-HOD Biochemistry, Dr. Uday Kumar sir, who are with me today from last 2 hours to see that everything is set right in this inaugural program and other programs also. I want to thank Dr. Sanyal, Director, Mahavir Cancer Sansthan, who is always keen to help me out in any program I do, and he is there today. He has made it with his wife. I thank her also to be here with me in this today's program. I want to thank Dr. I.S. Thakur sir, who is the superintendent of PMCH. Any program, I have not seen him, skipping any program of mine. I thank him personally that he always makes it sure that he's there in all my programs. Dr. Ashok Kumar Sinha, who is EC member of ASI and who is the pillar of ASI in Bihar, and thank him, sir. He has come today, and he is always there keenly to see that all the association works are done perfectly and all are united together to do any kind of work of ASI. I want to thank my batchmate, my friend, Dr. Atul Verma of IGIC, who is there with me today since morning, and he has always helped me in whatever program I do at Patna and Bihar. I want to thank my all department colleagues, my all staff members who are here today and who are working with me from last 1 month, day in, day out, to make this program a big success. I want to thank persons from press and media who are there and whom I expect that they will inculcate whatever we have told today and tomorrow and show it in the next 2-3 days to the people that what we are doing and how we can help in their life and make them healthy in this our department. I want to thank all the people who of this Gyan Bhavan who are here and who have been working with me hands in hand to make this program a big success. I want to thank my wife, Mrs. Ritu Ranjan, my son, Adit Mandal, whose emotional support is there with me from last 1 month, where I'm relentlessly working to make this program a big success. I want to thank all the people whose name I have not taken and who have been with me from last few months to make this program a big success. Thank you one and all.
Thank you for your kind words, sir. Now, with this, we come to an end of this program. And now you may proceed for dinner. And that's all. Thank you.
I request all the faculties to come upstairs to have a photo with our minister, sir. I request all faculties to come on stage.
Dinner arrangements are downstairs. Once we are done with the photography, we may proceed for the dinner. पेन कहाँ पेन था यहाँ
Check. Hello, hello, hello. Check. Hey, hey, hey. Check, check, check. Hello, hello, hello.